Hello and welcome to London Live Endoscopy 2024. Great to have you with us, whether it's morning, noon or night, where you're joining us from. We have two superb days ahead of us to discuss all aspects of diagnostic and interventional endoscopy. More than 60 cases to inform expert-led discussion about technique, about advances in endoscopic technology, but all focused on allowing us to deliver excellent endoscopic care. In addition to the cases that we're showing and the discussion that we'll be having, delegates can access industry-specific equipment that we've been using simply by clicking on the industry logo at the bottom of your screen. If you want to know more about the procedures through the Gastro Learning site, you can access the Knowledge Center. You can even go and look at further procedures related to what we're talking about through the on-demand section. There is a chat function allowing delegates to ask questions. You know, there will be lots, I hope, that is explained by the faculty. There'll be lots of other questions that you wish to raise. Please do so. We have 4 symposia over the next couple of days. We're going to start with upper GI endoscopy, then HPB endoscopy, second half of the day, and then tomorrow a superb colonoscopy symposium, followed in the second session tomorrow by an innovation section, great session on the role of AI in endoscopy, but also an interesting session on removal of foreign bodies, something that many of us see in our clinical, urgent clinical practices, and lots of tricks and tips from faculty informed by some very interesting and informative endoscopic cases. So stay with us over the next couple of days, and it's great to have you with us for 2 days of debate, learning and fun. So let's get going, and I'm going to hand over to my colleague and Dave Graham to lead the start of the upper GI session. Good to have you with us.
Good morning, welcome. There is no more important part of the GI tract to start with than, of course, the esophagus and the stomach. And I'm delighted to be joined by 3 colleagues who I've had the pleasure of working with over a few years now, and they're really inspirational in their work in the upper GI tract. So we had my friend Matthew Banks from UCH, Raf Bishops from Leuven, and of course, Roos Powell from Amsterdam Medical Centre. So welcome, guys. This first part is going to be about neoplasia detection and resection. And to put you guys on the spot straight away, what are the key messages? You've got one key message each for people to take home from this section. So let's start with you, Wish. You get to start first. It's the easier bit. Go on. What would you like to learn?
I would say that for successful neoplasia treatment, endoscopic resection is the cornerstone.
Endoscopic resection, brilliant. Okay, go on, Raf.
Stole my thunder. I think the other one was is that I think ESD is the key to push the boundaries for oncologically acceptable endoscopic treatment.
Wow,
especially
okay.
in various
That's a very punchy first statement. This is really pushing the ESD button. Go on, Matt. You can't say resection or ESD now. So.
All the thunder's gone now, so I'll just stick with some light patter rain. I think even before we get to the stage of endoscopic resection, ESD, you have to detect the cancers. So one phrase that David Tate coins all the time is blink diagnosis. So when you're looking at the tissue, when you're doing your Barrett surveillance or your atrophy surveillance, it's very important just to, in the corner of your eye, look for a few key changes. One is color change, anywhere in the esophagus or the stomach, and the other is a subtle change in topography. So slightly depressed, slightly raised, nodule, anything that catches your eye. Blink diagnosis, focus in, and then work out whether you think it's pathologically significant or not.
Ah, well, fantastic. And it's almost like I prepped you for that, because actually the first talk of the day is a very quick lecture on upper GI neoplasia detection. So well done, Matthew. Let's play the first lecture.
Good morning. We wanted to start today by talking about the important issue of lesion detection in the upper GI tract. We know this can be challenging, and unfortunately the data will tell us it can be done poorly. There are significant issues with missed cancers in upper GI endoscopy. Even in the world of Barrett's esophagus, where you should have dedicated lists and dedicated experts, you can see that the missed cancer, that is those diagnosed with cancer within 12 months of their initial clear endoscopy, is significantly high. So whenever we give a talk about this, we like to talk about using your best scope. And here I want to illustrate that. On the left, we have a scope that's about 10 years old. And on the right, we have a scope that is newer, one of the new generation Olympus 1500 scopes. And you can see even in white light endoscopy, you can easily make out the mucosal pattern with the new scope. But when you flick on image enhancement, it becomes even more apparent. And you can see this subtle cancer here at the 6 o'clock position. So choose your best scope. But now let's talk about some pathology, and let's start with Barrett's esophagus. Of course, we don't want to miss the diagnosis of Barrett's esophagus, and we know what the diagnosis is from many of the guidelines. But here I've demonstrated in this video that we can, of course, overdiagnose it to cause ourselves problems, and of course, cause concern for patients. Over-inflation of the esophagus can cause a hiatus hernia to appear like a long segment of Barrett's esophagus. So when you're finding the top of the gastric folds at the esophageal and gastric stomach junction, make sure you don't over-insufflate. Now, of course, we need to find pathology. And importantly, when you're looking for dysplasia, you need to know what normal looks like. And here we have two lovely images of normal mucosal pattern and normal vascular pattern. When we're looking for dysplasia, we're looking for a symmetry of the way the walls move. We're looking for any obvious nodules or ulcers or friability. They, of course, should be considered to be cancer until proven otherwise, and a targeted biopsy should be taken. But we then need to focus then on our mucosal and vascular patterns. And by knowing what normal looks like, we can then start to see abnormal. And you can see these 4 pictures here nicely demonstrate areas of dysplasia. The picture at the top left, you can see some subtle friability and nodularity. On the top right, you can see a beautiful demarcation of normal mucosal pattern, then going into abnormal cancerous mucosal pattern. And here, close-up views on the bottom row, they show you some mucosal and vascular abnormalities more. A way to improve our lesion detection, of course, is to use acetic acid. We know that this increases our sensitivity and specificity for picking up dysplasia. And we know this because the neoplastic areas in the cytoplasm essentially lose their whitening quicker, and therefore you get these lovely areas that lack acetowhitening. The video I'm demonstrating here shows you coming through the esophagus in white light, and you can see there are no obvious lesions at all. We, of course, then flick to enhanced imaging. Again, going back through the esophagus, you can see again, there are no obvious lesions that jump out to us as being clearly dysplastic. So in situations like this, what I'll then do is I'll then use acetic acid and spray the line of the esophagus with acetic acid, 2%. This will then turn the mucosal line in white, and areas that are potentially dysplastic will then lack that acetowhitening. You can see a lovely little demarcated lesion here, which we then took biopsies of, and this showed to be high-grade dysplasia. This second video again highlights this factor. I think we can all see the nodularity at the 1 o'clock position, which of course draws your eye and makes you think there's dysplasia there. But when we sprayed acetic acid, you see that actually those nodules on the top right took up acetic acid and mucosal pattern looks fine. But here at the 7 o'clock position, you can see a very subtle area that actually has an amorphous mucosal pattern and lacks acetowhitening. This area was then eventually resected and was shown to be an intramucosal carcinoma. Now, moving on to the stomach. Again, in order to know how to find dysplasia, we need to know what a normal stomach looks like. Here is the close-up view of a normal stomach, and you can see in the antrum you have that lovely groove-shaped pattern, and in the body of the stomach you should have pits. You need to know these patterns, then know what dysplasia looks like. Most of us are comfortable with the bird's eye view of chronic atrophic gastritis, where we have pallor, loss of folds, and of course visible vessels. So now let's use a few examples. You can see this stomach here. You can see the antrum is certainly pallor. There's certainly visible vessels, and this would tell us there's definitely atrophy in the antrum. And the incisura here. And of course, when we look at this lesser curve, you can see there is a lack of folds there. Moving on to the greater curve, and you can actually clearly see the atrophic border running through the greater curve there. And you can see there's almost a normal strip of stomach, nicely highlighted here. When of course we see atrophy, we then want to then try and focus in on areas of metaplasia, because of course this helps our eye pick up areas of abnormality. This is a very obvious picture of metaplasia, and you can see these are little white elevated plaques that we see. And what you need to know really more is in the body of the stomach. Intestinal metaplasia is relatively easy to pick up. You see little foci of this groove type pattern, this antralization of the body of the stomach. In the antrum, it can be harder, and really the main way to deal with that is put on your image enhancement, and you'll see these elevated color change areas that can either be grey or perhaps sometimes sort of pinky brown. And when you go up close to them using narrowband images, you can see this lovely light blue crest, which is another sign. So again, if we look at some examples, looking at this stomach, we can see there's atrophy, and you can start to flick through here little foci of intestinal metaplasia throughout the lesser curve there, and throughout the curve. And this is relatively obvious, and when we're performing our Sydney biopsies, we want to target these areas. But of course, what we're really wanting to focus on is, can we find dysplasia? And the reason we use metaplasia as a start, because if you're inspecting the whole of the stomach and taking that 6 minutes to look at the whole area, you can then start picking up areas that don't look quite right. And of course, what you're looking for is a loss of mucosal pattern, just like in Barrett's esophagus, irregular friable vessels, depression or elevated lesions. And here you can see a series of images that are very subtle dysplastic lesions found within the stomach. And you need to take your time and look for these areas. These are 2 videos now taken from our department, which hopefully show you the subtlety of gastric dysplasia. I hope both of you can see on both of these videos, there's obviously atrophic gastritis here. Now, if we look at the video on the left, and you can see a couple of clips up here in the upper body, and actually this patient was initially thought to have had a bleed because they were chronically anemic. But actually, as we look in on that white light image, you can see a color change there up by the cardia. And what we'll do is we'll flick on our image enhancement and examine that further. On the video on the right now, you can see that as we look in the stomach, you can see atrophy, and you can see that when we look at the incisura, it looks relatively normal in white light. This will show, both of these videos now will show us the key importance of image enhancement, because now we have image enhancement on both of these videos, and suddenly on the video on the left, you can see a color change, you can see a mucosal pattern problem, and you can see there's a subtle cancer here. And again, on the video on the right, look at that tiny little circle there of ulceration, friability, mucosal pattern change. This again was a subtle cancer found within the stomach. And both these videos really highlight the importance of image enhancement. But the most important thing, of course, is practicing. And there are 2 fantastic online platforms you can use to practice lesion detection in Barrett's esophagus, the Born e-learning project, and in chronic atrophic gastritis, the Kenshi Yao project, where you can practice seeing these lesions. But actually, we believe that there is a better way to do this in the future. And I'd like to introduce you to the first time for the virtual reality DEFT training program. We all want to perform endoscopy to the best of our ability,
But how do we perform with excellence when there's so little exposure to so much pathology? We are really proud to show you DEFT, a platform that is fueled by immersive experiences to allow us to perform like experts. We know that with virtual reality, we learn 4 times faster and we retain that information for longer. So let's have a look at this in action. So here we are in our endoscopy room. It feels pretty much like real life. Let's start by picking up our scope. And we can of course insert the scope into our patient as we normally would. On the esophagus, just like in real life, and we can perform manoeuvres such as our wheels and torque steering. We can clearly see pathology here in front of us, and it's clearly Barrett's esophagus. So we can perform a prior classification by using the measurement panel here. Importantly also, this technology allows us to really learn how to examine Barrett's esophagus properly. And here I'm really exploring the mucosal pit pattern, trying to look for areas of mucosal irregularity that would signify dysplasia. And there, at 6 o'clock, something's just caught my eye. There may well be a little patch here of dysplasia. Just like in real life now, I'm going to switch on my enhanced imaging to get a better view. And hopefully you can clearly see the demarcation line here between normal Barrett's mucosa and abnormal Barrett's mucosal and vascular pattern. In real life, take a targeted biopsy, and this is what I'm going to do here. By getting exposure to technology such as this, we can help learn how to become an expert in areas such as Barrett's surveillance and truly improve our performance. As Matt said a few minutes ago, lesion detection, of course, is the cornerstone, I suppose, before you can even do fancy stuff like resection. So on that topic, Ruth, during that video, you were talking about a couple of things, and I want you just to comment on the differences in scopes, if you could, and what you use in your practice in terms of scopes and how that makes a difference to lesion detection. And then also, I think one thing that people get really confused by are classification systems. There's so many classification systems out there, and everyone's just drowning in them. What do you do? What do you use yourself?
For the classification systems, yeah, I think it's really important to stick to a few classifications. I think it's really relevant to use those classifications, and not only because if you want to refer a patient to a colleague, it's very good if you sort of speak the same language and describe what you see in the same manner. And it also enables you to compare your findings, for example, to previous endoscopies. So you don't only, if you, for example, don't have good photo documentation, it's really helpful if you have classifications. And the classifications I'm referring to, like for Barrett's, I think you should always describe all the Barrett's using the CNM classification to describe the length of the Barrett segment. If you see a visible lesion, of course, you should do good photo documentation, but it also really helps to describe where the lesion is, how big it is, and what type of lesion it is according to the Paris classification. It also sort of forces the endoscopist to look at a lesion in a very structured way. And for describing the lesion itself, of course, we always say you have to look at the vascular pattern and the mucosal pattern, if it's regular or irregular. There is a lot of classifications out there, like the Bing classification is if you're using MBI, or the Blink classification if you're using BLI. Personally, I find it relatively confusing because there's so many out there, and you sort of sometimes have to study what they mean. Yeah. I think the most important thing there is that you look at it in a structured way and see if it's regular or irregular, and if you can demarcate a lesion, and that you describe that. So I would say using the CNM classification and the Paris classification is really important. And then describe in terms of what you see, just describe it. And I don't really necessarily think you should study the Bing or the Blink classification. Yeah. It helps you to look at it in a structured way.
Makes sense. Yeah.
But I think that would be my advice there.
And I think that's really useful. I think that's what people get confused with, the different classification systems. Raf, I guess one thing that people also hear is they hear you have to spend 1 minute per 1 centimeter of Barrett's esophagus stomach. It's 6 minutes in the stomach. And I think a lot of people don't really know what to do in that 1 minute? You know, we just sort of sit there and hope that something's going to sort of jump out at us? And also, what are we looking for? I mean, I think Ruth has beautifully described the different classification systems, but are there sort of gross things that we should really just look for? And what do I do in that 1 minute?
That's a very good point. So obviously not stationary at each level for 1 minute. That doesn't make sense. I think it includes an entire procedure that's quite dynamic. So you start off with cleaning. That in itself already is a very important step, not only to visualize visible lesions and to get rid of all the mucus, but it sometimes can cause also a little bit of oozing from these friable areas. Like if you have a very subtle lesion that you don't see right away, sometimes it becomes more apparent if you start cleaning and it starts oozing a bit. So that's for me the very first important sign to pick up during the inspection, and that's already included in that 1 minute inspection time per centimeter. And obviously after that, you need to do the retrovision to really look nicely at the cardia, where sometimes lesions can be hidden if you just have the forward viewing. And then you do a pull through. Usually you start with white light. And this is also something that's quite dynamic. So you don't stay there 30 seconds at one level. So you go and make sure you see all quadrants. So you keep it centralized. And you also look at the movement of the esophagus. So to see whether there's a disruption and the contractions due to a lesion, especially if the lesions are bigger. This is an important thing to assess resectability. And then finally, after that, we use an image enhancement with the virtual chromendoscopy modes we have, and do another pull through. And in fact, the average bar is about 4 to 5 centimeters max. So if you do all that, it's really not so difficult to spend a minute per centimeter. Maybe for the very long segments, we don't get there, because I don't really, usually they're done by experts, and to then spend 10, 15 minutes in a 15 centimeter barriers, I don't think we get there. But for the average barriers, use 1 minute per centimeter is not so difficult if you adhere to all these steps. And then in the inspection round, you really look for subtle abnormalities. So things that are slightly elevated, slightly depressed. Color change, as Matt pointed out, is very important, especially if you use the virtual chromendoscopy. The dysplastic areas could stand out as a more dark area because there's altered microvasculature. So that's really important. And also, if you use the image enhancement, very often the subtle changes in the relief become more apparent as well. So just take your time. And if there's anything suspicious, you take biopsies before you embark on the Seattle protocol.
Just what I was going to ask. The thing I always get asked is, everyone's told, don't biopsy the colon, don't biopsy the colon. I think that's in everyone's head. So if you see a lesion, you biopsy it.
Yes.
There's no problem in terms of future treatment, EMR, ESD, whatever it may be.
No, and the case we're going to show later actually shows that it's quite important to have some kind of confirmation on what that there at least is dysplasia. So sometimes I think barrels can be quite confusing. Also, you talked about the Blink classification, the Bing classification. I think that the decision to call something irregular is probably more driven by the macroscopic appearance of an area where you see there's something wrong, and then you zoom in and say, oh yeah, this mucosal pattern is not what I'm used to see. But the spectrum of mucosal patterns and vascular patterns in barriers is so diverse. So I'm sometimes very confused if you just look at a spot and then you have to make a decision on a zoom image whether this is totally regular or irregular. So it's a combination of the macroscopic overview. So one important point, maybe, if I may, is like in the referring. So sometimes people call something an ulcer very, very quickly.
Yeah.
So it's not because there's a bit of fiber on top of a lesion that is an ulcerated lesion, because calling something an ulcer basically precludes any endoscopic treatment. And in my experience, the majority of words that call something an ulcerated lesion are in fact not ulcerated, just like eroded. So it's an erosion on top of it. So an ulcer is really something where you can put your biopsy forceps in, right? And that's really an important semantic thing to take into consideration in your report.
Yeah, I think that's really useful. Matt, just coming to you finally, we showed there our VR experience. I know you've had a go on it, but you were part of our initial trial. What were your thoughts on immersive experiences in terms of development?
Well, it was very intuitive and quick to adopt, and I think at the level it's at the moment, I think it's a fantastic learning tool. And I think to add to Roos and Raf's description of how we should approach surveillance, it's really important, if you're not that experienced, to have a really structured approach. And as you alluded to in the lecture, try and structure your eye views. So look for the larger abnormalities, And then to simplify things, then just zoom in and think about pit pattern and vascular pattern. And with all of these classification systems, the outcomes are the same. It's, are they regular or are they irregular? And is there a demarcation line? And over and above that, that's all you need. And I know in Barrett's, the vascular patterns are really quite complex. The only difference with the stomach is you have to adopt a station-based surveillance approach. So you look at the antrum, incisura, lesser curve, greater curve, cardia, all of the hotspots where we know that the miss rate, the pugics. And with VR, you get a great bird's eye view as a beginner in a sense. And then you focus in on the abnormal area, and then you go closer and you have a look for the microscopic changes, the irregular pit pattern or vascular pattern, and any demarcation line. So first experience, really useful. And as an assessment tool, it's even better. So you go through a training you go through a structured training, and then you can assess people quite.
I'm an expert.
Absolutely.
Brilliant, fantastic. Well, look, I think we've definitely nailed lesion detection there. That's sorted. I think everyone will now never miss a lesion again. So we found the lesion. Let's go on to a wonderful resection case brought to us by Roos.
Hi, I'm Roos Pauw, a gastroenterologist from Amsterdam, the Netherlands, and I will present a case on piecemeal endoscopic resection for Barrett neoplasia. It concerns a 68-year-old man who was referred with a Barrett's esophagus without visible lesions, but high-grade dysplasia in random biopsies. Here I perform a pullback in wide-eyed high-resolution endoscopy, and you can see that after cleaning the esophagus properly, there is a visible lesion, type 2A, 2B I would say, and it really extends from 12 to almost 9 o'clock. You see that there's mucosal and vascular irregularity, especially with narrowband imaging. This is very nicely visualized. So it's actually quite extensive neoplastic lesion. The next step is marking the lesion with the tip of the snare to be able to perform a radical endoscopic resection. Here you see the markings in the cardia. And after marking, I've assembled the duet kit on the endoscope, and I always start the resection at the distal end of the esophagus. So this is the first part I will resect. You see that it's not a very big lesion. Probably there is some scarring here, but I've captured some tissue in the rubber band. The snare is then advanced, opened, and I always close the snare underneath the rubber band. So open the snare, push in the sheet, and have the nurse close the snare. I always tick over the snare for the cutting part because I like the tactile feedback when I go through the tissue. And after cutting through the specimen, I place it in the stomach and then continue the resection.
Contrast
the wound,
is advancing,
the
but
markings,
unable to.
and then I target the
guide
second resection. So again, I suck the tissue into the cap. You nicely see the markings in there as well. And then I release another rubber band. And then you have a second pseudo polyp that can be resected. So the snare is advanced, opened, closed underneath the rubber band. And with the endocut mode, cut through the tissue. And then you have two nice adjacent resections. It can happen that you have some minor bleeding. I always treat this immediately because it really can obscure your vision if you have this blood in your endoscopic view. Here I switched to red dichromatic imaging, which sometimes really helps you to identify the bleeding spot. With the use of your cap and the water jet, and then with the tip of your snare, you can really nicely touch up and coagulate the vessel. And usually this is enough to stop minor bleeding. And after this, you can nicely continue with your resection without having all the blood in your endoscopic view. So here you see that I got to the proximal part of the marked area. So I always work from distal to proximal, because if you start at the proximal end, you can have difficulties reaching the tissue in the distal part of the esophagus. because the esophagus can really get crampy after a while. So always start distal and move to proximal. You nicely see the markings within the specimen and the tissue that is captured in the rubber band. Here the snare is again placed underneath the rubber band, and you see that the pieces of tissue are much bigger here than in the distal part, so probably there's less fibrosis here. And this way you can nicely resect bigger pieces of tissue. I put them all in the stomach to be retrieved at the end of the procedure. And here I'm almost finished with the procedure. So again, look at the markings, suck in the tissue until you have nice red out if it's possible. Release the rubber band. And there's a nice pseudo polyp created here. And this video really nicely showed why it's so important to place the snare underneath the rubber band. Here you also see that sometimes can be a little bit challenging because the esophagus gets a little bit crampy due to the procedure. So in this case, the snare is placed around the specimen, but it's difficult to get it all the way around. So I push in the sheet, ask the nurse to close the snare. But what happens if it's not all the way around the specimen, that if you close it, it pops over the rubber band. And you really don't want to cut through the rubber band because there's a lot of resistance and that takes a long time. So if this happens, just take off your snare, reposition it. Again, advance the sheet and close the snare until you're really sure that you're underneath the rubber band and you can safely resect the tissue. So the risk of perforation with this procedure is really, really low. It's about 0.6%. And after you have resected everything, it's important to check if there's no markers left and if you have no residual tissue bridges. This is in the retroflex position. And then I pull back and you see a really nice wound, no residual tissue left. Don't see any markers. So this is an endoscopic radical resection. And after resection, I retrieve all the pieces from the stomach and send them to the pathologist. And in this case, it was a well-differentiated adenocarcinoma, an M3 cancer without lymphovascular invasion, and it was an R0 resection. After 3 months and 4 dilations, it had really nicely healed. There was some Barrett's mucosa left. Because of the relative scarring, I chose APC to ablate the residual Barrett's. And after another 3 months, the esophagus had really nicely healed. There was no Barrett's visible anymore. So I think a really nice result. Thank you very much for watching.
So a really fantastic demonstration of EMR and Barrett's endotherapy there. Couple of things about EMR. So talk us through firstly, what complications do you experience in EMR? How common are they? And I think then the second thing I'd like to comment on is Raf right at the start said that ESD is the most important thing in the world. I don't think he quite said that, but something on those lines. Does the data support that? So complications, and then what's the data around EMR and Barrett's endotherapy? If that's okay.
Yeah, so what we tell our patients, if we consent them for doing EMR, is that it's a really safe procedure. We tell them the risk of perforations is lower than 1%. And if it happens, that usually we see it right away and we can close the defect. So we never experience any really relevant problems due to perforation. And the other thing we encounter is bleeding. But if you look at the different studies and meta-analysis, that risk is also relatively low. It's somewhere below 4%. And of course, we take precautions that if the patients have blood thinning medication, that we stop it around the procedure. And actually, this also, we never see really, really severe bleedings after the EMR. But it's what you tell the patients. And of course, there's a risk of stricture, but that really depends on how extensive we think the resection will be. So if it's just a very small resection, 1 to 2 pieces, we don't tell them about that. But if it's a bit larger, then of course we also discuss that with them. But I think the really
comments on ESD were the most important thing in the world. So what is the data around EMR and Barrett's endoscopy?
I have to say that I really liked Raf's comments that ESD is sort of pushing the boundaries. Yes, and that's because a few years ago we did EMR for the lesions where we could achieve a curative resection, and at that time the curative resections were only said to be possible for the well-differentiated mucosal cancers. But we know that also patients with submucosal invasion or other histological risk factors, that these patients can actually be curatively treated with endoscopic resection, but those are usually the more bulky and uglier lesions that you cannot really adequately treat with the type of resection you just saw in the video. And for those cases, ESD, I think, is a good indication. So I think there's always these lesions where you could do both. Yeah. If one of them is better, I don't think we have the data for that. Yeah. But I think for the flat type lesions, EMR or piecemeal EMR, we have data from a lot of years that it's really safe also in the long run. And we're sort of exploring where ESD fits in. But I think since we're taking more and more patients away from the surgeons, there's more indications for ESD.
100%. And I guess Ruth described the lesions we're taking up by ESD as ugly, and I think that's right. But I guess what lesions are you now, when you see a lesion in Barrett's segment or the esophagus, what are you looking for to say this needs an ESD RAF or this needs an EMR? How do you make that call? In flat lesions certainly, but give us a bit more.
Yeah, first of all, I couldn't agree more with what Rose is saying. And actually, she made us push the boundaries with her study. And that's what I wanted to make. The point is that in the past, it was all about radical resection. And I think this is like a pseudo reason to do ESD, right? Because we know from the large EMR series that having a piecemeal, even of a cancer, does not affect the outcome for mucosal cancer in patients, right? It's just to please the pathologist. And that's not the first goal, is to please the patient. But now, as we are moving, we are looking really for a deep radical resection, which is the key. I think when we want to offer a potential curative treatment to patients that in the past would not have been regarded as being cured by endoscopic treatment, that means deep submucosal lesions, right? And for that, EMR is insufficient. So that's what I meant by that it pushes the boundary. And the problem is we are not very accurate at predicting how deep the lesion goes. So sometimes you can be surprised and say, oh, well, this is a rather small lesion, but it's an SM2, right? But in general, there are some rules of thumb that you can use, also based on the literature. So there is some retrospective data that can guide you there. So first of all, bigger lesions, bigger than 3 centimeters, seem to be an indication that there may be a higher chance of submucosal invasion. Very bulky lesions, so that is also practical because if you really have like a really bulky part on top of a tumor, if you then apply a cap, a duet, or another system, even the classical cap EMR, it will fill up the cap entirely, and then you cut through the lesion, right? So that's not even accurate for a mucosal lesion with a very bulky part. So that's why we always use ESD. And then the more depressed ones that it's a bit subjective, that look more ugly in terms of mucosal and vascular pattern, where you have this demarcation line that we discussed about. If you really see like a larger area which is demarcated, where you have disturbance of the mucosal pattern that's a little bit slightly depressed. So these are the lesions where we move now more and more to ESD, just because of the fact that we offer surveillance for these patients in a preferred trial that Rose is leading. And I think this is really going to change how we approach this. For me, in the past, I would have never said that statement that I used at the beginning of the session. But now for me, the role of ESD in Barrett's has become entirely clear since we are pushing the boundaries, right? Because first of all, we need to get rid of that terminology, non-curative resection, when we talk about resections in Barrett's, because it's not because a lesion is deeper invading in the submucosa that by definition the patient is not cured. So this has a very bad connotation to the patient if you write in your report you had a non-curative resection, while in fact there's a 95% that the patient is entirely cured, right? So, I mean, the surgeon doesn't put in the report it's a non-curative resection because it's a T4 cancer, right? So why should we put that in our reports? So I think that's first some semantics that need to be changed also to communicate well with the patients. So in short, the selection is bulky lesions, larger lesions. I think maybe the one that Rose just showed, maybe you too, we might tend to do more with ESD now, especially because of the nasty part at the top. And then those that really have these depressed areas. And then a fourth one, unfortunately, we see that more and more, is where either there was an attempt for resection or there is previous inflammation. I think there you have some room for ESD, even in case of fibrosis, to facilitate a resection that is impossible with classical EMR.
Fantastic. And I think, Raf, you've alluded to the first study, which I think is really important discussion on what we're going to do. I think we've got a case now that that you brought to us, Raf, which is your ESD, and you've kind of alluded to what it's going to be, which is a refractory case. So we'll put those slides up, but I do want to, before we go on to that, there's a couple of things I want to come back to in the discussion after the ESD case, which is the preferred study, because I think that is just really changing the dynamics of how we treat Barrett's anything, because you've led that. So I'd love to hear the summary of where we are with that at the moment. And then Matt, we talked a bit about stricture, or we've mentioned stricture. They're a bit of a nightmare, or they can be a bit of a nightmare for us to deal with. So I'd love to hear your comments on that. But let's see, have we got the PowerPoint slides for Raf's case? If not, we can go straight to the video. Oh, we're coming up the slides now. Fantastic. So Raf, do you want to go through your slides for us?
Yeah, if they show them, I can. So I think the case in itself is also quite interesting.
Yeah.
Because it's more than just a resection that we're going to show. It's actually a case of a patient with a long segment Barrett's that was refractory to treatment. So you can see here a patient with a very long segment Barrett's, C9 M11, with visible lesions. And we resected that first one with ESD. Because he had two lesions that were close to each other, and we resected that as a whole, as you can see. Next slide. And then obviously we planned. The problem is that after the Halo 360 Express, 3 months later, there was a minimal response. There was a maximum 20% regression. So you can see C6 M11. And we tend now to more quickly then switch to the Ultra 90 in order to hope that this has a better response. We have a couple of cases where having the closer application of the Halo 90 Ultra gives better results, especially after a poor response after the 360. I don't know why that is, but it's just something we learned from practice. So we also switched PPIs to 3 times isomeprazole, pantoprazole further, but still after the other Halo 90, he did not have a good response. So it's a poor responder. So how do you manage this? First question to ask, is there still reflux? So we did a pH impedance, which was perfectly normal. Even there was no a significant non-asset reflux. Next, please. Obviously, you have to wonder at that point, is there still dysplasia or not? So we did a new Seattle protocol, and this did not show any residual dysplasia. Next. So we decided to follow up and perform the endoscopic resection surgery in case of recurrence of dysplasia. So that turned out to be good. So there was no dysplasia on the Seattle protocol biopsies until March 2022. And then, next slide. And then 6 months later, the patient came back, and you can see the subtle lesion here at 6 o'clock, where you can see like a fibrin cap on top of a slight elevated reddish area. And on EMR, on pathology, this was only inflammation. And I almost thought, okay, this patient needs to come. He was normal. So next slide, we said, okay, come back another 6 months. And we did 2 6-month intervals, and you can see that this lesion definitely grew. So my question to you guys is, what would you do with this? The pathology was only inflammation. And actually, the last time on that picture on the right, we took 8 biopsies, and I got back to my expert pathologist and said, please have another look at this, because this lesion looks very dodgy, and I don't trust this. So what do you think about this, Rose?
Yeah, I would definitely take it out.
Okay, so that's what we did. We can move to the video.
I think the mucosal pattern, let's move to the video, guys. The mucosal pattern doesn't look too worrying on that. I think we'd all agree that's a relatively normal mucosal pattern, but the fact that this is, and I think that's the learning point, because we've talked about mucosal pattern, but the fact that this is something that's growing.
Exactly.
that makes you very anxious. Is there hidden dysplasia? Because we know that during RFA you can bury dysplasia potentially. And I think that's what you're sort of getting at. Is there something underneath that top layer?
Exactly. So we were getting anxious. The patients was anxious. The referring physicians were getting anxious.
Yeah, let's refer.
And actually asked the patient if it was okay to show this case during this meeting, and he was very fine with that. That we could transfer the learning points.
I suppose this goes way back to the beginning. Any visible lesions need resection before RFA, and I remember 10, 15 years ago, that was the dogma.
Yeah.
And follows the same route. If it's visible, abnormal.
Yeah, RFA is out of the question, right?
Yeah.
So the question here is then what to do. So you can see the assessment here. The first step always is obviously the demarcation. I think this is very often not shown during lives, but I think in fact it's the most important part because this really determines your plan of action and determines how big your resection is going to be. And ESD, we tend to take larger pieces because we always go outside of the marking. So that's a bit different to the technique that Rose showed, where you usually take the markings along with the EMR, but usually would go like a couple of millimeters outside. So here we're going to go for ESD just because of the previous treatments and the fact that it's a bit of a more bulky lesion in the center, right? But I remember he's had 3 RFA sessions already. Not so much inflammation afterwards, but you can see that the lifting is a bit off. So there you can see that center where it's lifting well, but not like when you do a classical CAP EMR where this comes up. Okay, what we usually did, and this is what I learned in the school from Amsterdam, is to start with the distal resection, so a distal smile. Well, we use the dual knife here, as you can see, and a standard ESD cap. So you open that up, and obviously the trick here is to go deep enough. So you can see nicely here the muscularis mucosae, which is now at the level of the knife, and then opening up to the second layer is the submucosa. And when you start doing ESD in Barrett's, you really need to pass that barrier. Here you can appreciate already nicely the level of fibrosis that we are running into, and this is actually the difficult part in this particular ESD. Okay, so we finished that distal incision, and then we move more proximally to start the circumferential incision there, again with a smiley at the top. And here the incision was a little bit easier in this level. So this is the danger part. So for those who are not so familiar with ESD, this is where I always get a bit anxious when you get to that corner there. That's also where you approach the muscle. So you need to be careful here, not to push in, and you stay a little bit more superficial.
Does your knife selection, what knife are you using here, Raf? And does your knife selection, do you choose a knife according to that danger as you're describing there?
Well, I almost always use a dual knife in Barrett. But there are some new knives coming up, like the new hybrid knife seems maybe something that you can use in case of fibrosis because you can nicely inject through it, because that's obviously one of the challenges. With this dual J knife, you can also do that, but you always need to apply a little bit of coagulation best in order to have a good lifting when you inject through the knife. In this case, we're also injecting with a kind of a jet system, a pump through the knife. And Matt, you were also mentioning just when we were offline the use maybe of a speedboat that is very safe in case of fibrosis, because you can see in a minute that we're getting very close to the muscle layer. And actually there's
layers here.
Here
for non-ESDs, is that a normal view?
No, it's not. Okay. It's not a very comfortable view here, especially you can see that degree of fibrosis, that white tissue that's now in the middle of the screen and going straight down to the muscle, which is that wider structure, which you can see there. So you can see there's actually almost no plane and a lot of fibrosis. So the point here is to go slow. So in this case, we were using precise dissect on the Irby system. And I did this case together with Philippe Leclerc, and was very happy to have his expertise in the room, especially when we ran into this problem. So we kind of
I guess
together.
What are you thinking now?
Yeah,
you're now at the point where, to me as an ESD as well, I'm going, okay, this doesn't like, it's hard for me to see a plane here.
Yeah.
What are you thinking in terms of how do I make this better?
Yeah, the two things to consider here. First of all, is this neoplasia or is this fibrosis? So it's always hard to tell. So we discussed that while we were doing that, and we said, well, like we have all these biopsies that showed no neoplasia, so why would this be a deeply invading cancer? So it's fibrosis, and then at a certain point you need to cut it, right? So you really go a little bit closer to the mucosa and try to stay away, but you also need to be careful not to cut through the specimen, right? So yeah, and you give little bursts. Sometimes you can put the knife back in and just touch it with the tip of the knife to open it up better. But you can see how difficult and challenging this is here at this level, where the fibrosis is really giving us a hard time. And you can see we just go step by step, very carefully, checking what we're doing. So it's just a matter of taking your time. So this definitely took longer than we anticipated first. And we're also underwater here. So there's also something that can help in the tunnel, so that to really help to open it up and get also a better view on the different layers.
So underwater's one tip there, and then I think we're now
your next saline immersion. Saline,
what are you doing here, Raf?
So here we're attaching a string to a clip. So we're preparing a device, and I must say that I've moved more and more quickly now to using a traction device in the esophagus, especially in cases like this. And you can see momentarily how helpful that can be. The point here, obviously, is to make sure that you don't put it on the muscle, right? So you grab it only, and then before you deploy the clip, you lift it a little bit, and you see how the mobility is, and then you make sure that you're not stuck too deep.
And describe to us, so you put that on the clip. So this is happening at the other end of that string.
Well, you can pull it to different sides. If it's not working on one side, you can just change it to the right side in the patient. You can pull it a little bit, and you can see nicely now how this fibrotic area becomes much clearer just by pulling on that. So this was the area where we were struggling, and at least now you're a little bit reassured. You still need to inject again with a little bit of blue, because the problem, obviously, when you start pulling on a fibrotic structure is that you also pull up the muscle, right? So and you can even theoretically inject in the muscle, then it still looks blue, right? So the blue is not always 100% safe. So here we're struggling still, so that part remains difficult, but at least we manage now to get a better access. But you need to be careful. So what's that? We're in the middle, so make sure you don't pull the muscle up too high. And then we identify the plane again and slowly, carefully dissect that further. Here we're still in that fibrotic area, Matt. But finally, again, the magnification of the saline immersion technique here helps. So you need saline, otherwise you have no conductance for the current, right? So you cannot do this with classical water. But in the tunnel, in the cap, it can help you also to get a better view. And even with the flushing, you can actually get a better view on the level where you need to dissect.
And I think this is a really good point, actually. When you have fibrosis, and particularly where there's no submucosal plane at all, you've got a few decisions here. You either stop because of the risk of perforation, and also the risk of bleeding, because you have very little area in which you can coagulate without going deep into the muscle planes. Use underwater ESD, where the dissipation of current goes out into the saline rather than deep into the muscle, using precise resect or some current like that, because using cut probably won't work underwater particularly well. Ensuring access, and you've already got a conical cap on, and using retraction techniques or tunneled pocket type techniques where you always have access. You don't need to worry about lifting the tissue. Or using dry ESD, classical ESD, but using a very, very low cut, and just using a non-touch spark technique where you just take away fiber by fiber. And as long as you haven't got 360 of fibrosis, it's certainly possible to complete where you've got a limited area of fibrosis like that. But this is a very elegant demonstration of how to tackle fibrosis.
And your experience of traction techniques and this sort of thing, are you jumping earlier into traction? Do you use the same string and clip, or what's your experience?
Yeah, so we use a lot of traction as well, and you always, if you use it, you will think, oh, I did it, I should have done this earlier.
Yes.
So we moved from using a string to a snare, because it's a bit stiffer, and it you can also push a little
it,
bit,
yeah.
or you can
And
open the
pull it
snare
over you,
and
yeah. Snare's
and
lovely.
open and take a bit more tissue. So yeah.
There you go with the bleeding. So there was some small bleeding at the end.
Yeah, I was
so
going to ask for that. So I guess, I mean, thankfully, we're seeing the huge exploding vessels here that we have to talk about. But how do you tackle bleeding during ESD? What are the different?
Well, usually you can do this with the tip of the knife, but here because of the fact we already had this fibrosis, we changed here to the coil grasper, because also because it's you're afraid in the fibrotic area that you leave if you use your forced coagulation.
Yeah.
And the advantage of the coil grasper in this case is that you can, well, really precisely apply a current and then lift it a little bit. And even here also underwater, it's very safe to do that. Well, the bottom line here is this lesion was entirely benign. It was only inflammation. So coming back to having a confirmation of your pathology when you're treating Barrett's is really important. But I think in the end, we all agree that the lesion looked very suspicious. And we did have cases before where that was foveolar dysplasia, which was still benign, but it was like growing more into the deep and that's what made us decide to resect this. But in the end, well, it was just a benign lesion, but fortunately, it went without any incidents. Yeah.
And as you just mentioned there, you said snare technique, and then Matt said, "Yeah, I love that one." But a lot of people won't know what the hell you're talking about. So what do you do with the snare? Describe what you're doing for attraction.
So actually, I do the same as Raf did. So you saw the clip through the endoscope, and then we use a flexible snare, the one that we used to use for the cap resections with the Olympus kit. So it's quite nice and thin snare. We put it around one of the edges of the clip, and then introduce it, clip the snare to the specimen. But the good thing is that you can open the snare as well, and if you want, you can put it around the specimen. Also, when your ESD has proceeded and you have a bigger piece that is loose, you can sort of reposition it. And it's because it's a little bit stiffer, you can not only pull, but you can also push if you want to.
It just creates that access.
Yeah.
And they go both through the working channel?
No, so the snare goes alongside the endoscope, like the string would.
Yeah.
And the clip goes through the endoscope, and of course, once you've released it, you have a free working.
It's the same way as this,
yeah. And it's actually quite helpful.
I know you're about to go and do a workshop case, but so I'm going to come back to the preferred stage in a second. I want you to talk about, before you leave us temporarily, about stricture management. So, because strictures can be really challenging. What do you do to try and prevent them from happening? I don't want to let's go down the line here of what we're doing when they've got a stricture. Is there anything we can do to stop them from happening effectively?
Predicting who's most likely to stricture. So those with squamous neoplasia more likely, 360-degree resections, and the length of resection. So the more you take out, the higher the rate of stricture. But it seems to be really unpredictable. Some patients you expect an awful stricture and they come back without any dysphagia at all. Others end up with quite long, complex strictures. You've got to be wary of those who've had radiotherapy in the past as well. They have awful strictures. So how do you prevent them? Well, the little data we have, oral steroids, although there are a few complications with those, we've adopted the submucosal triamcinolone injections, where you dilute the triamcinolone and you inject all the way through into the submucosa. And certainly there's data to suggest that the stricture rate declines by about 70% in those patients with the limited data we have. And oral topical steroids like budesonide, Jorveza, for example, we started using honey mixed with budesonide respials. And the limited anecdotal data we have is perhaps the stricture rate is lower. Yeah. And I'm hoping, with some of the new knives, like using microwave technology, that because the thermal damage may be reduced, you get less stricture formation. But I think the other point to make is we certainly have we have more strictures with ESD than we are. And that's something that we need to be very clear with. This may be a complete resection R0 with low recurrence rate, but the cost would be a higher stricture rate. Possibly.
So Matt, I'll let you go next door. And whilst you're moving next door, I've teased it long enough. So prefer study, tell us, please. How is it going?
Yeah, it's good. So the prefer study is a study we initiated in 2017. And by now it's an international multi-center study in 18 centers around Europe and Australia. And what we do in the study, so we used to think that patients who had submucosal invasion or poor differentiation or lymphovascular invasion, that these patients had a really high risk of lymph node metastasis. So up to a few years ago, all these patients were referred to for surgery, even after a radical resection of the lesion. Because we and the surgeons thought the risk of lymph node metastasis was like somewhere up to 46%. Yes. So these patients needed surgery. But that was sort of what we did for these patients before we had EMR and now ESD that really enabled us to remove even bigger lesions in one piece. And in the past years, we had more and more lithotripically treated patients. And from that literature, we found that the risk of lymph node metastasis is actually much lower than we previously thought based on the surgical literature. We thought probably somewhere more up to 16%, but not as high as 46%. Yeah. So most of these patients were operated like in vain for nothing, and surgery is really, really invasive. So what the protocol entails is that after EMR or ESD for a lesion with submucosal invasion or other histological risk factors, that we do baseline restaging. So they get a CT or PET-CT and EUS and gastroscopy to make sure there's no residual cancer and no lymph node metastasis or distant metastasis. And if it's N0, M0, we can send the patients for strict endoscopic follow-up instead of referring them for surgery. Yeah. So we see them very regularly, every 3 months for gastroscopy and EUS in the first 2 years, and then every 6 months. We do a CT scan after a year. And the idea is that if the patients develop local recurrence or lymph node metastasis, that we can still treat them in a curative stage with chemoradiotherapy and or surgery. And so far, so the study has included almost 200 patients now, because the 141 for the study we have, but we continued as a registry. And the risk of lymph node metastasis really appears to be relatively low. It's somewhere around 6%. And most of these patients indeed could still be curatively treated. We had some patients who had local recurrence, also around 6%, that we could not treat endoscopically anymore. And they had surgery or chemoradiotherapy. And we had 1% of cases who presented with distant metastasis. Yes. But the interesting thing is that those patients didn't have any local regional lymph nodes or local disease. So the question is, would we have saved them or cured them with invasive surgery? And I think that's a bit that it took me a while to figure that out myself when with part of the study was actually, you could have done an esophagectomy on those patients, but their MET was, somewhere miles away. So actually, would that have ever made a difference? And I think that's the key message, isn't it? Yeah. Is that you're saving someone a ginormous surgery, potentially. And 6% still sounds high, but actually flip it the other way, 94% chance, you're totally fine. And these aren't, generally speaking, 20 or 30-year-old people that are having these procedures. So, and I think now we reserve the more invasive treatment for the patients who really need it. Yeah. And the patients are really on board as well, because they say if we offer them the chance not to have surgery, in our experience, they all are very much in favor of that. Yeah. I mean, it's a really amazing study. I think, you're really leading in pushing the boundaries of endoscopic therapy for Barrett's neoplasia. It's a really wonderful work, so well done. And on that note, we're going to hand over to Matt and Adolfo in the workshop to talk to us about a new device that's sort of been used in the upper GI tract. So,
thank you, David. Could I introduce Adolfo Parablanco, colleague of mine? We go back many, many years. And we're going to present a case of an antral dysplastic lesion, which was resected with a speedboat knife, which is reasonably new technology, using microwave diathermy. But the design of the knife, we'll talk about in a little while, is unique. There's an insulated plate at the bottom. There's a cutting plane, which I'll describe, as well as a microwave in the tip. So this was the lesion. It's already been demarcated. And there's the speedboat itself, because it looks like a speedboat. and same technique as any other ESD. So you demarcate, which has already been achieved. With this lesion, it was very small and simple, circumferential incision. And the cutting edge you can see is with the knife, and it rotates in the scope. This is a slightly smaller prototype than the original knife that was designed for colorectal work. This has now been patented for upper GI work. Very, very safe because of the insulated tip. I'm going to talk no more and let Adolfo take over and talk more about what you can see. You're slightly disadvantaged. You haven't seen this case before, but you can comment on how good or poor the technique was and how we can improve. This case took, I think, probably less than 20 minutes with the knife. So, Adolfo, from your experience, you started doing upper GI cases before me with this knife. I've just really adopted it and changed from all the other knives that I've used, but I found it very safe, quick, and quite intuitive to use. What's your experience?
Yes, thank you, Matt. So yeah, we use this device mainly for esophagus cases, though the first case I did with the previous version with the 3.2 device was in the stomach for a large 6 centimeter low-grade dysplasia lesion. And what I like of the device is that I feel it's quite safe because of the bipolar energy it delivers instead of monopolar. In fact, it's the only device in the West for ESD which uses bipolar energy, which possibly leads to a lesser degree of injury of the deeper planes, mainly the muscle layer. Something I like is the microwave. You can see how, without having to change the device, you can apply the microwave. You can do it on both sides of the vessel and then in the center of the vessel. The case, I think it's very, very nice. It looks safe. I think you told me it was done by a training ESD, and it's going very, very smooth. The fact that you can inject with this water jet channel design makes speedy, and the backhand side of the device has a stainless steel hull, so which is protected against burning the deeper layer. So how long did it take?
Well, I didn't leave my chair. This is all done by Omar Ahmed, one of my colleagues who's learning ESD. It's a reasonably simple procedure, but I don't want to take away from him. He needed no hands-on assistance with this at all. And as you can see, there's virtually no charring. The plane is preserved throughout the submucosal plane. As you say, it's bipolar, so even the cutting, the propagation of energy away from the knife is very limited. It's very easy to rotate because you use the edge of the cutting knife to cut. The wave is really in the tip, so it's very easy to touch a vessel. You don't need to change the device. But what really impresses me is if you have a look at the plane here, it's almost as though it hasn't been touched by any diathermy. And I hope that, for example, particularly in the esophagus, did a circumferential large incision a couple of weeks ago, and there was absolutely no charring. And I hope that the rate of stricturing might be lower. And that's certainly something we need to you're looking at to understand.
That's important because, of course, in gastric lesions in the antrum, the wall is thicker and a bit less concerned about muscle injury. But in the esophagus, something you really don't want to make is a post ESD injury or a perforation. And it feels very, very safe. This device, I think, it naturally brings you to the deeper submucosa because of its design. You don't need, you can just put the backhand side of the device on the muscle and laterally move it and slide it. So yeah, I feel quite comfortable with it.
So perhaps with the pathological specimen, we may get a more precise diagnosis in terms of SM1 or SM2 invasion, which will help advise the patient in terms of risk of recurrence. So that's all from us. Back over to David.
Fantastic case. Now we're going to put you on the spot. We've got 3 cases. I think we all find knowing what lesions to resect by ASD challenging. So you're each going to get 1 case. You're going to describe the lesion you see, and you're going to tell us if you would or wouldn't ASD it. Okay. So the first case has a little bit of audio to start with, and it's going to go quiet. And then when it goes quiet, Bruce, you're on the spot to describe what we're seeing. So let's play the first. Lesion, if that's okay, guys. So I'm using the Pentax I20 scope paired with the new Inspira 4K processor to do this Barrett surveillance. And you can see a few things about this scope I want to show you. So the mucosal enhancement, really impressive. You can see really obvious groove-type patterns here, really obvious vasculature. This is non-dysplastic Barrett's esophagus, and you can see really obviously the grooves here. If we look here, this is not flicking into iScan 3, which is enhanced imaging. Again, really, really impressive views, very much brighter than the old generation OE iScan scopes. And you can see really obvious non-dysplastic Barrett's in the 6 o'clock position. The other thing to know about these new I20 scopes is they've been much more ergonomically designed. So the handle itself is much lighter. You have much better access to the wheels. So actually you can perform therapies with much more ease. And the other thing to note is it's very flexible. So it used to have a bend of 210. That's now even more flexible. And what it allows you to do is get into positions that you previously would have struggled to get into. And look, I'm now retroflexing right into this gastroesophageal junction here with absolute ease. And I can get really good views of the whole of the junction to check if there's any dysplastic Barrett's there. But what I want to show you now is we come back into the Barrett segment, up back here. I'm sure many people would have spotted it in the 12 o'clock position. The concerning area here for display. What are you seeing?
Yeah, so I see an abnormal lesion. I think it would extend from 8 to 3 o'clock. So just a bit more than 50%.
So I'm using the I20 scope paired with the new.
It's, I would say, type 2A to B lesion. It's
so
not too bulky.
We come back into the Barrett segment.
I also look at the peristalsis of the esophagus, which I think is there. Sometimes you see these very bulky lesions that don't move much. But what I saw here, I think that was relatively spared. But in the center, it's a bit more depressed. If I look at it now. And this would definitely be a case where I would be worried for some submucosal invasion. So I think maybe like 5 years ago, we would have done a piecemeal EMR, but with the experience we have now and the knowledge that even if it's a submucosal cancer with high-risk features, that we would still probably follow this patient endoscopically and not refer them for surgery. So you want to have it out really as good as you can, then I would go for an ESD. I think looking at these pictures now, mostly the center would worry me.
Yeah, and so I should say, all of these patients that you're going to see, CT scans are normal, PET scans are normal. So that's the question we asked is, would you ESD it? So you would ESD it?
I would do an ESD.
There you go.
Yes.
Okay,
Yes.
great. So Raf, now your turn. On the spot, Raf, describe what you're seeing.
Well, this is a type 1S lesion, which is located at 12 o'clock. So I think nobody will miss this lesion. I'm not sure if you're going to add some virtual chromodoscopy to that. I think the problem with these lesions is that there is indeed a high risk of submucosal invasion. You can see also the friability I was referring to first. So this is something you can also see in flat lesions. So this is an ominous sign for neoplasia. And I think the problem here is if you would embark on this with is this included in the lesion?
Yeah.
So we're not done yet. Okay, let's stay. So here you can see again with the virtual chromodoscopy the disturbed pitch pattern, right, in the center where it's also bleeding. So it's very irregular there. So are we at the GI here?
That's the GI junction.
Okay. So this is definitely a lesion that we would first stage fully because of the extent of the lesion. the fact that it's more bulky to make sure there's no lymph nodes, suspected lymph nodes, and a PET CT. I think that's very important to emphasize. And then again, looking at the mobility in the beginning of the wall, it looked that was still there, so that's okay, and we would definitely take it out with ESD. There's no room for EMR here anymore.
No, definitely not. No. Okay, fantastic. We've got 2 for 2 ESD. Let's go to the third one. Matt, you're on the spot now, Matt, for the third lesion. Play the third lesion, please, guys. There we go.
Oh, this looks very similar to the other one.
It's not.
So again, 6 o'clock lesion, Paris, 1S. Again, very bulky, obvious lesion. I'm really looking now at wall movement, peristalsis, because I think with these larger lesions, it's key. When you have a rigid, fixed wall, the likelihood of infiltration is much higher. And this looks like it moves okay. There's a slightly depressed area in the center, but that's part of the bulky area. Pretty borderline, certainly not EMR. And it's probably about 25-30% of the circumference. So I think this deserves an attempt at ESD.
Yeah, and I think the reason I've shown those 3 videos, actually, as you know, Matt, although you've cheated slightly because you know we did ESD that one.
Did I?
So, yeah, we did, yeah. Although you have no memory, so brilliant, a brilliant highlight into your life there.
Oh, so many.
I think what that sort of highlights is all 3 of those lesions, all 3 of those lesions would definitely not have come to endoscopists, a few years ago.
I was about to say that, David. Yeah.
Your one had that little depression in the middle. Okay, that's not me. Yours is both of yours are big, bulky lesion. That's never going to be
straight to surgery.
Yet, actually, now we're changing the complete dynamic here, thanks to the first study where we're sort of saying, actually, this can be given a chance, and then we'll discuss them afterwards. With the staging, as you said, ESD is the most important thing. Well, that is exactly why, because we can stage them accurately, and suddenly give patients a informed decision about what they're going to do long term. I think that's really valuable.
Yeah, and I think EUS would not. So we stopped doing EUS because we know that it's often false positive for T2 cancers, and then you do the ESD, and it's actually just a submucosal cancer, and you can remove it radically. So really, don't do ESD.
Yeah, and I think we get asked a lot. What's the EUS for these lesions? We never bother. You can use it for lymph nodes, as you said. And I've heard you teach before about. So you always say, if you look for lymph nodes, maybe.
And even an argument more for doing ESD is that, even though it looks very nasty, the lesion, I'm not talking about your lesion, but the ones that we saw, sometimes you still only have high-grade dysplasia and bulky lesions. So it's so hard to predict and Barrett's prior to the resection what the final histology will be. And you have these features that raise the risk for submucosal invasion, but it's not absolute. So and that's why having a proper resection is really key, and then to have a real radical deep resection, which is the key issue there.
It's the depressed lesions where we find they're always infiltrated, and sometimes then we even just, if we're not quite sure, we'll sometimes just see if they lift at all. Just before we do an ESD or bring them back to do an ESD. But sometimes those bulky lesions are surprising. They come back as high grade or intramucosal.
Yeah.
So we've talked about resection. We know that once we've removed that acute cancer, so to speak, you then have to talk about long term, and that's where ablation therapies, particularly radiofrequency ablation, has so much data to show us that they would massively reduce the risk of recurrence and give you those long-term outcomes that are fantastic. And of course, we know there's a huge amount of data around radiofrequency ablation, but there are other ablative therapies that we hear and often asked about in our teaching. So we've got a case now that has been done by my colleague Vinay Sehgal of cryo ablation. So handing over to Vinay.
Thank you, David and the team. So what I'm going to use the next few minutes is to demonstrate a case of us using the C2 cryoballoon ablation system designed by Pentax for the treatment of Barrett's esophagus containing dysplasia. So essentially the system is through the scope balloon system. So it's a 3 centimeter compliant balloon which houses a diffuser which sprays liquid nitrogen at -80 degrees, and you can actually visualize real time as you're treating your Barrett's segment through the balloon. So that's one of the big differences between RFA and cryoablation, is that you can actually see the treatment as you're delivering it real time. There's now been sort of a lot of real world evidence to show that this is a very effective and safe intervention, particularly when compared to RFA, and the durability so far seems to be effective. So there's also data to show that patients experience less pain and less dysphagia, which is often underreported in patients that are treated with RFA. So if we can just play the video so I can see it on my screen. I think that the primary steps whenever you perform an ablation in patients with Barrett's is to do a detailed endoscopy inspection to ensure that there is no visible lesion, which you've heard about this morning, because you need to have a low threshold to perform a resection in these patients. Once you're very confident that there is no visible dysplasia left in situ, you will then perform your ablation to really ensure that there is reducing the risk of recurrence, which we think is about 30% for all comers in patients that are not treated with ablation. So in the video, you should be able to see here the diffuser really being rotated both in a forward and backward manner. So here we go. So here's the balloon now. So I can see the video here. So this is the balloon. So it's a 3 centimeter compliant balloon, which I've inflated now, and I've brought back into my scope. So what you're seeing in front of me now is the diffuser in the center, and it has cylindrical dots on the catheter itself to define which direction with which the cryogen will be firing. So you can see at the moment it's firing in the 1 to 2 o'clock position. Now what I'm going to do, I have a very stable balloon position. I'm very comfortable with what I can see. I'm rotating the diffuser in a clockwise manner, and that's controlled by a foot pedal. So the foot pedal allows me to move the diffuser forward and backwards and clockwise and anti-clockwise. And I've rotated it now to the 4 to 5 o'clock position, which we're now treating. And the dosimetry that we use here is 8 seconds, based upon data from the Euro cold plate study, which was a multi-center study performed across multiple European sites. And what's really nice about this, you can see there's a little bit of a zone that I haven't covered in between. And I've just been able to easily rotate back in between and treat in 3 o'clock position. So we're gonna carry on with this and rotate diffuser all the way around so we cover the circumference. So if we keep moving around here, and you want to get a little bit of overlap in a very similar fashion to RFA, but clearly not too much overlap, whereby the stricture rate will therefore become a little bit more significant. So we quote a stricture rate of between 10 to 12% for this procedure. This current treatment has covered a very large surface area, probably 30% of the circumference. And what I'm going to do next is now bring the diffuser closer towards me using the forward and backwards pedal and continue to treat all visible Barrett's. And that's usually the intention when you do your first treatment session with cryoablation. So the procedure itself shouldn't take any more than 5 minutes. You are very much, and one of the other benefits I find really helpful is that you have one intubation and extubation. So there's no need to take the scope back out of the patient, mount your over the scope catheter or electrode and go back down. So it's a lot more comfortable and streamlined for patients, provided you get a stable balloon position. So we've ongoing to perform cases in patients and have set up a registry across multiple sites across the UK, where we'll be able to collect real-world data on this. And you can finally see this purple dusky effect of your after treatment. And that's really what you want to look for. Thank you.
Brilliant. Fantastic case, Vinay. Thank you so much for sharing that. So look, we've come to the end of the this neoplasia detection and resection and now ablation section. I want to just get key take-home messages. So you got to start last time, so I'm afraid you get to finish. So Matt, you can have the first key take-home message, please.
The key is detection.
Brilliant.
There we go. Bird's eye, microscopic. Always be aware, and systematic review of the esophagus and stomach, station-based.
Thank you very much. Raf, take-home message, please.
Yeah, please adequate reporting on referral. So we didn't touch upon that, but you talked about classification. So use the right classification, really crucial. So even if you don't treat the lesions yourself, making a good report with photo documentation can really help to speed up the treatment of patients and avoid unnecessary additional procedures.
Fantastic. And finally, I hope they haven't stolen your thunder as we had earlier. Let's go.
No, I'll just say that I think we very nicely showed you that we can do more and more endoscopically. And the key is to know what technique you use for what indication. And I think also that it's important that even if you have high risk, we can still offer them endoscopic curative treatment. I think I would like to add, because I was studying the outcomes, but I think it's important to notice that this should be done in expert centers who can really follow these patients adequately.
Yeah, I think that is
so
important.
Know when to refer your patients.
I think that's really important message. It isn't something they want to take on, because, you know, as you said, we have so much support behind, you know, this hospital. I'm sure at the AMC as well, you know, we have specialist nurses, we have all the imaging modalities, we have everything to support these patients don't get lost or they get the right treatment choice. But I think it's really exciting times as endoscopists, and actually we are doing more and more, not just in cancer resection, but in other bits we're going to see this morning. So we're going to take a 30-second break now, just whilst we change over faculty. Matthew and Raf, you're coming back later, so I'm not going to say goodbye properly, but so you get a little rest. Ruth, I'm afraid you get no rest at all, so you're staying with us. But thank you so much to everyone, and we'll go on to the next section.
Thank you, David.
Thank you. Cool. Nice. Well done. Thank you.
Hi there, Philip Chu. Please can I ask you to turn on your camera and microphone? Hi there, Philip. Can you hear me? Please can you turn on your camera and microphone?
Can you see me? Android. Can you see? Yeah. Okay. I have sent the presentation video to you, so I suppose you can.
Welcome back, everyone. And we've now moved on to the next section. We've covered resection and detection in the esophagus and the stomach. And now we're going to move into a bit that not many of us are that confident with, I think. But thankfully, I've got an amazing faculty to help me through. So in the chairs now, we have Pradeep Bandari from Portsmouth, who is well known to be, really pushing the boundaries in terms of interventional endoscopy. John Morris, similarly from Glasgow, welcome. Thank you so much for joining us. And Ruth hasn't left. And then Ruth from Amsterdam, I should have in some case. I think I'm just ignoring you there. So it's Ruth Powell from Amsterdam. And then, of course, joining us on the links is Philip Chu from Hong Kong.
Thank you very much. Nice to meet you again.
Yeah, thank you. Thank you so much for coming to join us. And we're going to start straight, if that's okay. So Philip has sent us a really amazing case of a duodenal lesion. So Philip, without further ado, we'll just go straight into your case, and we've got plenty of time afterwards to discuss that.
Please.
Today, I'm happy to share with you duodenal endoscopic submucosal dissection, challenges and ways to tackle. What we usually know for duodenal epithelial tumors is that it is not common in the prevalence of 0.03 to 0.4% upon OGD. The classification will include duodenal epithelial tumors or ampullary or periampullary tumors. And today, we are focusing on endoscopic resection for superficial non-ampullary ones. And the previous reports, including the technique of using EMR, underwater EMR, and ESD. I trust that the challenges with duodenal ESD include the difficulty in maintaining stability of endoscopy in duodenum, as we usually use a side-viewing endoscope for the performance of ERCP. And secondly, there's a lack of traction, and also the very thin duodenal wall, including, as shown in this histology slide, that the submucosa is probably more thick as compared to the muscularis. There are challenges in post-duodenal ESD complication, including bleeding, perforation during or after the procedure. To avoid complication of duodenal ESD, I trust that there are several techniques that are emerging which will enhance the performance of duodenal ESD, including the underwater principle, with good exposure to the submucosa using normal saline for water flush and dissecting in the middle part of the submucosal plane, usually for me, to avoid ischemia or delay. Secondly, we need to completely close the luminal defect. And thirdly, we can consider temporary pancreatidobiliary diversion to reduce the effect of digestive enzyme on ESD defect. And here, I'm going to show you a case of underwater duodenal ESD with a complete closure of the defect. So as you can see, this lesion is located over the second part of the duodenum, and it's around 25 mm to 30 mm in size. So usually for any duodenal superficial non-ampullary epithelial tumor, they have a very distinct border. So when we are making a diagnosis, we can actually use the image guide enhanced endoscopy to ensure we have an adequate resection margin, as we can see here. And after an initial mucosal incision, then I started to do a underwater exposure, because usually the mucosa of the duodenum is quite tight. So if you want to look at the submucosal plane clearly, sometimes it's very difficult because they are keeping the mucosa quite closely approximate together. So one of the ways to do is, in fact, to do an underwater exposure. And then you can see that now under the normal saline injection, we can see more clearly at the submucosal plane. And as I mentioned before, the muscularis layer is really, really thin, and you have to be very careful. And secondly, during the procedure, because in the duodenum, it's actually very vascular, and you expect to encounter bleeding from the submucosal vessel. And this arterial can usually be effectively controlled by the use of a tip of the ESD device and also remote. But if it's too much of the bleeding, you can, of course, use a coagulator. So during the dissection, I'm now using the gel knife and with the injectable function. And I think repeated injection is so important. And as you can see now, I'm dissecting over the submucosa. I would focus to leave, I think, the 1/3 of the submucosal tissue, so that to allow a coverage of the muscularis layer. And firstly, and secondly, hopefully they will also leave a submucosal vascular plexus. And that's one of the challenges, because I have truly encountered one case of a delayed perforation where when I finished the duodenal ESD, the plane was so nice, but then afterwards, I trust that it could be related to the vascular during the process because I stayed too close to the muscularis layer where I cut most of the submucosal vasculature, and that ends up in an ischemic perforation. So now you can see that we have a good exposure, especially during the process of underwater ESD. So very important, as we can know from the chemistry, that normal saline have a better conduction of electropottery as compared to just water alone. We will use normal saline for a conduct medium and also to enhance the submucosal exposure here. So now we are progressing and dissecting the submucosa, but at the same time, we have to be careful that we need to have a good margin, both from the oral side and also from the anal side. So as you can see here, very importantly, we have been able to expose the submucosa. So now we have almost completed the submucosal dissection, and then we have to judge at the margin of this ESD lesion, and we have to continue the dissection. As I mentioned before, so there's a very rich vasculature in the duodenum. And of course, we understand of duodenal ulcer bleeding. And finally, I will complete the dissection using the IT nano knife. And I trust that this is quite useful because during this procedure, at the end, we cannot 100% anal side margin. So the knife actually helps us to locate and identify the margin and ensure that we have a good resection margin. And this is the final part. Be prepared for the device of retrieval of this specimen. And I usually would use a suction to pull the specimen into the stomach before I retrieve. So this is the final part of the end of the dissection. And then afterwards, I need to achieve a good, complete closure of the luminal defect. And this is a new clip, the dual action clip. And I think this is a very useful device because we can actually anal side luminal defect to the oral side. And using this dual action clip, we can pull the tissue together and then close. The downside of this clip is that we need a larger channel endoscope. So we need a double channel endoscope. So we need to change the endoscope. And secondly, the manipulation will then be limited because of the larger diameter of the scope. But then you can see that we have a pretty good confidence of closing the defect using this dual action clip. And I think this is especially useful in closing the defect in the duodenum. And I trust that for all the ESD procedure within the GI tract, duodenal ESD is required mostly to completely close the defect. So I trust that there are many methods, but then the use of this dual action clip is quite effective. So after that, we would add on a few more clips in between to completely close and ensure the complete close of the defect. So here you can see that the defect is completely closed by all these clips. This is the specimen we have checked and with a good lateral border and resection margin. So when we look into the outcome of duodenal endoscopic resection, this is one of the report on the digestive endoscopy open. And you can see from the experience of using duodenal EMR, the post-resection bleeding rate varies between 0.6% to up to 25%, while the on-block resection rate ranges from 68% to 96%. But the general appearance is that this on-block resection rate is not higher than 90%. While for the duodenal ESD series, when you look into this summary, there's probably a higher chance of bleeding and perforation. Ranges, especially for perforation, you can see that the range of these perforation including from 6% or up to 36%. So this is quite high in the risk of perforation. While the off-block resection rate actually is more than 90%, sometimes at 100%. So this is an important message that ESD can actually achieve a high off-block resection rate, but with a higher complication. So how do we avoid complication? I think in managing a perforation and also in managing bleeding, then I think complete closure of the defect is so important. So there are numerous methods, including the use of clip closure. You can use a simple, no ordinary clip if it's a small defect. You can use a string clip suturing, as well reported by our Japanese endoscopists. So using a clip and a suture to pull the defect together and then completely close by using other clips or clip loop method, or as I demonstrate, the use of the dual action clip or even the Mantis clip from Boston Scientific. And I trust that nowadays we can also use a suturing device like the X-Tech. Unfortunately, I have tried using the Apollo overstitch in duodenum, but it's really, really difficult. First, we need to pass through the pylorus in order to enter into the duodenum to do suturing, which is quite challenging. And secondly is that when we are suturing with such a limited luminal size, it's actually very difficult to use the Apollo overstitch. But the X-Tech method helps us to perform this procedure because this will be a through the scope method. So you can see that while we are applying this tech, we can actually pull the luminal defect together. And I trust that as a surgeon, this is a more confident method of closing the defect, as you can see here. And then finally, to tighten this text, we will complete the procedure by using the cinching device, as we usually do for Apollo overstitch. So now this is a complete cinching. So when we look into the other methods like the OTSC closure, this is one of the study reporting on the use of the OTSC from our Japanese endoscopists, and with the closure of this defect in 46 cases, complete closure rate is 97%. Post-operative adverse event happens in 11% of these cases, and the use of the OTSC clip can actually prevent complication. And this is also another recent study reported from Japan, from Professor Yahagi, in the use of this complete closure of the defect, which also allows prevention of stricture formation in egg lesion, especially when he is actually doing more than 90% of circumferential ESD. So in summary, duodenal ESD achieved higher rates of en-bloc resection for superficial non-ampullary duodenal epithelial tumors compared to EMR. Duodenal ESD is technically challenging with a significant risk of life-threatening complication, while techniques of underwater ESD, complete and plus or minus pancreatobiliary diversion will help to reduce this complication. Thank you very much.
So a really fantastic case there, Philip. Thank you so much for sharing that with us. Whilst that was being shown, Pradeep was literally sort of bouncing around in his chair with a million questions to ask you. So I'm just going to hand straight over to Pradeep to ask you a few questions.
Hi, Philip. That was a excellent demonstration of how you can perform such a complex procedure in a safe way and achieve the defect closure, so we don't need to worry and sleep at night. I've got two questions in my mind. One is, how do you select your cases for ESD? Because I find it extremely challenging to assess a duodenal adenoma and decide this is likely to have high grade or cancer. It's not that difficult in colon. Barrett's also, we mastered it now. But duodenum is very difficult to make an optical diagnosis. And second, if you can just show us the intricacies of how you change your technique, the ESD technique for duodenum, apart from just underwater. What other things do you do differently?
Thank you, Pradeep. And you are so right. In fact, the selection is really difficult because we cannot make a good optical observation, and it's kind of challenging to look into the presence of a deeply invaded or a high-grade dysplasia. But I think in general, we applied a ESD if the lesion is greater than 20 mm, and at the same time that we cannot get it in the one piece, then we would apply. And secondly is that the kind of border, we actually wanted to make, achieve a good on-block resection. And secondly, so my technique of duodenal ESD actually evolved, as you said. Initially, it was like a, no water, no underwater, and just using CO2. At that juncture, it's really difficult to expose the submucosa. And secondly, in the past, I actually do a little bit deeper dissection into the submucosa, but now I leave a plane of submucosal tissue to avoid a delayed ischemic perforation. And thirdly, complete closure is so important that I think we need a lot of methods to achieve that in order to prevent delayed complication like delayed bleeding perforation.
Sure. Thanks. I'm sure my colleagues have got a lot more questions than me.
Yeah,
so we move on.
fantastic case, Philip. Thank you so much. What's the sort of long-term outcomes of these? What's the recurrence rate of these duodenal adenomas? Is it similar to colonoscopy or?
Yeah, I think the important thing is about the recurrence rate. That we wish to reduce the recurrence rate by doing a ESD. I trust that most of the report is a retrospective cohort study, and but those actually showing that the on-block resection rate is better than the EMR. But at the same time, we have no randomized control trial because of the limited number of cases, as you can see and know. And so that we cannot have a good data about the long term as well. But I think that is the goal, that we wish to reduce the recurrence rate. In our cohort study, we actually do like 30 cases, and the recurrence rate is actually quite low. Most of these cases were on block resection, and so I think we have good confidence that for duodenal ESD, we can achieve a high on block resection with a low recurrence.
Fantastic. I'm just going to ask a couple of questions to the guys in the audio in the studio. So, John, I mean that's an amazing case that Philip showed us, but I find the conversation on duodenal adenoma is quite challenging. When do you take them off? And what sort of patients?
Well, firstly, I would say, and perhaps Philip's best place to answer this is for me the discussion is primarily about EMR and cold snare. Access is critical. So, I'm really interested in Philip's view on this in terms of, the position in the duodenum. Does that affect his choice between EMR and ESD? I think that this is certainly something that we have to be very, very careful in our consenting process. So we're warning patients about the significantly higher risk of bleeding and also of perforation. So this is not for someone just seeing a 1 centimeter duodenal adenoma that may never become a problem. I think this is for a significant lesion that there's got to be a genuine concern that lesion will become cancerous in the future. So I think it's the careful planning. And I'm really interested to ask Philip exactly this. What do you tell your patients, Philip, in terms of potential complications rate and a little bit more on the technical side of this, on how long do you keep the patients in your institution after the ESD? I think these are really practical tips that I think the audience would appreciate an answer to.
What are your thoughts, Philip?
Yeah, thank you so much. And so I think firstly is that the consenting process is very important, that we have to tell the details about the complication. And I think out of all the ESD, we have, highest complication probably from the duodenal ESD. And secondly is that when we are, keeping the patient in the hospital, I think we have to be really careful. So usually in general, I would keep the patient in hospital for 4 to 5 days to ensure that there's no other complication. We check post-operative blood tests, white cell count, amylase level and also CRP, and then of course for any bleeding as well. So I think these are very important, to be careful in managing the duodenal ESD. If we are worried, in fact, we can put in the feeding tube, fast the patient for a longer period of time.
So I think one of the questions in my mind, and Philip, you may be able to answer this, is are we potentially making something a little bit more complicated? Because I think you would agree the R0 resection is not significantly better in these two techniques, as far as I understand. So are we gaining something? Is there significant benefit safety-wise? Because I'm not so sure the data is bearing that out at the moment. But again, I'd really like to drill down on how often can you successfully close the defect? What are the technical challenges with that? Because often in these live cases, we see a beautiful closure, but in the real world, that can be very challenging. So a little bit more practical decision making.
Yeah, I think the closure require a lot of techniques. So firstly, you need the expert to do the duodenal ESD. So of course, if you are not expert, please do not try to do it because it's really difficult. And the second is that the complete closure, it requires a combination of technique that you probably gain from closing defect from like colonic ESD, learning from that, and also the gastric ESD. And then you have multiple methods, a lot of clips and the X-Tech system. And then I think those are very important, or even the Japanese using the clip line closure approach. But the complete closure is definitely most important. And I agree with you that probably if you encounter such a lesion, which is manageable by just underwater EMR, I think that is a preferred choice as compared to ESD.
Thanks so much for that. And just coming to, I remember, obviously this lesion was a bit big, but I remember when the full thickness resection device was sort of first brought out, there was a lot of chat, oh, it's fine, duodenal adenoma is a thing of the past and we can just quickly suck those up and get rid of them. What's your experience and feel of using these sort of full thickness resection devices in the duodenum or in general?
Disclaimer, I don't do much duodenal work, but of course we get a lot, because most of them, at least the patients we get referred are patients who have adenomas, and we do in our center mostly cold snare EMRs for those. But the cases we get referred for example, full thickness resection, are usually if there's suspicion on a small neuroendocrine tumor, for example, because those are lesions you can find in the duodenum, and usually they're relatively small. To fit into the full thickness device. But I have to say those are very limited. We have very limited indications for full thickness resections in the upper GI tract, and even smaller for the duodenum. There's some series out there that describe good outcomes, but I think the duodenum anatomically seen in its relation to the pancreas and the colon, etc. I think if you should only do that if you are really comfortable that you know what you're doing, and that it's the right indication. And
I understand. And Pradeep, coming on to you, we talked a bit. I don't know if you saw in the esophageal section about stricture in post ESD, and one thing that I think is always slightly anxiety driving is you get a stricture. Let's say it's either in the duodenum as we've seen here or in the esophagus. Can we safely dilate those? Is that okay?
I think duodenal stricture is not as common as the stricture we see in esophagus. Somehow you get less stricturing in duodenum, but once you get a stricture in duodenum, dilatation is a lot more challenging than in the esophagus. The access to it, the position and things, you never get a straight long view in front of you. So I think once you get a stricture in duodenum, it is challenging. So as John was saying, think a lot before you start doing anything. If it's an elderly patient with a adenoma which involves 80-90% of the circumference, we're taking a massive task here, because if he strictures or gets a perforation, everything is challenging. So I think it's when not to intervene is very, very important when it comes to duodenum. So you have to keep that very clear. Once you know there has to be taken out, then your choices, to me, underwater EMR now for duodenum is becoming very, very popular, and cold EMR. And that can be safely done, very quickly done. But then it only flat lesions without big nodules qualify for that. You have a big nodule, you have to resort to ESD or EMR. and then depends on your skills. If you are like Philip, he can do ESD, is no problem. But I have a technical question about ESD to Philip. So Philip, when it comes to ESD in duodenum, what I find is, I don't have as much experience as you do, but the first injection in the duodenum, we get super lift. It's very nice before the incision of the mucosa. Once we start cutting the mucosa and start dissecting, after that, the lift starts dropping. And I find it very challenging right at the end. When I'm doing the far end, that's very difficult because now I've dissected everything. Lift is not staying. I can't retroflex. So I've started changing my practice, and I do the far end first, and I do a mucosal incision on the far side, and then go from this side. But then I suffer that my lift begins to disappear even quicker. So it's just a dilemma in my mind. Can you help me, please?
Underwater. I think that's the answer.
Yes.
Underwater actually helps. You can see.
Yeah, I agree. Maybe this is what we need to do more. But in the duodenum, does the water stay for long?
Yeah, that is it's challenging. So you have to keep on injecting. That's also that's a challenging, and you have to be careful. So I think the warmness of the water, the normal saline, and also don't over initiate the normal saline to the patient, also very important to cause like fluid or electrolyte imbalance. So be careful about that.
Yeah, brilliant. Look, thank you so much for your. It's been it was a really phenomenal case, and really interesting to hear your thoughts as always. And thank you so much to the faculty in the studio. We're going to change on to our next section now, talking about reflux and motility. So thank you so much, Philip. Good night, I think, for you.
Thank you.
Good morning. So have a good evening, and we'll hopefully see you very soon. Let's change on to the next section now.
Thank you.
What do you do?
Hi, welcome back. So we are now starting the soft gel motility section, and we have with us Raf, Vinny and Pradeep. So I'd like to go straight to Professor Pradeep Bandari, who has already been introduced, who's going to talk about interventions in esophageal reflux and motility.
Welcome back. I'm delighted to talk about how endoscopy has progressed and how we're making a big difference in treating motility as well as reflux disorders. I remember very well in 2004 when I started doing ESD, I had a big surgical lobby revolting against us that we're taking the stuff away from them. And now we're doing the same by starting treating reflux and motility disorders. But I'm sure you will see at the end of my talk that it makes sense. So these are the two guys who laid the foundation for this work by describing the third space endoscopy. So they had these concepts and idea in their mind and did some animal work to prove. This was back in 2007. And then Professor Inoue in 2010 performed the first human POEM procedure. And this is what I think has laid the foundation for a lot of things that we're doing these days. So how is POEM doing? Well, it's not just the esophageal POEM. You can see now how third space endoscopy has evolved, and we're treating so many conditions by the same principle of third space endoscopy. This is a patient with achalasia. You can see that the sphincter is tightly closed. We do manometric studies to confirm the type of achalasia, and then you make a simple mucosal incision after injection, and you enter into the submucosal space. So it's very important at this stage not to damage the muscle. Once you are into the submucosal space, you dissect and make this big tunnel, goes all the way beyond the lower esophageal sphincter, about 3 centimeters or so into the stomach. And then we do the myotomy and cut the muscle. We used to debate a lot about circular myotomy, full thickness myotomy. I don't think any of that makes a difference. And then you close, and that's job done. So the whole procedure would take about 30 to 45 minutes if it's not complicated by previous intervention. You can see here in this meta-analysis that a lot of patients have been treated. It is pretty safe. The success rate is good, almost 90%. It does have a reflux rate. A lot of these patients would suffer from reflux afterwards, so you got to manage that. But overall, it's a very safe procedure. Now, there are not many endoscopic techniques which make it to New England Journal and JAMA. And this is two randomized trials, one against balloon dilatation, the other one against surgery. You can see here that at a 2-year follow-up, POEM was superior than balloon dilatation, and the outcome of POEM was very similar to surgical myotomy with a lot less complication. So in my mind, I think achalasia now, the best technique is POEM, not balloon dilatation or surgery. I think the reflux remains an issue, but there are lots of ways of fixing the reflux. This then evolved into taking the same principle forward in the stomach. Patients who have motility disorder in the stomach, we make a similar tunnel. We find the pyloric ring. You see there, that white muscle is the pyloric sphincter. I use a knife, cut the pyloric sphincter. It's almost done. One more cut, and you can see we extend very tiny bit backwards. Try not to cut the stomach muscle too much. Once the pyloric sphincter is cut, it's best not to pull that too far back, because this is where the complications happen. We hit various vessels and enter into a strange cavity. So same thing, come out, close the mucosal defect, and job done. Again, lots of patients treated. The biggest challenge here is not the procedure. Procedure is pretty straightforward. You've done a lot of POEM, but it's patient selection. I still don't know who's the best patient and who will respond. but in general, we find post-surgical gastric stasis, patients who had vagotomy or damage related to that, they are a good candidate. Everyone else is debatable. Zenkers, again, we're using the similar principles of third space. This is another different kind of motility disorder which causes dysphagia. You open up, you find the septum. There's nicely demonstrated septum. We inject on both sides, make space on both sides of this septum, and then we use the knife to cut the septum in the middle, take it right down to the base of the pouch. Once the septum is cut, you come out and you close the mucosal defect. There you go. So the septum's cut. This is very quick, 15 minutes, no more. And a lot of these procedures are happening there. You can see in this study, they compared the technical success of Z-POEM, of septotomy and surgery, and looks like Z-POEM seems to be equally or better or more effective. There is complication rate here. Patients can get mediastinitis and surgical emphysema, so you need to be really, really careful when you're doing. And if you're not very experienced, this is a very tight space, so be very careful when you are in this space because closure can be very challenging. I've treated you, how do I make this video work? I think somebody could click on this to make the video run, will be a great idea. Patients who get big diverticulum in the esophagus, as the guys click on this video and make this work, I'll show you that these big diverticulum in the esophagus can be extremely challenging and can cause dysphagia. In the past, some of these patients used to have surgery. You see here, there's a man who have achalasia, but has a massive diverticulum which is giving dysphagia. So we use the same principle again here. Here, I'm going a little bit above the septum, starting a tunnel from here. We'll get up to that diverticular septum. There you go. We found that septum muscle. We'll cut the muscle very much like how I showed you in Zenker's diverticulum. Once the muscle is cut, it's very difficult to make out when to stop, but you have to constantly keep coming out, keep going back in to understand where you are to decide when to stop. That is definitely the time to stop. And you see your mucosal defect, put some clips, close the defect, and this was sorted. So this was extremely rewarding because patient was very symptomatic and symptoms really improved very fast. Moving on rapidly to the new world of anti-reflux options. There are a lot of these options now. Some of them are device assisted, others are non-device like ARMA and ARMS. We don't need any special device, whereas for GERDEX and TIF, we need special device, and then you have Strata. So before we jump into this, it's very important to understand the anti-reflux, the natural anti-reflux mechanisms that we have. So it's very important to know that the diaphragmatic crura forms a very important part of both physiological and an anatomical valve. Similarly, this shape of the stomach where the angle of His comes in and forms a big mucosal fold which forms this mechanical flap valve and anatomical valve which prevents reflux. And finally, the lower esophageal sphincter, the circular muscle of the lower esophageal sphincter is very important. It runs downwards into the stomach as these sling fibers, and they again form a very important mechanism for anti-reflux. Somebody could click on that video to run, please. This is a patient who's having, so if you click on the video, yes. So a patient who has a TIF procedure for reflux, you assess, and you can see here that the sphincter is loose. I would say Hill grade 2. We put the device, you can see it opens up. This is the jaw of the device. We'll put a helix down, grab this mucosa just below the squamocolumnar junction, pull it in, and then create a wrap. Do you see that how I'm rotating? And you just rotate it towards 1 o'clock, get a nice tight wrap, and you fire your staple. You do the same thing 3-4 times on one side, then you move to the other side, pull that in. You see that? This is only half done, and already it's looking really, really tight. So it creates a nice wrap. We done the other side, and you can see such a big wrap around it. You can see the data here looks pretty good. The technical success is very good. Even the clinical success rate, the quality of life related to reflux, there's very good quality of life, not falls down, it goes up. The PPI consumption at 12 months goes down, and all the reflux symptoms in almost 70% of the patients, the symptoms settle down. The adverse event rate is very low, but it requires a lot of steps, and it requires a very good assistant to show you all the time. This is the data from the GERDEX trial. Could somebody click on that video, please? So this is the other device called GERDEX. We put a guide wire, and because this device doesn't have the scope that we can thread over, so we then put the device down, and as the device goes in, you can see here, then we can put the scope through the device, and then the very similar principle to the previous device is we helix, pull the tissue, but it has massive jaws, and then it will fire the staple. So this causes gastrogastric plication as compared to esophagogastric plication, which I showed you with the TIFF device. This is the data from Nagi Reddy's group, where they did a sham control, randomized control trial in 70 patients. And you can see at 12 months, there's a progressive improvement in the quality of life related to reflux, a progressive drop rate in the consumption of PPI and various other reflux measurements. They also did objective measures of pH, and there's significant improvement in pH measurements as well. A similar randomized sham control trial done in post-POEM patients by Amit Maidev group, showing exactly similar results. So another very interesting device. The beauty is it's very short procedure time, less than 20 minutes you can do. So these are the two non-device assisted procedures. On the left is the traditional EMR procedure we're doing. It's called ARMS, anti-reflux mucosectomy. At the cardia, you go, you inject, you use this old-fashioned Olympus cap and snare technique. Once you lift it, you preload the snare in this cap and take. On the right side, we don't do anything like this. We go straight with a APC catheter and ablate the mucosa, about 2 to 3 centimeter patch of ablation on the gastric side of the sphincter, making sure that we leave a 2 centimeter patch like that clear and not ablate that, making sure we don't touch the Z line to avoid the stricture rate. Here you can see we're doing the preloaded snare, suck the tissue, EMR. Both these techniques are quick. You can see after 3 months on the right side how tight that sphincter is as compared to the beginning, and you get the similar result with EMR. I think it's a personal preference, but both techniques achieve very similar results. I feel this is a technique for patients with Hill grade 0 and 1 or non-erosive reflux. If you have non-erosive reflux, which is about 60 to 70% of the reflux is non-erosive, this is the way to go forward. Some meta showing all outcome of all these ARMS, ARMA, and band ligation, again showing that the reflux symptoms improve and the PPI consumption drops down. So in conclusion, I think third space endoscopy has revolutionized things for us. We're doing so many things which we could never dream of before. And a lot of very clever devices are coming in the market to help us treat reflux, but there's still a role for non-device assisted techniques like ARMS and ARMA. Thank you very much.
Thank you. Pradeep will join us in a second, but that was a really informative run through in a very limited time period. So congratulations, Pradeep. I thought one of the things we should focus on now is what we know in terms of our current data sets for outcomes in regards to these different techniques, because we now have balloon dilatation for POEM, for achalasia, we have POEM, and we have Heller's myotomy. And based on options we have, question to you, Raf. What is the current evidence base when we're advising a patient who's sitting in front of us who says, well, doc, what would you advise I have? You're the expert, you're the doctor. Can you tell me which is better for me? What do you tell them?
Well, unless it's an achalasia type 3, where we really need a full thickness myotomy with POEM or Heller, I think the patient has a choice as a primary treatment. And we need to be honest about that. I always tell them it's not because I like doing POEM that you should have it. So if we look at the data that were presented by Pradeep, I think Heller's, at least in our center, is off the shelf as a primary treatment after the randomized trial POEM versus Heller. We don't see that the risk of reflux is so much higher after POEM, despite that Heller is combined with a Dorfund application. So that seems, at least for our surgeons, not a primary treatment option anymore, because POEM is very well controlled. You can extend the myotomy, so that's not so much of a discussion anymore. The question in type 1 and 2 achalasia is whether you're still going to offer pneumodilatation, and Pradeep referred to the Amsterdam study that showed like so-called superiority for POEM, but we need to not compare apples to peers, because it's like apples to oranges in English. Because if you have to compare something, you need to give the correct recipe, right? You cannot make a carbonara without guanciale. It's like then it's not a carbonara. So it's like so it's the same thing. So in that trial, they only dilated once, and the correct recipe for a good pneumodilatation is normally to at least go to 35 millimeters. They only have one dilatation, and to repeat it within 1 year if necessary. That's the classical Heller versus pneumodilatation trial, which showed similar efficacy for both modalities. And that is what you need to explain to the patient, right? So the information we give is that pneumodilatation is quick, but you need to repeat it. You probably need 2 or 3 dilatations to get a good effect, 85% in 5 years. And there's a higher risk of perforation, but you don't need general anesthesia. It can be done as an outpatient. On the other hand, you have the POEM, has a low risk of perforation, one-time stop, but needs general anesthesia and usually 1, 2, 3 days admission. And that is what I tell the patient. And then some choose to go for the one stop and say, I want to have it over with. And others say, well, I'm not so much in favor of the general anesthesia. I rather prefer the short dilatation, although I know there's a high risk of perforation. And I think that's the correct information to give to the patients.
I absolutely agree. So you lay all the options on the table and let the patient make the right decision. And as they see, I think in the Leuven data, it was a 2.5 dilatations over 6 years to achieve the same outcomes as Heller's myotomy. I'm going to stop you there, and we'll re-explore this and different POEM techniques later on. But we do have a POEM case that Vinny's going to talk through using EndoFlip. And so we'll start the video, and Vinny, I'd like you to talk over it as we go through it, and we can discuss as we need to.
Thanks, Matt. Do we have the case presentation that we can show? Okay, so this is a middle-aged lady that has a long-standing history of dysphagia. A diagnostic gastroscopy, as expected, revealed a dilated fluid-filled esophagus, and a time barium esophagram revealed a significant column up to 10 centimeters after 5 minutes. High-resolution manometry confirmed panesophageal pressurization with an elevated IRP in keeping with type 2 achalasia. After careful discussion about the various treatment options available for her, she proceeded with the POEM procedure. So this case will demonstrate a POEM procedure, but also pre and post EndoFlip panometry to actually demonstrate how the myotomy and the case itself was adjusted during the procedure. Next slide. So the equipment that we use, so we use an Olympus 290 gastroscope. We began our POEM procedure using the Olympus Dual J knife, and we actually completed the myotomy with the hybrid knife T-type from Irby. We have the EndoFlip balloon, and also we used Instinct clips to close out. So yeah, the learning points in this case is we're going to discuss the stepwise steps involved in performing a POEM procedure, discuss EndoFlip, and I think that will be very interesting to hear everyone's thoughts on the panel, and also the management of some peri-procedural bleeding within the tunnel, and how we actually close the entrance to the tunnel at the end, and different debates about how this best should be done. So if we can roll the video, please. So while we're waiting for the video to start, here we go. So this is what you've seen a brief video from Pradeep, but this is what we normally see, a very dilated kind of food debris within the esophagus. This is despite a 48-hour liquid diet before the procedure. So it's really important that these patients are counseled as to how to actually prepare for this procedure. But you can see the lower esophageal sphincter is very much non-relaxing, and this is very much stereotypical of what we would see. So a quick retroversion. So this is the immediate endoflip imaging. So just for those that are not aware of endoflip, this is functional lumen imaging probe. It's a balloon that will pass down endoscopically into the esophagus, and it's measuring a few metrics. It measures the surface area, it measures the distensibility index, compliance, and planometry. So that you saw there revealed a distensibility index of 1.2, which is pretty stereotypical of type 2 achalasia. So we now begin our procedure, and what we've done here is we've used the patient as their own internal control. So for us, our starting DI was 1.2. So you can see here that we've done a submucosal injection and begun to make the entrance to the tunnel. What I'll ask while we're talking with the cases running, do Raf or Pradeep, do you both use endoflip at all or not really? Maybe start with Pradeep.
No, I don't use, but I think it's a very, very valuable device when you start doing ESD poem, because you don't know where you are. Once you begin to recognize the gastric muscle, I don't think you need to know this. But and also there are challenging cases where manometry is not very clear. And those are other cases which is very controversial. And that's where, again, it can play a very good role in making sure we're doing the right treatment.
Can we just go back to the case? Thank you, Pradeep. So the four steps of POEM are making your mucosal incision, as you've demonstrated here, creating a tunnel through the esophagogastric junction, 3 centimeters into the stomach, undertaking your myotomy. We can talk about that after the case or during the case, and then closing your mucosotomy. Where are we now?
So what we've just done our mucosal incision and begun to find the entrance into the submucosal tunnel here. So we're injecting here, and we're now beginning to begin forming the tunnel here. So this, when you're starting to learn the POEM procedure, this can sometimes take quite a while actually to find the entrance. And once you found the entrance, this is my experience of having learned it more recently than the guy sitting around me, is that this step took me a while to get the hang of exactly. And then actually when you start going into your tunnel, it's actually very, very efficient. You actually work your way down to the GOJ relatively quickly here. So what we're seeing at the top at 12 o'clock is the muscle, and the mucosa is kind of down in the sort of 6 to 7 o'clock position. And you can see you've now got a nice blue space to aim in, and it's very satisfying, as you said, Raf, as you kind of begin your tunnel at this procedure, and you think this is very straightforward, until you then begin to encounter some resistance as you get towards the LES.
Always.
So, so the muscle here is on the right.
On the right.
And the mucosa is there on the left, just to kind of orient.
So this is anterior approach, yeah?
Yeah.
Yes. And you're using a dual J here, but to be honest, you can use any knife.
Yeah, I think so.
Whichever knife is a preference for you and you feel comfortable and familiar with, providing you don't damage the mucosa.
Yeah, so that's the fundamental difference here, isn't it? You cause a mucosal injury here wherever you can avoid it.
It's a bit opposite to ESD. So once you've 1 or 2 centimeters distal from the incision, it doesn't really matter if you touch the muscle already. It can create sometimes some subcutaneous emphysema during the procedure, but usually this is always a bit tedious, right?
Yeah, so this is what I'm just demonstrating here, is that we had a little bit of a peri-procedural bleed here. And it's just quite a nice demonstration of how you can use the coagulation function on your knife to really just deal with this bleeding quite nicely. And you often encounter these vessels as you get closer to the lower esophageal sphincter here.
So just from a surgical point of view, are you using sterile saline or sterile water here? Because, you're almost close, you're about to enter the mediastinum after you cut the muscle. So do you take this into consideration, or you just use tap water?
That's a good point.
We don't use tap water. We use saline.
Sterile water or saline.
Yeah. I think it's an important point.
So Pradeep, you brought up anterior versus posterior. As we know, the outcomes are very similar. What would be your approach? When would you use an anterior? When would you use posterior, if at all? Do you have a preference?
Because I started doing anterior poem, I still prefer doing anterior. But posterior, we have mastered it now, because a lot of patients post-surgery are coming, or post-poem recurrence are coming. So you need to then go posterior. So posterior is a backup, anteriors are standard. But I don't think there's much of difference.
No. And logically, in terms of data, we have no evidence to suggest one is better than the other, even with redo cases.
Yeah.
And then that's maybe where EndoFlip will be really helpful in those cases where you want to adjust the extensibility index. Just for the audience, 1 is bad, 10 is good.
Yeah, so the lower your distensibility index, the more resistance or less compliance that you have in this area. It's important we use the right terminology, because EndoFlip is not the same as high-resolution manometry. It's a different measurement. It's a different technology. It's not the same thing. So it's important not to compare the two, a bit like you're saying apples and pears. So the distensibility index is one metric that we can use during the procedure. So I'm just going to show you the beginning of the myotomy here now. So we've switched knives to the hybrid T. You don't necessarily need to here, but we just find it slightly more efficient to do your myotomy here. And you can see that we've kind of grasped the circular fibers here, and we're kind of cutting down through systematically from the top. Matt, in terms of length of myotomy, I was going to ask you.
Well, I mean,
what's your practice?
We don't want to divulge. We don't want to do a deep dive into a lot of the more complex technical issues of POEM. But if we talk about circular versus longitudinal, as far as I'm aware, there's no data to suggest there's any difference between the two. The use of longitudinal is to ensure you don't do a deep dive into the mediastinum. So, and they also give you direction of dissection. And here you're preserving them very nicely. So I think that it's a safety blanket, isn't it? That they're keeping the longitudinal.
But at the end of the procedure, usually everything is ripped open anyway.
Yeah, by the time you get down to the junction. In terms of long-short myotomy, there was a non-inferiority study from Nagy Reddy's unit showing that there was no difference between a 3 and a 6 centimeter myotomy. And that this is a reasonable clinical question to ask. Why are we doing 6 centimeters? Because we're basing it on the original study.
Yeah, and I think, Matt, I mean, I agree with the study. I'm well aware of it for type 1 and type 2 achalasia. But on the other hand, we're doing a surgical intervention. You need to dive into the mediastinum. So the reason why we do the long myotomy is based on the surgical myotomy, right?
Correct.
And obviously we know if you do limited rupture of the muscle with balloon dilatation, that we do get a good result as well. So it makes sense to do a shorter myotomy, but on the other hand, it's a different intervention than a balloon, which you can do in 5 minutes. This takes an hour, 60 to 90 minutes. So why not just do a proper job? If there's no difference, you can just as well extend it and do it like it's always showed to work, right? So I would be very cautious in limiting it.
The concern was over an amotile distal esophagus with.
But it's amotile as it is. It's achalasia. There is no motility anymore.
The video,
right?
Except in type 2s where you still get shortening.
Wow, but that's not motility.
Correct. Agreed.
It's spasms.
Just to interject, I just wanted to demonstrate on the video here that we've now gone down back with the EndoFlip balloon. And actually, what we just missed was that the balloon had actually gone into the tunnel.
My gosh.
Right? So I think it's important to sense check before you inflate the balloon. Which is why I included that in this video here. So we've repositioned the balloon under endoscopic visualization now into the stomach. So perhaps something that one wants to consider before you start opening up this device and using it. So what we should see next now is some images from the immediate post myotomy EndoFlip images. And it's quite interesting because we were pretty happy with our technical result at this stage before we close the tunnel.
Jesus, look at that.
Yeah, you can see that?
Yeah.
So we've repositioned it. So you would have definitely delved into the mediastinum there if we'd inflated the balloon. So interestingly, the DI, which you're seeing in the bottom right, is still only 1.1.
Okay.
Right?
So how much do you inject? Is this 60
mils?
60 mils. That's also important to emphasize, so that the reference is at 60 mils. Right?
So what we did here was we extended the myotomy longer.
This is very interesting. So although we're using our patients as an internal control, we don't really know what DI we should aim for, but what we should, as a general rule, we should aim for a DI at least 5 or more.
Yeah, roughly speaking.
So in this scenario, the EndoFlip has been really useful because you've now extended your myotomy. Again, from Nagy Reddy's unit, there was some data to suggest a long gastric myotomy extending beyond 2 centimeters might increase the risk of gastroesophageal reflux post-POEM. And small study, they suggested that if you limit it to 2 centimeters, you get less reflux, but very small numbers, unclear data. And as we were discussing offline, it's so difficult to measure between 2 and 3 centimeters. Whatever technique
Give it 60 seconds.
Just the immediate images afterwards.
Yeah, give it 60 seconds to
We've kept the balloon
settle.
inflated for 6 seconds. The DI is coming nicer.
So you have to compare like for like.
So this was now closing the tunnel with some instinct clips.
So you went for the full myotomy in the end?
We went for the full, extended it with a full myotomy in the end.
I think the surgeons
point
will
in
be very
question.
happy.
Sorry, Matt.
No, but I think for us, the endoflip is a really useful tool in the refractory cases. So as Pradeep was saying, very often after pneumodilatation, there's fibrosis at the GI junction. The manometry shows low pressures because it's like an open but really fixed opening. So it's really fibrotic.
Yeah.
And the manometry doesn't measure any high pressure anymore. And then in combination with the barium swallow and then showing that there's a porous sensibility, that is really something that always triggers us to do the POEM. And then in those cases, you do in fact find this large fibrotic block of tissue at the level of the GI junction. If you cut it, the patients are really improved. Yeah. And
does anybody use anything other than clips to close their tunnel?
No. It works
not,
perfectly.
not in Europe and UK, but if you're in the US, you will be stitching it.
Well, it takes about 30 seconds to close a mucostomy with clips that cost you about 100 quid. And probably not many. So the idea of using stitching is nonsensical. So that video, I think we've got a few minutes left, and it's important that we really table some key learning points. And we'll focus on POEM. Pradeep, thank you for the lecture. That was actually in 8 minutes or 10 minutes. That was a wonderful, very quick journey.
I was
covered
told
everything.
You have to whistle. What do you call it?
Whistle stop. A whistle stop. Yeah.
Whistle stop tour.
So I think if we just focus on POEM, each of you just have a think about some key learning points from referral, techniques, outcomes. What would your learning points be?
The important thing is about case selection to make sure you're choosing the right, as we were discussing various technical points. To me, gastroscopy informs me a lot more than all these things. The HRM and barium brings the patient to me, but how I tailor make the myotomy depends on what I see on gastroscopy. If you see big shelves of tissue and muscle poking into the esophagus, you know you have to go above it. If you just focus on the sphincter and not take care of these big muscular ridges in the esophagus, patients come back with recurrent symptoms, or they develop pop-up diverticuli because the muscle pressure is very high and you cut the muscle below it. So it's important to do that assessment yourself and decide where you will start your tunnel and how much muscle you will cut. And second is to warn your anesthetist that these patients will get surgical emphysema, they will get pneumoperitoneum, no reason to worry, but you need to be very good in managing that. It's very, very important that you know how to manage that. Otherwise, it becomes a complication. It is not a complication. This is part and parcel. And generally, we keep the patient overnight. Next day, they get a swallow. And if there's no leak, they eat and drink and they go home. We don't give any antibiotics, nothing. Increasingly, maybe you could do it in the morning and send the patient home in the afternoon. We've done when there are no beds in NHS. But maybe that is the way to go forward, but I'm still not brave enough.
No. So, yes, day cases for some patients. So, key points are your endoscopic assessment will tailor your POEM in terms of what you do, which is really important. Raf?
I think the patient involvement is crucial, and patient information, as I told you before, about the choice between POEM and pneumodilatation, especially for type 1 and 2, but also to get the patient's expectation right. I always explain to them what that 85% success rate in trials means, and that's an ECGAT score below 3. So that means that dysphagia usually is still there to some extent. So if they expect to be eating like 20 years ago, you need to warn them in order to have a happy patient, in my experience. If you say everything's going to be fine and normal again, it's not going to be the case. And they need to know that in advance, that there's going to be some residual symptoms, because the hypermotility will not disappear.
So, multimodal assessment from Pradeep, key information and adequate consent with managing all of the patient expectations prior to the procedure and the choices they've made from Raf. Vinny?
I think, yeah, in addition to what the guys have just said already, patient selection is critical. I think a lot of patients come to you thinking POEM is the best and the gold standard, when actually when you inform them, pneumatic graded dilatation actually can be just as effective, particularly for a suitable cohort of patients. Training is very important. I think it's really important that you do this in an expert high volume center. You learn where you have surgical support on hand. I think a sort of training number of 20 probably is reasonable. But that needs to be tailored to what your previous endoscopy experience is. So I was, and then moving into POEM was probably not so steep a learning curve. But if you're just starting, understanding the anatomy of the third space and what you're looking at, this is completely out of convention with what you've seen endoluminally. So you need to take that into account and appreciate what you're doing is very different to ESD. We're damaging the muscle here intentionally, whereas that's an absolute no-go area in ESD. So I think training is important, making sure you find the right center. And I think I'd be intrigued to see how EndoFlip evolves as we get more and more data. We begin to get a better idea of what is or isn't normal. And I think the treatment failures, that will be very, very interesting to see as we do more of this and develop a better understanding of this technology.
Thank you, Vinny. Thank you all. We'll wrap up now. Thank you for a great session. And now we'll finish here and go on. So please come back to us for management of strictures in our next session.
Welcome back, everybody. That was a very speedy coffee break. So we've had a very quick turnaround within the studio itself. So we'll just begin by reminding everyone who's in the room at the moment. So John Morris has joined us back again. Professor Bishops and Roos is back on the audience. The next focus for the next session really is going to be the management of strictures and perforation. So complications, when things go wrong, something we see more of. And I think in my own experience, we've become more embracive of radical endoscopic therapies, including ESD and the esophagus. So we are facing more and more strictures. And often managing the fallout of these is something that we need to counsel patients about before. And I think it all comes back to patient selection, talking to your patients very carefully and warning them that we are going to render you quite symptomatic, potentially. And I think things can sometimes go wrong when patients' expectations are not necessarily aligned with the reality of what happens afterwards. And I think that's a thing I want to get into with the faculty here who've clearly got a lot of experience in this field. What we'll begin by doing is we'll begin by demonstrating a case of it. So if we can get the slides up for the first case, please. So this is a 70-year-old gentleman who was treated with endoscopic mucosal resection for high-grade dysplasia in Barrett's esophagus. He developed a stricture after his resection that was symptomatic and has been referred for endoscopic dilation to us. So next slide, please. So we're actually going to use this opportunity to demonstrate the ambuscope. So this is a disposable endoscope that you may well have heard a little bit about. And we're going to show you the optics of this scope and actually how it can be used for therapy. Very portable, very convenient, and potentially has some applications within certain remits. And we're going to be using a Boston CRE through the scope balloon to perform the dilation. So if we can go into the video, please. Okay, we're just going to wait for the video to load in a second. Can I just ask, have any of the faculty used the ambuscopes?
I haven't used them.
Ralph or Rose?
I haven't used it.
Just for some diagnostic purposes.
And in what was the remit for that, or the reason for that, I should ask?
Yeah, it's just, it's a very easy answer. We're merging hospitals, so we are building down our endoscopy service in one of the two hospitals. And using disposable scopes might offer logistic advantages in not having someone there cleaning the endoscopes, etc.
So more for convenience and practicality.
We're certainly seeing these scopes being used in our more remote and rural units where you may have the same issue with disinfection and reprocessing endoscopes. Mm-hmm. So it does offer flexibility, and I think we're seeing a big growth in that.
And I think there was a real interest around the pandemic time around kind of transmission of infection and getting rid of these scopes. You think it did gain a bit of traction at that time, Raf?
Yeah, for ESCP, definitely. We are doing a pilot for bleedings at the emergency for the same reason. Don't have to process the scopes, especially in the weekends or the nights, so it can be beneficial.
So a potential role, yeah. So I think we're ready to go to the video now, so if we can roll the video. Please.
So this is the AMBU single-use gastro-large therapeutic gastroscope. As with all AMBU scopes, it's single-use. The handle is made out of bioplastics, so it reduces your carbon footprint by 70%. It's incredibly light and very maneuverable, and it's really easy to set up. Simply plug in the scope into this monitor, and you've got a monitor you can take anywhere with you alongside a stack. And here we have a gentleman who's had an EMR, and he's got a post-EMR stricture. And he had his EMR for Barrett's high-grade dysplasia. I just wanted to pause here quickly just to show that even with this single-use scope, you can definitely make out the mucosal esophagus perfectly adequately to perform your mucosal inspection. But Jen, if you just show us the stricture here in question. So we're going to perform a balloon dilatation for this gentleman. Now, we know the scope itself is 13 millimeters in diameter, and if we can't pass the scope through, we therefore know that it must be smaller than that. And just looking at it, it looks like, say, about sort of 8 to 10 millimeters. So we're going to have a 10 to 12 scope to discuss, 10 to 12 balloon to discuss. So we're going to pass the balloon into the channel. So it's a 4.2 millimeter channel, so that's really very big. You don't have any trouble passing any instruments at all. When you're in the channel of the scope, when you're doing a balloon dilatation, always advance the wire 5 centimeters before you get the balloon out. So that way you lead with the wire rather than the balloon, therefore minimize your risk of perforation. So now you can see that Jen is nicely guiding the wire through the stricture. Now, one mistake people often make is they get really up close to the stricture with the balloon, but you have to remember your balloon is quite long, it's 6 centimeters long. So actually, once you've got the balloon fully out, you can then give yourself some space so you don't get sucked through. So there's the end of our balloon there. And then all you have to do is just clamp the balloon with your fingers by the buttons there. And again, as I said, just give yourself a little bit of space. And now we can inflate the balloon. I've got up to 10. What I would then do is just slowly go back and forward, see how tight that is. Does that feel tight, Jen? That's not too bad, is it? And come back a bit. Come back now. Just bring your balloon back into your... Yeah, that's great. So we know that's about 10. You can see the balloon's probably, yeah, just about sticking there, but that's pretty good. So guys, let's go all the way up to 12 now. Actually, I wouldn't necessarily do the next step. I'm fairly confident that it'll be fine. So just give yourself a little bit of space, Jen. That's 12. So now we're up to 12 millimeters. Again, I'll just do the same thing, which is a gentle back and forth, just to see if the balloon goes through. And it does, you can see it's passing through. So let's bring that down then, guys. And then the first thing you need to do now is now inspect the area you've dilated to make sure there's no perforation there. So we're just going to have a good look here. So again, you can see there's no deep tears there. There's no perforations. We're very happy that this is a finished job. And that's a balloon dilatation performed with a single-use disposable large channel ambu gastroscope.
Okay, that was great. So I think what we're going to do is we're going to go to the next case, and then we'll discuss both this case, the one we're just going to see shortly. So the next case is a 68-year-old lady who was diagnosed with metastatic esophageal cancer, which was complicated by an airway fistula between that and the esophagus. She's presented with absolute dysphagia with recurrent pneumonias. And she was referred to us because the local community hospital were unable to confidently place a self-expanding esophageal metal stent, and there were also concerns regarding airway compression when we placed the stent, which is a really topic that I'm interested in. I'll talk to you about your experience shortly. So the focus of this case is to demonstrate a Pentax I-10 gastroscope, the use of a Boston Medical Amplax wire, and a fully covered self-expanding wall-flex stent for esophageal placement. So if we can begin the video.
So this is a patient who's been referred to us with a long esophageal stricture that they were uncomfortable stenting in a local hospital. She's also known to have a tracheoesophageal fistula as well. You can see the top of the tumour here starts at 20 centimetres. And so these can be tricky because obviously they're quite high. You can see, however, her hypopharynx, if we come back to her cricopharynx just here, we've got about 3 or 4 centimetres. That's the hypopharynx there. That's probably at 17, maybe 16, 17. So there is space. It's just there isn't much space. So what we need to do is have a nice, accurate stent placement. So the best way to do this is use a contrast bleb marker. Needle out, please, Mark. Great. And what I'm going to do is I'm going to come back to where I feel comfortable putting the top of the stent, which is probably here. Arno, could you just support the scope for me there, Arno? Thank you. And inject, please. Screen, please. And you can see I'm just putting a contrast bleb there. Keep screening, keep injecting. Yeah. There you go. There's our contrast bleb forming there now. Good. Stop injecting. Thank you. Needle back. So now you can see, stop screening. Thank you very much. And just flash the screen for me there. So that mark there is where I want the top of my stent to be. Screen again for me, please. Which, as you can see, is just below the, and support the scope for me there, just below the, wire for me now, please, sorry. Amplax wire. Just below the cricopharynx. So now we're going to use an Amplax wire. You can see this is a bit of a tricky tumour, this. And so we're going to use an Amplax wire. We use these for these sort of trickier stent, rigid wires, but they have this flexible tip that allows us to pass through the tumour with a bit more ease. Screen for me, please. So you can see it was tricky to get the wire in that case, just because there's a bit of a twist and a turn to it there. Keep screening for me, please. And I'm just passing this wire down. I'll come down into the stomach. See, I want to see it's in the stomach, please. Super. So you can see the wire now is really far down into the stomach. Come back up to my scope, please. Here's my top mark. Okay, so now you can see the contrast bleb, and you can see the top radio-opaque marker just there, level with the contrast bleb. So now we can release the stent to make sure it doesn't move from that contrast bleb. But you can see it's just sort of hidden behind that ECG wire there. Okay, keep screening, please. So now it's just about keeping the stent secure at that level, at that mark. We know we haven't got much maneuverability here. And there, you can see the top is now released at the mark. Screen, please. Good, you can see the proximal flange there, right on the mark. You can see it's opened out below that, that's good. It's very tight in the middle there, actually. Very tight. Everything out, guys. Everything out. Thank you so much. So now it's a case of just quickly checking that one, the stent isn't slipping, and two, that it's in the right place. So there you go. You can see the top of the stent here, below the cricopharynx. Here, sitting there nicely. She might get some symptoms from that, but hopefully not too much, and obviously it will allow her to eat and drink. So there we are. We're in the stent now. That's good. So there's the top of the tumour there at 20. And when we're just coming back now, and you see the top of the stent is perfect there at 17, 18. Just sitting there nice and open. And you can see there's a hypopharynx there at 16. So this is a patient who's been referred to us with a long esophageal stricture that they were uncomfortable stenting in a
So good, we had to almost play it twice. So a lot to discuss in the next 5 minutes. I'm going to really try and focus my efforts on this. So John, I'll start with you. What is your experience of very high foregut strictures in the esophagus with suspected airway involvement? Do you have an approach to this? Do you have a systematic way of deciding what you're going to do?
Yeah, I mean, I think David has brought out some key points here. I mean, the first thing is to make sure that when we're selecting the stent, we've always got an awareness of the risk that the stent will be deployed too much proximally. So I noticed that the David injected, occasionally we've made the point in a really challenging wire position that we'll actually get the wire in and then exchange out and then go back in and mark. So there's no distortion. And we've clearly have to measure the distance from the upper end of that stricture to the hypopharynx. Otherwise, the patient's going to have a sense of globus or at worst, you know. I think the other thing is for these high, especially when we're in that area, we want to make sure there's not a risk of tracheal compression. So occasionally, in a very high lesion, what we'll actually do is actually go down and inflate a balloon roughly to the diameter of the stent that we expect or the expansion that we expect, and then you inflate the balloon, and then you just watch and see, what's happening with that patient's airway, what's happening with the saturations, etc. But otherwise, I think that was a textbook demonstration. I think what David's also shown is an awareness of that stent will shorten. So the deployment there has got to be crucially as far proximal as he can make it. But equally, we don't want distal migration, so that'll shorten by about 30%. So even his last comment about, well, that should be okay, I think that will be fine because that stent will still shorten. So it's having aware of the others around you. I'm not quite sure why this was a failed ERCP, a failed placement. But clearly, this has got to be done under screening. In my view, so I don't think there's any case for a blind placement. But otherwise, very nice case.
Yeah, and I think the thing that we haven't shown in this video is that the patient had a pre and post bronchoscopy. So we work very closely with our chaps in interventional bronchoscopy. We're a bit privileged to have that service. And they looked down first, made an assessment of the airway, and then checked afterwards. And if necessary, intervene. And that comes to my next point, maybe to you, Ralph. What's your thoughts, or do you have any experience of combined stenting, airway and tracheal? Is it something that you recommend, or is it something that's frowned upon? Are you concerned about?
No, actually, I was about to bring up that point as well. So usually we do this together with the pneumologist. Bronchoscopy is also in our endoscopy unit, and I think we would schedule that case together. And very often, because of the tracheoesophageal fistula, we would do a stent on both sides in these cases. Yes.
Yeah. And so we often have to think about doing that as well, but it's really important to counsel the patients that I couldn't see the fistula endoscopically on that video there, but these stents, if you leave them in for long enough, they will fistulate. And the reality is, in our experience, these patients are very, very terminally unwell. Yeah. And you're doing this intervention as a quality of life improvement measure. You're not really doing this for anything beyond that. They just want to be able to swallow.
Exactly.
And sometimes if there is is no room, we may just place an NG tube, and if they've got a life expectancy, it's not uncommon to see sort of 4 to 6 weeks. And you have to be pragmatic in that, you know, and you need to have a balanced conversation. So we look at all of these scans in our MDTs, we look at them with the respiratory guys to kind of assess possible airway compromise during the procedure before. So it's not just all horses for courses. If we come back to a more simple case of the stricture ruse, just want to ask you, what are your thoughts on balloon versus bougie? I get asked this a lot. Which one is better? Which one do you prefer? Is there a difference at all? What are your thoughts if someone was beginning to explore dilation in the foregut?
Yeah, so I would say there have been some randomized trials. There's no difference if you use a balloon or a bougie. I think it really comes down to what you feel comfortable with, because the bougie, of course, gives you the tactile feedback, which you don't have with the balloon. But with the balloon, you see what you're doing. And I think personally, I have a preference for the bougies because that's how I was trained. So I have a lot of experience with that. But if you're trained using the balloon, which in a lot of countries is the fact because there's no bougies available, and you feel comfortable with that, you can use that as well. So I don't think based on data that we can say that one is better than the other. I think you always have to be careful, like was really demonstrated in the case, just do it in a stepwise manner. And if necessary, have the patient come back for an additional dilation. Of course, the problem now with the bougies is that they are disposable. So in terms of costs, there's no more advantage, which was there in the past. And the only indication I have for using a balloon rather than a bougie is if we have a very fresh ESD wound and we do the dilations, then it sort of mentally feels better to use a balloon to dilate than having a bougie scrape across the wound every time. But that's how I usually approach these cases.
Yeah, I mean, I think it's really important for the audience here to conceptually think of these post-endoscopic therapy as there's almost two divergent pathologies. So we have in this case, we have a post-EMR stricture, which I think is going to be treated well with just the dilatation. We would personally choose to use the balloon dilator. But if you have an inflammatory stricture component, which may be post-halo treatment or some other ablative therapy, there's so much inflammation, then we would tend to go early with injection of steroids as well, because otherwise you'll get recurrence. And it's amazing how often I hear that people will do a dilatation, then they'll wait and see. They'll say, okay, we'll just wait till the patient comes back, which I don't think is adequate. I think these patients have to have a scheduled program. We need to have that expectation. You know, you have this dilatation, then we're going to bring you back. I mean, what was interesting in that case, I thought, was it seemed actually quite soft. You know, the balloon, was quite mobile. And again, for, potentially for trainees and nurses in this audience, David made a really important point, which is about making sure that you anchor your balloon during the procedure, because naturally when you inflate the balloon, it's going to go downstream. And so either having you're anchoring it at the biopsy channel, but also often, the contractile force will actually move the endoscope. So perhaps having the nurse anchoring the endoscope so that everything's under control, and then you have a good dilatation. And I guess the final thing I would say is, it's a dilatation. We have to see some kind of tissue damage. And an amazing number of times I look at a dilatation being done, and okay, we get up to 12, and actually, where's the stretch? Where's the mucosal tear? And unless you get something like that, I sometimes feel we're a bit conservative with dilatation. Vinny, I don't know. Maybe
totally. You are wanting to induce a mucosal injury. I would be more anxious if there was no mucosal injury, that I haven't actually delivered an effective dilation. Talking about size before we go to the next one, do you have a target diameter in your mind that you say, because someone asked me, is it all about the size or is it about how the patient's feeling? Do you have a target diameter, Ruth, that you aim for?
The target, if it's a post-radiotherapy stricture, the target is max 14. If it's post-EMR ESD, then we usually do at least to 16 millimeters. And then if the patient still have complaints, we go up to 8. And if they recur after dilation up to 16, then we go up to 18.
Right, okay. Interesting. So these are the sort of questions that people do ask, and it's very relevant. But we're going to have to move on to the next case. So we're moving slightly away from strictures and malignancy to fistulae. So this is a 79-year-old lady with Parkinson's disease who requires enteral feeding, particularly for her medications in Parkinson's disease. So we see a reasonable number of these patients. She unfortunately developed recurrent cellulitis around an old PEG tract site, raising the suspicion of a fistula, and cross-sectional imaging confirmed a small collection concerning for an ongoing fistula. So what the next video will demonstrate is use of the padlock device to close the PEG fistula endoscopically. So if we can begin playing the video. Okay, so just a reminder about the equipment. So this is a Pentax i10 gastroscope. We're going to be using a Jaguar. We're going to be using a clip, which is an over-the-scope clip made by Steris Medical. And we're going to discuss afterwards the treatment options that are available for PEG fistulae and how we can use an over-the-scope clip to help treat small fistulas such as this. The next case thereafter is something that we're seeing a mini pandemic of sorts around in London, intentional foreign body ingestion. So this is a 27-year-old lady who's been in and out of hospital, actually. On this occasion, she swallowed a sharp razor blade. So brought herself to a local hospital. They put a scope down. Everything looked fine, but when they tried to retrieve the razor blade, they noticed immediately that they'd caused an esophageal perforation due to surgical emphysema. She was referred, I remember this on a Friday night, and had an emergency endoscopy done where this defect you can see here on the right wall was seen. She had a few clips placed, but the defect was too wide to close primarily with clips. And what we're going to demonstrate is the use of endoscopic suturing as a primary closure technique in this case. Next slide. So again, using Pentax gastroscope, we're going to use argon photocoagulation to help agitate the edges of the defect via IRB. We'll be using the Overstitch SX device, which is now Boston Medical, and a few clips at the end of the procedure by Cook Medical. So if we can begin playing the first case of the PEG fistula, which I'll talk over, and perhaps we'll have a bit of interactive discussion with the faculty during such time. So let's talk about PEG fistulas while we wait for that video to load. Something you see a lot of, Raf?
Well, fortunately, it's not that frequent. So most of the time, after removal, it will close spontaneously. But yeah, especially like in elderly patients with poor wound healing, you can run into that problem. We have a couple of cases each year. Yeah.
What are your steps towards it? Do you wait a certain while? When do you think this is persistent or not?
Yeah, time can usually heal. And you can first, if it's very small, you can also try just abrasion first and see if that heals up before you put in any other clips or over the scope clips. But obviously, like if it's refractory to that and it doesn't heal, then this is a very nice escape treatment to solve the problem.
So what you can see here in the distance here is the relatively new insertion of a PEG tube with a jejunal extension there. Yeah. So that's what's currently being used, but there's a NG tube that's been placed through the PEG fistula that's been persistent. So I've mounted the padlock clip onto the end of my gastroscope. There'll be probably a lot of people that are more familiar with the Avesco over-the-scope device than they are with this one. Similar first principles. Actually mounting the padlock clip itself is a lot simpler. It's a lot easier to mount. It doesn't require sort of a through the channels piece of string to mount it on. So a little bit simpler, particularly for those that are beginning to start their procedure. And the deployment is just literally one turn from the outside of the patient. So probably a slightly simpler way of doing the clip. Has anybody here used the padlock device?
No.
No?
So just a practical question here, Vinny. Do you use like a dummy first to try to pass the throat? Because I'm always a little bit afraid not being able to pass the
do you mean like a test cap to see that will get down okay? I don't routinely do that. I think if I do feel significant resistance or concerns around anatomy.
Especially in elderly patients, you may underestimate the fibrosis of the upper esophageal sphincter. So sometimes it's not possible to pass with the device on.
Sure. I think if there were any significant issues with it, we may consider a very gentle dilation, actually, to help facilitate that. In this case, that wasn't an issue. So what we're doing is we've got the fistula kind of on fast now, sucking right down, so till you almost get a red out, a bit like you're doing an EMR in a Barrett's resection that we've seen earlier today. And just from one turn outside the patient, the clip will be deployed very shortly. So very quick. It took about 5 minutes to perform. very safe, but yet risks of causing an injury in the esophagus when you introduce it is probably one of the things you want to watch out for at the start. But I think with a bit of experience on using over-the-scope clips, having a bit of confidence, I think it's a relatively straightforward intervention, I would say. Haven't got time to talk about other mechanisms.
So
right
did you
now.
do some abrasion of the channel as well?
I usually do it. I do usually agitate the tract with a
Yeah.
cytology brush and some APC.
Yeah,
In this case, the defect was so small, I kind of felt it was overkill, to be honest with you. I didn't think it was strictly necessary. And I just went for primary closure with Peg. And she's been absolutely fine. This was performed, I think, about 12 weeks ago, approximately.
Okay.
So a pretty good outcome. So
I haven't used this, but it is a bit appealing. So we're very much in the same as you, Raf. We'll do our best to manage these conservatively and keep hoping, but after a number of months. And I guess, when we look at the patient here, 79-year-old, if it wasn't that she was having cellulitis or an abscess, I would still be saying, conservative management.
Absolutely.
What I like about this, and I've not done this, actually other methods of closures have been somewhat disappointing, whether it's just other clips or, some people are saying we should be using the suturing device as well for these, but we haven't found that to be terribly successful. So, it's quite appealing. I mean, I just wonder whether, technically speaking, one of the things that you had here was you had a clear line on that fistula, but with your Foley catheter in situ. And I just thought you were going to leave the Foley until the very last minute so that you could center your clip right on the on the defect.
That is something you can do. That is something you can do for reassurance. Sure. If you're particularly when you're starting with the device, it may be useful just to keep that in view until the very last minute to make sure you've got it all.
Yeah.
It might be a useful thing to do. I think because it was just so straightforward to access this, it was so on head on. I think you could make an argument for suturing it, but I think that's slight overkill. I think that's a very big piece of kit to do a very small treatment.
And how successful have you found this to be? I mean, I'm interested.
The padlock clip.
Yeah.
We've done a handful of cases, and we've had no patients come back so far. I think a lot of this is about the chronicity of the fistula. I think this wasn't that old. I think if you've got the older fistula, you can bring tissue together however you like, and you'll pat yourself on the back at the start, but they'll come back because the tissue comes apart. So a lot of it is about tissue characteristics and tissue properties, which we'll talk about a bit later with vacuum therapy. It does come down to the tissue. It does come down to microperfusion in that area as well. So you do need to pick your cases. So we're going on to the perforation case here. So I think it's pretty obvious to most at home that that's a significant defect. So here, Raf, like you said, and John, I've agitated the edges of this tract here to really kind of help improve this coming together. So this was done at day 4 after the injury. So pretty within the first 7 days. So this tissue is still pretty fresh. As you can see, the edges are still nice and pink, still nice and glowing. Has anyone else used the overstitch device in the esophagus for this application?
Okay. We've used it for post-surgical fistula. I have to say with limited success.
Sure. I think the real advantage in this case has been how quick we went down. So what you can see now is the end view of the Boston, I should say now, the Boston SX device. So this is a single channel scope. You don't need the historical double channel scopes to use this device, which is increased. So I've actually carefully placed the needle driver and the suture based upon the configuration of the defect. And you can really play with that. I know that they say there's only one way it can go down, but not. You can actually modify it to how you want to place your stitches. So what I'm actually doing there is that's the historical clip that was placed at the time of the emergency endoscopy. And that was placed to prevent propagation of the tear. That was not placed to try and close it. And I'm working just proximal to that. And I think in my experience, the first bite you take is the most important bite because that will define the rest of your treatment here. And what we're doing here is the intention is to place a running suture from the distal esophagus, working our way more proximally. And the first bite I've taken, you can see just at the top there, we returned the suture back to the needle driver. And now I'm going to take the second bite at the lower end of the defect here. So there we go. So I'm just going to, you can see, you can do it very, very carefully. You can really transfer the suture back under direct visualization and pull it back. And if there are different ways you can do this. You could place one suture, deliver your cinch, and then close it, and then carry on repeating that step. But in this case, I had such good ground. It was all going so well that I carried on with one running suture. And sometimes access can be very difficult. So what you see before you mount the device can be very, very different to when you go down with the device on. And sometimes technically it's just not possible, particularly for the surgical leaks, particularly in the sleeve patients. They often leak up in the fundus. And you, by hell or high water, you can't get into that region. And I often have the surgeons with me in the room, so they can actually see what it is that I'm actually trying to do for them. And it's quite good for them to conceptualize that as well. So all about that MDT discussion, all about having very, very close collaboration.
So why did you leave the clip inside, Vinny? Because it would have been easy to take it off.
It would have been easy to take it off. I think I was worried about if I pulled it, making the tract even bigger. I was happy just to leave it in situ to begin with. And I think what happens here is, I think towards the end of it, I almost run out of room with the suturing device. And what I do is I place a couple of clips right up here at the end, just to facilitate kind of closure at the end. So we're just kind of working our way nicely across the top here. And you can, during the procedure, you can begin to tighten your sutures. So you can make sure that what you're actually doing is working. You can kind of sense check what you're doing here. And this is just an extended application of how you would think about closing a poem tunnel, for instance. And
somehow companies should be able to miniaturize this even further, right? To get some more maneuverability and
so there is the X-Tac device, which is through the scope, but that's not really a suturing device. That's more of a you're bringing together. You're not really doing full thickness bites like you are here. So that can be useful for when you're in the duodenum or where there's very tricky to access situations where this device would struggle to get through. This is a big device. And you can see here, it's come together really nicely here. We're coming to the top.
You're doing great. This is you don't have a lot of space to move around. That's really very well done.
Do you do any kind of imaging before? Because you do it really nicely control and you see what you're doing, but just to make sure there's no, like, the relation to the aorta and...
You mean to make sure we're not bringing anything else in?
Yeah.
In this case, not. She's had a CT scan before, so there was nothing that worried us beforehand. Clearly, the procedure is done with the patient tubated and ventilated, and careful kind of control on the airway. But we don't routinely have kind of dynamic imaging on standby, to be honest with you. You do need to be very careful with fistulae. This is not something that I would encourage people to begin closing sort of fistulae. We've seen a few surgical leaks that have complicated with airway fistulae, and that's a very tricky situation. I'm not saying it's the right application there.
So would this still be a good indication for a sponge?
Potentially. So it depends whether you mean intracavity or VAC stent. So that was a long defect.
Or both.
I don't want to jump the gun because we're going to talk about VAC stent very shortly. So that would probably be slightly too long a defect for the VAC stent. So the cutoff was 3 centimeters. And the reality is we weren't using the VAC stent at this stage when I did this case. So we didn't have that available.
Oh, it's not a criticism, just a thought that...
I think because it was so fresh and the tissue was so healthy, I felt that primary closure would be a suitable option in this case. If this was 6 weeks down the line, I think we'd be looking at a very different kettle of fish.
On the other hand, the endosponge data are better if you do it early on for leakages postoperatively.
Yeah.
We don't wait 6 weeks anymore. So,
sure. And what we're just doing here, coming towards the end of this video, is now actually deploying the suture. So we use a cinch device that I've advanced out, that you can see at the 12 o'clock position. And from outside, we'll close the cinch, so the stitches will all come together here.
Well done. Very nice.
This took about 45 minutes to perform in total. So because I was onto a winner at the start, that first bite, I think, will really help. And it's important you get that right from experience. And it's very easy for it to otherwise go south and you'll not be able to finish the closure.
You raised an interesting point that I think clinically we're seeing far more patients swallowing foreign bodies. And I don't know whether this is a UK thing, but a lot of, particularly young women, a lot of prisoners. And despite the best efforts, a lot of, we had one patient locally who was admitted every single day, every day, required an endoscopy to remove a foreign body. And when you challenge them and the authorities, why can't you stop this? They said it's not possible. And in the end, the patient began to swallow parts of the cell. Literally, just I don't know what's happening. So I think we all the key message here is prevention, isn't it? Trying to, taking a razor blade out of this patient along the esophagus is very risky.
Yeah, I'm not sure the technique that was used at the local hospital. We often would use something like a capuchin hood, or maybe even an overtube, to really prevent something like this happening. Where
It can still happen.
Yeah, well, I'm glad it's not just in London that we're seeing a bit of a mini epidemic of sorts. Is this the case?
Yeah, it was. I think this is always very difficult. We try to really have a multidisciplinary approach also with the psychiatrists in these patients, because they're usually known at a psychiatric ward or department, and we tend to not to do any endoscopies. Just keep them conservative, see what happens, because we know that endoscopy also carries a risk every time. So we just do imaging as long as there's no signs of perforation.
Interesting.
We just.
Is that for any foreign body, or is that?
Yeah, even for the sharp and glass, and yeah.
I think that's the inevitable conclusion we're reaching as well, that actually you're facilitating this behavior. The gain is enormous. I mean, I guess the exception, especially for people watching, is if someone's swallowed a button battery, that has to come out. It absolutely has to come out as soon as possible.
Okay, so lot to just talk about there. So we're going to move on to the next case. We've already had a slight introduction to it, and vacuum therapy, and in particular we're going to discuss the VAC stent, and it's really good that Roos is here because you've got the most experience really. But let me present the case for you and talk you through it. So this was and it leads on nicely actually from this morning. It's a 79-year-old lady who was found to have an early squamous cell neoplasia in the esophagus. So she had a 7-centimeter circumferential ESD with an R0 resection. She somewhat inevitably developed a symptomatic stenosis. She had a 10-millimeter bougie dilation performed, and I should add that she had previous dilations that were a lot lower in diameter, but this was complicated by a perforation. She had a temporary fully covered esophageal stent placed, but in spite of waiting conservatively for a few weeks, the leak was persistent on CT. Her inflammatory markers were rising, and we therefore felt that she would be an appropriate candidate for endoscopic vacuum therapy, and we used the VAC stent here in this case. Next slide. So the equipment is a Pentax I-10 gastroscope. We're going to be using a Boston Scientific Jaguar to deploy the stent, and so the VAC stent is manufactured by Microtech, and it's important to say that it's not just a stent. There is a pump that will be needed that will be connected to the vacuum stent, and we've used a 3M VAC Ultra pump here in this case. After the video, Roos will kindly go to the workshop and actually demonstrate a hands-on video of the equipment itself, really, so it gives you more of a perspective. So we can move on to the video, please. So something we're seeing more and more of. So we've talked a little bit about dilation, we've talked a little about target diameters in post-ESD. Have you seen any complications like perforations in this sitting?
Yeah.
And what do you normally do with them, Raf?
Well, we put in a stent first. So fortunately, it's rare. But as you pointed out in the beginning, you need to warn the patient about this potential scenario, which is not unlikely when you embark on a very large ESD. And then, usually there was a stent that we placed, and it passed.
Yeah. So that's just to orientate people. The stent you saw at the start was the old stent that had just been removed. I struggled to find the defect in this case, obviously, but there was something on CT, and what I did here was pass the Jaguar through where I thought the defect.
So this was a delayed diagnosis.
Well, no, she had a stent in, but she was still leaking behind it.
All right.
So I had a fluoroscopic image there to show that the Jaguar were going side by side. So that was for me where the perforation was. What I'm doing here is actually using a contrast bleb just to help delineate where I want the proximal margin of my VAC stent to sit. It's something that I do less of now. I think when you're training in stent deployment, it can be very helpful just so that you got a fixed point to focus on. But as you get more experienced, we tend to use markers in either thoracic or cervical spine instead. So placed a wire down here. So the stent itself, which you'll hear about, it's a 7-centimeter stent in total, but the 5 centimeters in the middle, so that is covered by sponge. And that is going to be sitting over the defect here. So you have 1 centimeter of metal above and below the stent. and you'll be connecting this up to the vacuum pump afterwards. And based upon a lot of the amazing work that Roos, you and your team have done so far, we're using the same kind of protocols really in terms of pressure settings and management after the procedure. So this blue tube that you can see here is what the stent is connected to when it's connected to the pump. And this is the immediate view you get. So it's a relatively short stent. It's not a very long stent, and I think that's why the cutoff is 3 centimeters at the moment. Maybe we can talk a little bit longer whether there's any role for slightly longer defects and are there any ways around that. And this is the immediate view that you get endoscopically. So remember, you will have to reroute this tube now as if you were passing an NJ tube, for instance, back through the nose. But one of the really significant changes that we've seen in these patients, often surgical. So in our experience, this is an endoscopic complication, but about 75 to 80% of the patients we're treating are surgical leaks.
Yeah.
And these patients historically were just fasted and kept nil by mouth for really extended periods of time. And actually, in these patients, we could actually now give them a liquid diet afterwards. It's a bit of a game changer for them.
Absolutely.
Just in terms of psychologically, these patients are often hanging around in the wards for months and sitting there on artificial nutrition for long periods of time. So in this patient, we left an NG tube down because his swallow was slightly unsafe temporarily. But in all the other patients we've done, we've allowed them to swallow safely. And then you'll be aiming to exchange that stent within 7 to 10 days' time. We leave the pump on 125 millimeters of mercury for the first day, and then reduce it down to about 75 millimeters until then. And I think it's really important there's a very clear plan that is relayed to the ward team, because things that are going to go wrong are things about how the pump is being managed. So what do you think so far, Roos, about the vaccine? What's been your experience of it so far?
Yeah, I'm very positive
Yeah.
because we used to do a lot of endoscopic vacuum therapy using the sponge, which was also very effective, much leaks. And then the vacuum stent came, and it sort of combines the best of both worlds,
Sure.
I would say, because you have very effective vacuum therapy because you also create sort of a chamber between the flanges of the stent. And I think because of the vacuum, the stent stays nicely in place, and it has an open lumen. So the patients, so we give them liquid diet on the first day, but just a soft diet the days after. And for life, the patients are really happy with this device, and the results we've seen so far are very good.
Very promising.
And at first, it's so this is a really nice demonstration, I think, of putting it in, which is not that hard, but getting it out can sometimes be a little bit difficult.
A little bit fiddly, yeah.
But once you know the tips and tricks, I also think that's relatively easy. And so I'd say that the results are really good.
Yeah.
I think we can close these type of defects much faster than we used to with endoscopic vacuum therapy, just using a sponge.
Sure.
But you have to be sure that there's no extra esophageal cavity that needs to be cleaned out.
Sure.
So we always combine it with imaging to see if we need to place an extraluminal sponge or not, or if we need to do external drainage.
Sure. So what we showed there was just using a tapered hood to really kind of release the edges of. We've turned the pump off 4 hours before the procedure on the ward, and then we used just a grasping forceps to grab the stem. Now, what I'm trying to demonstrate here is that I can't get my wire through for hell or high leather, and actually a CT with oral contrast the next day was clear.
So
that was only, I should add, she only required one exchange, so she had in total 2 stents placed.
So would this now be your primary treatment for post-dilatation perforations?
Yes.
Especially in the setting of post-endoluminal therapy?
If I'm not able to, if you mean a delayed one, yes.
And when you first see it, or you would put in a regular stent still?
If you first see it, I would actually try to close it, actually.
Yeah, but it's not so. Usually it's not endoluminal therapy. There's a lot of fibrosis. Clips, and these tears are usually deep, so usually it doesn't work with a clip because you have fibrosis, and then you will not be able to deploy the clips adequately.
Yeah, if you can't get primary closure, then I would I would probably, from our experience, we've done about 15 patients so far.
So rather this than the classical stent to seal off the defect.
Yeah.
All right.
I think so. I think we've seen very positive outcomes internally ourselves. Bruce is a slightly larger data set, and it's very, very encouraging. And I think this is going to be gaining traction. But you've got to work with your surgical team. You've really got to get them on board. But they've seen the fruits of it already far, and it is rather labor-intensive. So remember, I always tell people, when you place this stent, you need to know when you're going to exchange it.
Yeah.
You need to make sure you're not going to be sitting on a beach next week and you're not the only man that can do it. So you need to make sure there's a service that can facilitate this.
You definitely need more people to do it.
You need more people to do it, yeah. So that's important. I think what we're going to do now is head over to the workshop where Bruce has moved to really demonstrate a hands-on experience of the vacuum. Move to the workshop now.
Yes. So I'm here with the vacuum stent. This comes in a big box, as most of these esophageal stents do. Stent with the releasing system, the blue tube for the suction, and a Y connector, which you need to connect the tube to the vacuum pump, which is really important to apply good suction. The first thing you need to do when you take this out of the box and before you introduce it is that you need to flush the different channels of the vac stent. So first you flush the blue channel. There's this very handy purple connector you can put at the end. Just use a luer lock, flush this with some water. Then you take this purple connector off and you put it next to you. You need that once the tube has been rerouted via the nose. What is important then is also to flush this channel that facilitates deployment of the stent later on. And you have to flush this channel, which is the channel that is used to put the guide wire through. So once everything is flushed and the guide wire is in the patient, you need to remove this iron thing from the stent. This is just for packaging, so it stays straight. Once that's out, you have the guide which you introduce in this blue piece here at the end. Comes out at the other end, and just as you would do with a dilator or another normal stent, you introduce the stent into the patient. If you are then happy with the position, either based on your endoscopic view or on your screening view, as was nicely demonstrated in Vinny's video, you can ask the nurse to sort of deploy the stent. It's a distal release system. So usually I do it under endoscopic visualization. So I put my endoscope in the patient next to the stent, and you can really nicely see deployment of the stent. This orange connector is then just released. The nurse holds the stent, and you can then deploy the stent by pulling back the left hand in this case. And if you have the end of the stent, so the other end in the video. So if you can move the camera to the other end, so I'm just pulling my hands together, and what you can see happening is that the stent is deploying. And you can stop anytime and reposition it, and then you just go on. And there's a sort of point of no return here, because if you continue, the proximal flange will also deploy. Then the stent is in situ, and you can remove the whole connecting system, making sure the blue tube stays in place, because that's connected to the stent, and you don't want to pull that. So it's just like with ERCP, you take out the connecting system or the introduction system, but keep the blue tube in place. And as I said, the stent is 7 centimeters long, and this part is 5 centimeters. That's covered with the sponge on the outside. The diameter is 14 millimeters, and the flanges are 3 centimeters. So that's also good to have in mind if you're working in a narrow esophagus, for example. And once you have placed it, you can immediately connect it to the vacuum, and then the stent will even deploy further. I will just do it a little bit with my fingers, and you can see, put it down a little bit. how it looks. And you can endoscopically check if it's in place. I usually say that it's better to place it a little bit more distal because you can always pull it back a little bit. It's more difficult to push it in. But actually, that's the demonstration of the vacuum stand.
Thank you, Roos. That was really elegant. So we've only got a little while to wrap up. Raf, what do you think so far about what you've seen with the vacuum stent and vacuum therapy? Because you've obviously got a lot of experience with it before in just endoluminally. Do you think it has an application, and in what space would you recommend it for?
Yeah, I think, as you said before, probably in the past we were way too long and hoped that things would heal up by itself, which then creates hard to treat fistula. So at least with the vacuum therapy in general, we now move to early deployment whenever we have, like in most cases, a post-surgical complication. And I think the vacuum stand in itself is very, very elegant. I think it has a great potential there because it seems easier to position that than in comparison to an endosponge, also for smaller defects where that to get at the right position.
Yeah, Roos has kindly come back into the debate. You've used this a lot, probably more than most. What are the sort of, if you had to give 3 learning points about your experience so far, about when it can be used and what's really important to consider and what can go wrong, what would they be potentially, Roos?
I think before you start, you really... So what we see is that a lot of centers start with cases where everything is so those are the most difficult cases who will probably also not respond well to vacuum therapy using the vacuum stand. So if you want to do this, just start with the post esophageal surgery leaks, etc., or small iatrogenically, just to not start with the most difficult cases. And familiarize yourself with the technique, like the placement, practice it, look at videos. I think you have made a really nice demonstration and also pointed out the fact that taking it out can be difficult. So the first case I did, I was told, well, taking it out is really easy. And I spent like 3 hours on that case, and I was a little bit fed up. Now I know the tips and tricks. I always tell people who do it the first time, you have to be using the conical cap, put the pump out like a couple of hours before, etc., etc. I think if you are prepared really well, it's actually not that difficult with your team. And I think we usually, like for us, it's for all the leakages, boerhaves, and perforations, this is our therapy of choice. The only reasons not to use this is it's really high up in the esophagus. So if there's no room for compared to the sphincter, because that's also taking it out can be really difficult. Any tears that are longer than 5 centimeters, we do not treat with the vacuum stent. So we don't use the 3 centimeter cutoff, but we use 5 centimeter cutoff. And the most important thing I think is that you should really do this multidisciplinary with your surgeons. So all the defects, we always discuss them with our surgeons. See if there's an indication for imaging, external drainage, if the progress is well, because if you have someone else doing the procedure every time, it's difficult to keep the progress and healing tendency in. So I think that's something you should pay attention to as well.
Great, and I think you've created a really helpful endoscopic vacuum therapy academy.
Yeah.
Little plug here, but I think it's really useful with tips and tricks, protocols and steps to follow that we've been using really to help get the service off the ground. And I think it's really helpful for those that are wishing to embark upon startments. Great, I think we're going to have to call this session a wrap now. We could keep talking for a while, but we'll have to move on to the next session. So I'd like to thank all the faculty for their time, and we will see you after a very, very quick break again. Thank you.
2.
We're now going to spend the next 10 minutes using an opportunity to discuss the management of uncontrollable life-threatening GI hemorrhage, and in particular focus on an increasingly important and higher number of patients that are now using direct oral anticoagulants, and an update on how we can manage these patients better within the GI space. So these are my disclosures. It's important to state that we will be discussing andexanet, or the brand name Ondexia, which is a licensed reversal agent for life-threatening bleeding, both in intracranial hemorrhage and in the gastrointestinal tract. It's NICE approved for life-threatening GI bleeding. So I'm sure you will all be aware that multimodal endoscopic therapy is now the gold standard therapy for GI bleeding, whether you want to combine injection therapy either with mechanical clips or heat-based therapy, or take things further with using an over-the-scope clip or hemostatic powders. Whatever you choose, endoscopic therapy is the gold standard. However, the management of GI bleeding begins before the patient gets to the endoscopy suite, and the most important aspect of management is adequate resuscitation of the patient, so that has been shown to improve outcomes in patients with GI bleeding. Why am I talking to you about this? Well, we know that there's an increasing use of DOACs within the general population, and DOACs are now essentially first-line therapy for thromboprophylaxis in patients that have atrial fibrillation, whether you give apixaban or rivaroxaban. What's really important, and these are some data from randomized trials that were comparing apixaban and rivaroxaban respectively with warfarin, is that the overall major bleed rate is not insignificant, so 3.6% for apixaban and 5.5% for rivaroxaban, but GI bleeding was the most common bleeding outcome event for patients taking these medications. So this is relevant to us as a community of gastroenterologists. And this further supports that actually GI bleeding was more of an issue in patients using DOACs compared to warfarin as well historically. So something that we need to know more about. Based upon that, however, the only real recommendation that we still have is that patients that present with GI bleeding that are on a DOAC is to temporarily interrupt the therapy. Now that's based upon the premise that these medications have relatively short half-lives, particularly when you compare them to vitamin K antagonists based upon a normal renal function. Unfortunately, routine measures of clotting are not helpful in patients taking some medications, but based upon this rapid half-life, fortunately, the vast majority of patients, that is enough. They don't require specific reversal therapy. Based upon this and some real-world registry data, andexanet alfa is now approved by NICE for the use of reversal in life-threatening or uncontrolled GI bleeding. Now, what is andexanet alfa? Well, simply put, as a gastroenterologist, this is a recombinant modified decoy molecule for anti-factor Xa. So it sequesters the active drug and actually takes it out of the circulation with a half-life of about 5 to 7 hours. This is some early randomized data in patients taking both apixaban and rivaroxaban, just to show in healthy volunteers that the drug rapidly brings down the level of anti-factor Xa activity very abruptly in both cohorts of patients. This also demonstrates that you're able to restore thrombin generation as well, which is obviously critical in patients with GI bleeding, where you want to slow down the bleeding before you get them through to an endoscopy or relative treatment accordingly. Based upon these scientific data, a prospective study of nearly 360 patients was performed, looking at a wide cohort of patients with either intracranial hemorrhage or gastrointestinal hemorrhage that were treated with andexanet alfa. Approximately 25% of patients had GI bleeding, and the primary indication for anticoagulation was atrial fibrillation in nearly all cases. So this was measuring the change in anti-factor Xa levels and clinical hemostatic efficacy as judged by an independent panel. Adverse events that were measured were thrombotic events and 30-day mortality. So in this study, the overall rate of good or excellent hemostasis that was achieved was 85% within the GI space. And the definition of this was really based upon hemoglobin characterization. So patients that had a less than 10% or 10 to 20% decrease in their corrected hemoglobin were deemed to have a good to effective outcome. We actually had quite a mixed cohort of patients in terms of bleeding site. So a bit of a mixed bag. These weren't predominantly upper GI bleeds. Some were lower GI bleeds, but also there was a mix where it was unknown as well. So that's clinically relevant to take into your practice. This is a receiver-operated curve showing that the anti-factor Xa levels didn't really correlate very well with how patients did, and therefore some form of point-of-care testing is needed. One concern for patients often, for clinicians, is the thrombotic event associated with this medication. So the overall thrombotic event within 30 days was 10%, but what's really important to drill down into is that if patients were restarted on their oral anticoagulation after their GI bleed was treated, the thrombotic event was next to zero. We have to remember you are going to be using this medication in the face of a life-threatening GI bleed, where your primary aim at that stage will be to slow the bleeding down. And you're always going to be faced with a dilemma regarding thrombosis. But at that point in time, if you are faced with a sick patient that's critically unwell with a life-threatening GI bleed, you will want to do something to slow down the bleeding. This was an indirect comparison of mortality based upon the Annexa 4 study, which I described, but also a historical study called the Orange Registry, which looked at the management of all bleeding in the UK. This was comparing 4-factor PCC. So remember, 4-factor PCC just contains clotting factors. It's not a reversal agent. So you hope the difference between the two is, one, you are just replacing clotting factors, whereas with andexanet, you're actually reversing the actions of the drug itself. And it showed that there was a significant reduction in mortality in that group. There's also now some real-world data. So this is across nearly 5,000 patients in the States that shows that there was a 50% lower risk of in-hospital mortality in patients that were treated with andexanet in GI bleeding compared to 4-factor PCC. So what's really important is, how do you pick your patient? So who is the patient that's having a life-threatening GI bleed? And I think that's one of the biggest challenges that we have as a community of physicians and gastroenterologists. So there may be some risk factors that you can detect at the front door. So patients that have a history of malignancy or portal hypertension, you may want to have a lower threshold. Patients that present with hematemesis, so frank, bright red bleeding. Those that are shocked in spite of resuscitation and often may require high-level care to intensive care. And perhaps a hemoglobin of less than 80, although that's a slightly softer one, I would argue. You could use clinical risk scores. These are all available at the front door. This is a Muse chart that may be useful to help detect a sick patient or one that is deteriorating. So very simple things that can be done. We know that a score of more than 7 predicts a higher level of care, may be useful in your decision-making process. We're all aware of scoring systems. So the Glasgow-Blatchford score is probably one of the more commonly performed scoring systems by the acute medical team or your A&E physicians. It also has a very important utility of actually helping ambulate patients that have a score of 0 or 1. The Rockall score, a little bit more historic, has a composite score that is both pre and post endoscopy and can predict mortality. And all of these scoring systems should be incorporated within care bundles that should be delivered locally within each institution that you work. And all these factors can really be brought into play when you're thinking about picking the right patient that is suitable for reversal therapy. A lot of work has gone into this space, and this was just a figure demonstrating a Delphi consensus panel that I was part of to help define life-threatening GI bleeding. So we looked at signs of and symptoms of hemodynamic and hypovolemic shock, so altered mental status, hypertension, pallor, people that are needing higher-level care that haven't responded. And bear in mind, patients that are at higher risk, the patients with heart failure, kidney disease, or even advanced malignancy are probably more at risk of coming to harm. The recommendation from this Delphi consensus was to administer reversal within 1 hour. I think that's a very ambitious target, but if anything, this should just focus the mind at the front door of people encountering these patients. So this is something that's been put together on the backdrop of everything I've just discussed. So if you see a patient with a GI bleed and they are on a DOAC, you want to resuscitate them first. And if they respond, you can move to the right-hand side of this algorithm and they will just have their standard medical management and usually need an endoscopy within 24 hours, assuming you can't ambulate them. If they're not responding and they have ongoing hemodynamic instability, so you can use a shock index, a News score, or even a Glasgow-Batchelor score, in combination with hematemesis or a history of portal hypertension, you might want to then have a consideration or a discussion about reversal with andexanet alpha, followed by definitive endoscopic therapy. And that's the key here. This is not instead of endoscopy. This is a measure to resuscitate patients to make endoscopy safer and help improve outcomes. This is a busy slide, but it's just an example of the protocol that we've developed at University College. It includes all the signs and symptoms that people need to look out for in these patients, and also how to administer and draw up the drug. Therefore, I would argue that andexanet alpha still does not replace the need for standard medical therapy. Just go back a slide, please. Life-threatening GI bleeding, please consider that in patients with persistent hematemesis or hemodynamic instability. You are looking to give the reversal therapy before endoscopy to resuscitate the patient, and perhaps incorporating it within a major hemorrhage protocol may be part of that process. And if you're thinking about giving it and you're not a gastroenterologist, then you need to call your gastroenterologist, because they will probably need to go to endoscopy at some point. So resuscitation is paramount, and it remains the cornerstone of therapy. The vast majority of patients do respond to medical therapy, and everyone will need an endoscopy within 24 hours. Do consider andexanet alpha in life-threatening GI bleeding, provided you've had that senior decision-making process that's taken board. If you want to get more information or know about any future events in this space, please follow this QR code, where you can sign up to newsletters from the team and find out about getting more information about andexanet alpha itself. And this is just a final holding slide with the SPC of the drug itself. Thank you for your time. Always go straight into a case just to set the scene. So this is a patient who presented to their local hospital with a life-threatening upper GI bleed. So hemoglobin of 50, shocked, not responding to resuscitation measures, requiring higher-level care. Quite polycomorbid, with recurrent DVTs being the indication for a DOAC, with a history of lung fibrosis. They had treatment at their local hospital with clips and injection therapy, but re-bled, so were referred to University College Hospital. So we're going to move into the video now.
You can see a cratered ulcer on the lesser curve, with a visible vessel with an overlying clot indicative of the recent bleed. You can also see two endoscopic clips placed, which you can see are not on the area of the visible vessel. Given the refractory nature of the bleed, the decision was made therefore to try and place an over-the-scope clip to try and get endoscopic control of the repeated bleeding. So, prior to removing the clot, the first step is to inject the area with 1 in 10,000 adrenaline, and you can see this being performed here. This is to allow safe removal of the clot, if we can, to expose the vessel and apply treatment. However, you can see following the endoscopic injection of adrenaline, the lesion itself begins to bleed quite obviously, and you can see a pulsatile bleed there. Therefore, we can see really where the bleed is coming from, and also probably that it isn't safe to remove the clot itself. However, in order to apply a over-the-scope clip, we certainly need to remove these previously placed endoscopic clips. Therefore, a stent grabber is used to pick up the clips and remove them from the area. And you can see this is done here. Once the two clips have been removed, we then remove the scope and attach the over-the-scope clip. You can see the vessel is bleeding. We place the over-the-scope clip onto the end of the scope itself, ensuring that it is pushed in place with the thumb on the end of the cap rather than holding the sides, as this can cause problems with the delivery of the clip itself. The scope then is placed back into the stomach and manoeuvred into position. We will maneuver the scope towards the area of the visible clot and then suction the area into the scope. Once we are sure that we're in the right place, we then can twist the wheel and apply the over the scope clip. You can see here that the clip has been placed in the right position. However, despite that, the vessel continues to bleed. At this point, it is clear that the bleeding is refractory to endoscopic therapy with clips. Therefore, the decision was made to switch now to hemostatic powder, and we use Next powder from Medtronic to try and gain control of the bleeding area. Next powder cannula was passed through the scope, and the lesion was sprayed in order to try and gain hemostatic control. Using the adjustable bar on the device, you can see we're able to control the speed of the application of the Next powder and therefore maintain good views throughout and ensure we get good coverage. We also know, given this lesion's on the lesser curve, that we need to also approach it from the top, and therefore we then maneuver the scope round, and again we're able to restart the Next powder using the toggle and ensure we covered the entire lesion. You can see, following application of Next powder, that we have successfully stopped the bleeding. Given, however, the numerous large bleeds this patient had undergone, she then went to interventional radiology later in the day and was found to have an aneurysm of her left gastric artery, which was clipped. So an example there of a really refractory bleed, and then the use of hemostatic powder to really help us. And we used the Next powder made by Medtronic, and I just wanted to demonstrate the device. It's very easy to put together. So it comes with three parts. We have the handle, then we have our catheter, and then it comes with a little silver packet that has a nice little vial here of the Next powder. So in that video, I talked about the toggle, and one of the key factors here is that you can control the speed of the powder being released by just moving this toggle up and down. So you can have it on full power here, where it's all the way up, and then you can just reduce it up and down to control your speed, which allows you to keep the visibility, control your application of the powder. What I'm going to do now is just put the device together, and you see it's very simple. You just simply slide the device in here, and then unscrew your silver little powder. And the thing to remember here is don't tip your powder upside down and spill it all over the floor. Maneuver your handle upside down and just simply screw it into place here. Once you're fully screwed into place, there's a little black piece of paper here you just have to pull out so you can get ready to use. And then there's an on button at the back here. And this, you'll now start to hear a loud noise, and this is the air that they pump through the catheter. I'm going to switch it off temporarily. So that air pumping through the catheter stops the catheter from blocking as you're going to apply the powder, which is a really key thing. We all know on sort of first generation hemostatic powders that you end up getting blocked catheters quite regularly, and this allows you to avoid that complication. So I'm now going to show you the application of the powder, so I'm going to put the noise back on. So this is the catheter applying through here, and this is where see if I can coordinate my hands. So I'm going to switch the toggle on. The spray is coming out here onto the powder, and I can control the speed. I can slow it down there, and I can speed it right back up. So it's a really great device for controlling refractory bleeds, and it's something that we are increasingly using in our practice. So back to Vinay and the guys in the studio.
Thanks, David. Back in the studio now, just to say that we've had a slight change around in faculty. So Professor Bandari, Dr. Jonathan Potts and Dr. Morris are back in the studio with us. John, I'll come with you. When I think of GI bleeding, you come in my head straight away.
Thank you.
I must admit. So we talked a little bit at the start about GI bleeding. What are the main challenges with GI bleeding in 2024 that you see? Because you've had so much experience in this field. Where is there still room to improve? And what is your thoughts about DOACs? Have you seen more patients coming in with DOAC-related bleeds?
So, well, thanks, Vinny. Hopefully not bleeding that I've caused. Yeah, I mean, I think the focus now is moving a little bit away from the therapies to really appreciating if we're going to make an impact in terms of the mortality then it's managing the comorbidities. And yeah, we're seeing so many more people who are on DOACs. It's an everyday occurrence. I think sometimes we get it wrong, so we delay endoscopy, thinking that we need some time for reversal. I mean, absolutely, you know, the clinical case that you described, an unstable bleeder, absolutely great to have adenexate in the armamentarium. So I think for me the challenge is around getting the basics right, and we're going to talk about that again in a minute. We realize that as a gastroenterologist, there's actually quite a small part of the clinical care that we deliver, and we assume that everything else is going to be delivered well. So not only it's about managing patients on DOACs, but it's also being sure that we don't get an unintended consequence of the teams in the ward forgetting to restart the DOAC. So you mentioned thrombosis risk, etc. So I think it's getting the basics, it's identifying the high-risk patient, it's making sure they're resuscitated, so I completely agree with you. And then endoscopic therapy, and I think we're perhaps moving, the newer technologies are really changing the whole paradigm here, and beautifully shown, great case. But actually, there's decision making, so it's the non-technical skill part of GI bleeding that I think is critical. Why would we choose a clip on a high Lesser curve, chronic deep ulcer like that? Might we expect that to be the best therapy at the outset? And even then, moving on from there, and we'll come back to this, is if you get to a point where you've delivered more advanced therapy or a rescue therapy, you need to have a clear clinical plan for what's going to happen if you get rebleeding. So lots of things to discuss.
Sure. So Jonathan, in terms of next powder and hemostatic powders, have you had much experience in using them? And I'm going to ask you a probing question because of your interest in liver disease. Do you think there's any role for them in that remit or not? Because there is mixed data on that.
Yeah, I have to say our primary use of these powders is normally more diffuse bleeding, tumour bleeds. I know there are some data on the use of them in portal hypertensive bleeding, but I think more as a holding measure rather than any kind of definitive therapy. So from a sort of portal hypertension perspective, I think the established techniques of banding and glue embolization still stand. So our use of them is in more diffuse bleeds, and as I say, in tumour bleeding, I think they work well. I think there are limited data on portal hypertension, but beyond that, I'm not sure they're not part of our sort of first line treatments anyway.
Sure. And Pradeep, what do you think about hemostatic powders? Do you think we should be moving to them first line, or do they still form rescue therapy, so to speak? What do you think about it?
I still feel that they are rescue therapy because almost all the data suggests that the rebleed rate is quite high. So I think they are very important rescue therapy. Also, we have all grades of endoscopists. Some have great experience in dealing with bleeds, others don't. So it just helps standardize the management. If you're really struggling, if you have a powder like that, you control the situation, and then you go back with an elective attitude to treat the bleeding point. I think this is where there is a gap.
Sure.
In understanding that, I sorted out, the bleed is controlled, but then they come back again because you didn't follow it up. And I think for the near future, it will remain like that.
Sure. I have to ask you, what are your thoughts on topical hemostatic powders after ESD? Potentially, do you think there's a role for it?
The powders are a problem during ESD. The majority of the bleed in ESD EMR is intra-procedure bleed. If that bleed, you use a powder, you almost have to abort your procedure because you cannot carry on. So I don't think they have a role in that bleed. In order to prevent the delayed bleed in them, I'm not sure a majority of these powders work with blood being there as an essential component to activate. So if there is no blood, it doesn't last very long. So I think there are other topical hemostatic agents like Purostat, which doesn't need the blood and they stays for 4 or 5 days. So this is an evolving field, and I think we'll see a lot more products coming in this field with that intention of prevention.
Sure.
So at the moment, we are in a therapeutic just treating. Prevention is a different game.
Sure, thanks Pradeep. Okay, so I think we're now going to move to Dr. Morris, who's going to give us a talk on an update on GI bleeding, including the incorporation of care bundles. So over to you, John, please.
Well, thank you, Vinny. When I was asked to address this, one of the issues that I thought is that this was perfect timing to emphasize not only the importance of endoscopic treatment, but more importantly, the care that we talked about a moment ago. So I just want to talk a little bit about the work that we've been doing with care bundles here in the UK, and how we believe that the care bundle is critical to the improvement of the management of patients with upper GI bleeding. Now, you might be forgiven for asking, what is a care bundle? So let's just nail that straight away. It's a small and relatively straightforward set of practices that we can, as a group, implement and reliably and continuously improve the outcome for our patients. So if you like, the ambition is really clear. And why do we need one? Well, GI bleeding remains a major cause of mortality. In terms of GI emergencies, absolutely, it is the par excellence cause of mortality of virtually everything that we do. And when you compare this with other medical conditions, GI bleeding is way ahead in terms of mortality. So the message is we have to do better. We have to improve the care for our patients with GI bleeding. And whilst we might think that the trend is for reduced mortality, I want to share with you our BSG audit data from 150 hospitals across the UK, done last year, nearly 4,500 patients. And some key messages. Firstly, if you'll see at the top of the slide, the overall mortality is remaining unchanged at 8.8%. What I think we're seeing, though, is there's a clear dichotomy, which is getting more so, and that is that a patient who is newly admitted to hospital actually has a remarkably low mortality compared to the patients who are inpatients. So the kind of patients we're going to hear about in a moment who have liver disease, the patients on DOACs, and look at the mortality. So across the UK, 20% mortality if you have an inpatient GI bleed. So what can we do to improve that? Well, just to remind us, we're all enthusiastic endoscopists, but essentially endoscopy is a component part, but not the only part of a successful outcome for our patients. We need endoscopy to make a diagnosis, to deliver effective endoscopic therapy, but nevertheless, there's a lot of other key components to patients' care. And if you want to review all of these, I would refer you back to the ESG guidelines update that was published in 2021. And let's just reflect on the patient journey, because that's critically what we're talking about this morning. And Vinny has highlighted the importance of resuscitation and risk assessment. That's not happening with a gastroenterologist. That's actually happening at the front door of your institutions. And then the other things we've got to think about, whether it's DOACs, whether it's clotting, antibiotics, terlipressin, we'll hear more about. So actually our contribution as gastroenterologists to the pathway is actually quite slim. But what's really important is that we have to be, and I'm going to come back to this, is really clear about how we're going to follow up these patients and that we have a rebleeding plan. So I was fortunate enough to lead with colleagues on the UK Upper GI Bleeding Bundle. And essentially this is broken into 6 domains, the 6 Rs. And I just want to go through some of these with you. And particularly I want you to focus on this slide. Time doesn't allow us to go into all the components, but really important messages here. So the first one is, we all know that we should be restricting blood transfusion in our patients with GI bleeding. And yet, many times we see that patients receive inadequate fluid resuscitation. So simply at the front door, we're reminding our colleagues that to actually start IV fluids is important. And then the restrictive blood transfusion. Now, why do we suggest restrictive blood transfusion? And you'll see here, and I brought this into sharp focus on this slide, we're actually aiming to transfuse if the hemoglobin is below 70, aiming for somewhere between 70 and 100 as the optimum. And how well do we do that, and why do we do it? Well, studies such as this from Villanova showed that actually the outcome for patients in terms of rebleeding and mortality in a restrictive blood transfusion policy is significantly higher or improved than a liberal blood transfusion. So I think that case is made. But how are we actually doing in clinical practice? Again, I'm just going to show you that there's a big divergence and hopefully convince you why we need bundles. So again, this is data from our UK audit carried out. And you can see when we looked at the patients based on either their hemoglobin, nearly 50% or slightly more than 50% of patients are being inappropriately transfused. And what's most worrying when we look at this, that there's a significant amount of blood transfusion is being given for patients with a hemoglobin over 70 who are hemodynamically stable. So there's work to be done to improve our overall care. Now, why is that important? Well, if you look on the left-hand side of this slide, you'll see that actually blood transfusion adversely in our audit affects outcomes. For every division of the Glasgow-Blatchford score that Vinny alluded to, you can see there's a higher risk of rebleeding if you give a blood transfusion. And actually, when we look on the right-hand side of this slide, you'll see that actually the tendency is towards increased mortality. So the UK Bleeding Bundle, the second part of this that I just want to focus on is the review of the patients. You'll see that actually we're no longer recommending that patients should stop all of their antiplatelet treatment. And again, it's this avoiding the inevitability of a complication of their medical therapy. So we're advising to continue aspirin, but to suspend other antithrombotics. Those words are carefully chosen, because if we suspend antithrombotics for too long, then the patient's risk of thrombosis will go up. And finally, I just want to talk a little bit about the review. And we really want to ask ourselves as endoscopists, what are we doing to contribute to a successful outcome? We're clearly mentioning here the importance of a good quality endoscopy report, and we'll come to what that might mean in a second. PPIs if there's high-risk bleeding, and a post-hemostasis antithrombotic plan. This is interwoven into everything that we're doing. And so this is the overall bundle. The plan is that this is, and it's freely available on our websites, it's been published in Frontline Gastro. The idea is that this is completed within the first 24 hours of admission. You do not need to be an expert in managing GI bleeding, but all of the important components to avoid harm are here. And this can be incorporated in patients' electronic notes, and the hope is in the future this will be incorporated into our endoscopic reporting systems, and hopefully for a better outcome. But how do I convince you? Well, we actually, in Scotland, we asked our trainees to implement this bundle across all of the hospitals when we first brought the bundle forward. In 2018, we studied the outcome of GI bleeding for 6 weeks before and 6 weeks after implementation of the bundle. Now, I can't give you all of the outcomes, but I just want to share a couple with you. Obviously, we publicized the use of the bundle in a multitude of different ways. So does it change behavior? Well, here's the evidence that it does. So if we just take a simple outcome such as the Blatchford score, there was significantly more accurate recording of the Blatchford score, which we know is an essential component of assessment before and after the bundle was implemented. And it was directly related to the use of the bundle rather than the generic awareness that there was an audit ongoing. And what about target hemoglobin? Again, absolutely clear that there was a target hemoglobin set and achieved more after we implemented the bundle than before, and particularly if the bundle was used. So overall showing us that bundles do work and that we should be trying to advocate for their use. I just want to stop in the next minute or so, but to bring the final part of this discussion, and that is, what is a good upper GI bleeding endoscopy report? Well, you would expect, wouldn't you, that we would accurately discuss the Forrest classification. I think it's also important to mention things like access to the lesion. So the case we've just seen, high lesser curve ulcer, always going to be a challenge. We would like to know why that endoscopy failed, and the confidence of the endoscopist as to whether they've achieved hemostasis or not, because that will then define how we advise to restart anticoagulation therapy. Of course, we want recommendations on the use of PPI, antithrombotic plan, but I think it's also important to be clear about whether the patient should have Helicobacter pylori eradication, are we going to continue PPI long term, and so on. And clearly a statement as to whether it's realistic to expect that a repeat attempt at endoscopic therapy would lead to a successful outcome. So thank you for your attention.
Thank you, John. That was a really excellent synopsis of GI bleeding and the challenges that we face at the moment. John, I'm going to come to you. I have a bit of an interest in antithrombotics and resumption of anticoagulation in patients after GI bleeding. I think John's already highlighted it, how it's important to have an anticoagulation plan. What are the sort of thoughts that go through your head if you're faced with someone, for instance, with a duodenal ulcer that's required combination therapy with epinephrine and some clips, and they were on a DOAC valvular heart disease potentially. When would you think about restarting the medicines, and what would your decision be based upon if you were doing the endoscopy?
Yeah, it's a good question. I mean, as a general physician and hepatologist, my sort of view is that this is obviously bespoke to that individual patient, balancing the rebleed risk versus the risk of thrombosis. In the main, it's easier to deal with rebleeding than it is to deal with thrombotic events, particularly cerebrovascular accidents in liver. The patients are actually generally prothrombotic despite their coagulopathy. So generally, I think earlier resumption of these agents is probably preferable. You may want to defer a NOAC for a few days with heparin cover if you're concerned about the patient. But I think in general, bespoke to the patient, but probably erring towards earlier resumption with agents that one can stop if there is rebleeding.
Sure. Okay. And Pradeep, what are your kind of approaches to patients to anticoagulation? Clearly, you take precautions before resections, but are there certain medications that worry you more than others in your experience?
Well, I think resection field is a little bit simpler in a way. If patients are on double antiplatelet agent, we would stop one of them, preferably clopidogrel. DOACs we always stop. But then when we know that the patients have to go back on it, then invariably we will perform a defect closure. And if we are happy that we've done a good job with defect closure, then I don't have a problem in patients starting almost immediately or next day. But that's not always possible because it can be a very challenging area to achieve closure. But majority of these bleeds happen within 24 hours. So for me, 24 hours is the area time period. If you pass that, you should be safe to take it.
Sure. And just one last question before we go to the final talk, but thanks for coming back, John. So training is obviously critical here. Trainees clearly want to get experience in managing GI bleeding, but is there a system in place or something that will come that will reinforce kind of DOPS or KPI data with GI bleeding for trainees coming through, including report writing? What are your thoughts on that in terms of from a society, from a BSG point of view?
So this is very much one of our focus at the moment. I think there's two elements to this. One is access to training opportunities. And I think it's very unfair for our trainees to not be able to access that. So you have to organise the service to allow that training to occur. So that might be having a fixed time in the day when these patients with bleeding are done. I think we are probably, in the UK certainly, we find it difficult to have trainees on bleeding rotas because of hours of work and so on. But you can still deliver a lot of endoscopic therapy within hours. We know that actually you don't need to endoscope patients in the middle of the night. They can be done in the morning once the patient's been resuscitated. We've already developed a one-day bespoke GI bleeding course, and we're just in the process of updating that. As the technology changes, we have to keep up. But it's not designed only with trainees in mind. I think there's quite a lot of consultants and senior physicians who also haven't become familiar with the hemostatic powders or with the over-the-scope clips. So we've had very positive feedback in that sense. In terms of monitoring a trainee's progress, I mean, I think there's two things. We know that, for example, in the UK, we've got JAG and we have DOPS. There are GI bleeding DOPS available that all trainees can use. And some really nice data that showed that if trainees used a structured DOPS, which is available to them and to their trainers, the feedback was much more constructive and much more structured. So I think if we as clinicians are doing bleeds with the trainee, we should be encouraging them to use the DOPS. And the final thing is there's an absolute desire from our trainees that we find a path to certification of competence. It's almost, well, you've heard me saying before, it's almost nonsensical that the procedure with the highest risk of death or the condition that we as clinicians don't have to demonstrate competence. It shouldn't be a punitive thing, and there's a map that might be that this is an option to start with, but the trainees are asking for this. It's not that we're forcing it on them, and we understand there are constrictions on time and training and all the other things, but this is important. If you're going to be on a GI bleeding rota, you want to be happy that you can deliver all of the therapy.
Yeah, thanks, John. That was really helpful. So we're going to move to the final talk of the morning now with Dr. Potts, who'll be giving us an update on the management of portal hypertension and prophylaxis of variceal hemorrhage. Over to you, Jonathan.
Thanks, Vinay. It's a real pleasure to present to you on the management and prophylaxis of portal hypertensive-related bleeding. So I've got no disclosures. I'm going to whip through a little bit of background on the change in the paradigm of portal hypertension. That influences who we survey and prophylax. And then I'll focus the talk on acute variceal hemorrhage, both esophageal and gastric varices, and then a few hints and tips. So there has been a paradigm shift in the last 7 or 8 years. And this is just to show the difference between the 2015 BSG guidelines in who we survey for portal hypertension and gastroesophageal varices to the new Baveno and ESGE guidelines as of 2022, and the concept of advanced chronic liver disease as a spectrum of fibrotic liver disease with different stages of compensated advanced chronic liver disease separated by the presence or absence of clinically significant portal hypertension. And that's defined by an invasive hepatic venous pressure gradient exceeding 10 millimeters of mercury. But obviously that's not available in a lot of different settings. And we now have extremely good non-invasive tools, largely based around elastography, that can categorize the risk of your patient. And so using a liver stiffness measurement and simple blood parameters like platelet count, it is possible to characterize patients' risk. So just to remind you, in most etiologies of liver disease, cirrhosis is defined by a liver stiffness measurement exceeding 11.5 kilopascals. If you have a patient with cirrhosis whose liver stiffness measurement is less than 15 kilopascals and whose platelet count exceeds 150, then there is a very high negative predictive value for the presence of varices. So these patients are unlikely to have varices, and as of these guidelines, they do not require surveillance. The converse of that is that there's a very high positive predictive value in patients who have a liver stiffness measurement exceeding 25 kilopascals, and these patients should actually receive non-selective beta blockers without any endoscopic surveillance. So we're trying to tailor the treatments according to the likelihood of having varices. There is good evidence now that beta blockers alter the natural history of cirrhosis and influence the rates of decompensation. And there's also good evidence that carvedilol is preferable in terms of having a greater beneficial effect on HVPG. So this is just the background to portal hypertension and where we're moving to focus our surveillance. Primary band ligation is limited to patients who are intolerant of beta blockers. And just to give a plug to colleagues who are completing the BOP study, which is looking at the benefit of beta blockers in those with small varices, and that should hopefully report in the near future. Moving on to acute variceal management, I think as John has spoken about, a lot of the defining points in GI bleed management, particularly in patients with liver disease, relate to the non-endoscopic management. So these patients presenting with acute variceal hemorrhage, normally in the setting of decompensated cirrhosis, most of their outcome will be defined by the non-endoscopic treatment they're given. Early resuscitation, antibiotic prophylaxis, given the GI translocation that occurs in the presence of GI bleeding in cirrhosis. There's good data behind a restrictive blood transfusion strategy from a New England Journal paper several years ago, and judicious correction of coagulation, and the early use of splanchnic vasoconstrictors. Again, bearing in mind that these drugs have side effects, particularly in terms of coronary and digital ischemia. And really, this is a team approach. So early involvement of critical care, hepatology and gastroenterology coordinating with endoscopic colleagues. And these are the patients that you would want to scope with early and within 12 hours of presentation. And often these are the bleeds that often happen overnight. And I've put in red at the bottom that what is absolutely vital is that you prepare your endoscopy appropriately. If these patients are encephalopathic or are having active hematemesis, their risk of developing aspiration pneumonia is high, and there should be a mandated airway protected endoscopy, often performed in theatres. The management of esophageal varices is often with band ligation. This schematic just goes through how one approaches banding. it's important to have a careful inspection without the bander to identify the GOJ, identify where the bleeding site is likely to have been, mindful that the perforators arise from the GOJ proximally. One bands from the GOJ proximally up to a maximum of 10 centimeters above the GOJ. I teach our trainees to deploy the band after a readout and keep sucking after they've deployed the band, and then relax and then inspect for proximal decompression after each band. And generally less is more. A maximum of 3 to 5 bands is normally sufficient in one session. I'm sorry the video didn't play, but there's a video just if someone is able to click on it, just showing what you may encounter. And you may find a situation, particularly without airway control, where GI bleeding is significant, and you may have to primarily glue inject, but that's fairly uncommon. I'll move on just because the video's not behaving. Gastric varices are a source of anxiety for a lot of gastroenterologists. I think the important thing is to get the kit ready in advance. Consent the patient appropriately. There are not insignificant rates of embolization with glue. Inject with saline first to ensure there's no saline bleb, and then we inject a mix of Lepidol and glue in a 50-50 ratio, and again, less is more, rarely more than 4 mils in total. This is followed by a saline chaser, and we do one follow-up scope after the gastric variceal glue embolization. I hope these videos will play. They just show you some of the pitfalls associated with glue embolization. So if we play the left video first, this just demonstrates glue injection, and one has to be mindful that the injecting on the side of the varix can risk this kind of injury where the varix slices open. The important thing is to maintain calm, reposition yourself, and re-inject. The video on the right just shows the importance of the saline chaser. So it is possible for the needle injection to stick to the varix, and just be prepared for this. If you inject with the saline chaser after you've injected the glue, you can leave a little spike of glue and avoid this complication, which one of my colleagues was able to deal with and extract the needle without causing any particular problems. So I'll just move on. In terms of rescue therapies, having a plan at the start of the procedure as to what you're going to do in the event of non-control. Sengstaken and Blakemore tubes are often kept in the fridge. It's important to know where they are. These can only be inserted under general anesthesia. 300 mils of air is placed in the gastric balloon. One shouldn't inflate the esophageal balloon. And the video on the left, if someone can just play that, just shows the effects of an esophageal injury that can occur with either displacement of the gastric balloon or with inflation of the esophageal balloon. And I think, as we've spoken about, you can often deal with rebleeding, but if these patients get significant either esophageal injuries or other problems, they can be much more problematic to deal with. So my advice is that you use tape traction to the mouth, don't apply weights or bags of fluid, and be mindful of the incidence of problems related to the balloon, and deflate and relook after 24 hours. A Danis stent is another rescue therapy, and the video on the right just shows placement of a Danis stent. The best indication for these, if we can just play the video on the right, the best indication for these is for esophageal ulcer bleeding. I'm sorry that video is not playing either, but these stents allow coverage of esophageal banding ulcers. They can be left in place for up to 2 weeks, and they're a good measure and a bridge to another therapy. So just moving on. Post-endoscopy, be mindful of the other general measures for the patient. Place an NG tube to allow them to be fed. Aim for an early extubation. Maintain vigilance for the side effects of terlipressin and aim to wean that off quickly, typically over the first 72 to 96 hours. Start secondary prophylaxis as soon as the patient is stable and outside the acute bleeding episode. And as John has spoken about, in your report, have a rebleed plan. Should this patient be rescoped? In the event of rebleeding, are they someone who should be worked up for a TIPS? If so, order the investigations such as a triple phase CT to assess their vasculature. Are interventions like a Danis stent appropriate? And then also take a longer term view. What is the overall outlook for this patient's liver disease? Are they a candidate for liver transplantation? There are good data to support preemptive and early TIPS, and the Kaplan-Meier curves to the right just show the difference in overall survival out to 2 years in early TIPS group versus those treated with band ligation and drugs. And sadly, some of these patients, the variceal bleed will be part of a pre-terminal event, and we increasingly recognise that palliative management in liver disease is extremely important. So just to summarise, in the management of varices, the paradigm has changed, and our use of surveillance and prophylaxis is now guided by the presence of clinically significant portal hypertension. I've highlighted that acute bleed management in portal hypertension is often dictated, the outcome is often dictated by non-endoscopic management. And my advice is that you think beyond the endoscopy suite. Is the patient a candidate for radiological measures such as TIPS? Are they a transplant candidate? And should you be involving palliative care? I hope that's been helpful, and that now concludes the upper GI bleed session. Please come back and join us at 2 p.m. for the HPB session. Thanks so much.
Hello and welcome back to our second half day of endoscopy within London Live Endoscopy. Really exciting to start this HPB Symposium with my friends and colleagues, Reem Sharia from New York, Tazam Manabawi from our team in UCL in London, and Gavin Johnson also with us at UCL. We're going to try, big ask, we're going to try and cover all areas of ERCP and EUS this afternoon, and we're going to start with the most fundamental and the most basic aspect of ERCP, which is, can we get into the bile duct? So we're going to start with a case. 50-year-old female, presents with right upper quadrant pain, has an outpatient ultrasound, which suggests a mildly dilated bile duct. MRCP shows a 5mm bile duct stone, but she has normal liver function tests, and her pain has resolved when she attends her ERCP. During the procedure, we're going to be using a range of equipment, the Pentax EUS J10 scope, the Pentax DEC duodenoscope, Boston Dream Tome. We, as you'll see, will be using the Cook pancreatic stent and the Olympus extraction balloon. And so we've got some learning objectives right through this session. What is the role of endoscopic ultrasound and the need to confirm the presence of stones before we proceed to ERCP, and some tricks and tips and challenges around cannulation. So let's go.
So this lady's symptoms have improved since she had her CT and MRI, and she's had some liver function tests this morning, which showed a bilirubin's normal and only slightly elevated ALT. So we've started with an endoscopic ultrasound to confirm whether her small 5mm stone is still in the bile duct before we go on to do an ERCP. So we've now got a nice stable position in the duodenal bulb, and Charlotte's picked up the bile duct with the cystic duct, it looks like, inserting onto it. So we're now going to track that up and down to see if we can find this small stone. Looks to me like the cystic duct inserts incredibly low down on the bile duct here, so it's probably the ampulla just below the bile duct down here. So Charlotte's got a nice view here in the bulb. We've got, she's going to demonstrate, we've got pancreas up in the top right here, we've got bile duct here, we've got cystic duct coming inserting in, portal vein behind, and she's going to trace this down to the ampulla to see if we can still find that stone. And there we go, so distal bile duct, we've still got a stone with an acoustic shadow here.
Right, so Charlotte's going to continue on. The nurses have done a very rapid switch of scope, so we're using the Pentax duodenoscope. There's the ampulla, first view of the ampulla. And you're going to use the Boston sphincterotome with a jag wire and a short wire, on the assumption the whole procedure will be a short wire procedure for simple stone extraction. So I can see then Charlotte just moved the scope around a little bit, just getting a feel for the angles in. You can see the scope's going towards 11 o'clock, although the bile duct's probably heading at 12 o'clock in this one, so we'll see how it sits. She's heading towards the top of the ampulla, so she's already engaged the os, and you can see it just dropped in a little bit then, so she's probably already within a duct, but that's pancreatic duct. The wire has gone straight over the midline and over the spine, so that's pancreatic duct. So there's different approaches about how you take this forward. Now Charlotte's taken a wire back. Okay, so she's going to use the bow to try and get an angle further up towards the bile duct. The other approach would be to shorten the scope a little bit, use your bridge and try and lift the hood of the ampulla. So yeah, it's back to PD again. So at this point, the options available would be to put a pancreatic stent in. We could use a double wire approach where you can put a bit of forward pressure on this wire to try and open up the os and see if the biliary os becomes more visible separately. That's one option. You could put a pancreatic stent in, or we could then fall back to a needle knife if really necessary. And now we'll just see if you can get in over that with a sphincterotome, but often you can't, in which case we may need to then do a needle knife, and then we'll regret having not used the double wire technique, but let's see. Well, I might do. Does your wire go anywhere? Right, that looking good. That's looking good. That looks like it's going to be a bile duct. Yeah, you're in the bile duct. Well done, Charlotte. So there we can confirm the bile duct position. We're not showing the stone outlined beautifully yet. I'm just wondering if that was a stone in the cystic duct. The stone's right at the bottom, I think. So at this point, because the access was so difficult, my view would be I would just get on and do the sphincterotomy and not worry about the fact the wire is in the cystic duct. Also, once you've done the sphincterotomy, then you'll be able to pull a stone out even if you're pulling initially from the cystic duct. So that looks quite a lot of tension there, but that's fine. That's right. Just bring, that's it. That's much more controlled. So now you're going to bring yourself up a little bit more, a bit of bleeding. So in terms of the bleeding now, you can argue a few points. I personally, because we're away from the pancreatic duct, I like to put a bit of blue pedal at the top of the apex here, just to the left, sorry, where you are. That's it, just on the left wall there. I think that's where the bleeding came from. So let's carry on the cut, because we're not going to get the stone out with that sort of size cut. Yep. Keep going, and stop. I think that's enough. Yeah, go a little bit. See, is the stone just in the cystic duct up there? No, the stone's below you, probably. It does look like a stone, rather than a bubble, I think. Okay, stop screening. You ready? So, okay, screen, please, and inject. So we're not clearly, there's the stone just popped out. Okay, so it was into the distal duct there. Try and reposition your wire. All the way down with the wire. Okay, now just pull back with your scope a little bit, reposition it. And then just see if that changes the wire position. Now try that with your wire. Cystic duct. So, or do the opposite and push in. And now try with the wire. Okay, it's done the same. So at this point, we just need to move your position, push in, pull back, take the locks off, and just see what flicks the wire up the bile duct. So, I mean, if it's gliding up really easily, you can very carefully just see if the tone drives through the duct easily or not. Only if it goes really easily. You can't push against any force. Up with the wire again then. And there he is, up the bile duct. Okay. So we're now just below the hilum, that's enough. And I like to suck with the scope to pull the bubbles down and contrast from above. Keep injecting, keep injecting. And a picture there, please. Okay, nothing there. And then we're done. We haven't seen any more bleeding since we started. I think we can leave that and come out. Okay.
Okay, so I think a nice usual case, if you like, to get the ball rolling. We saw a nice example there of starting the procedure using EUS and then proceeding to ERCP, having identified the stone. Gavin and Taz, you have been absolutely instrumental in the UK in trying to develop training around ERCP and EUS through JAG. And Taz, you've closer to the sharp end than some of us. You've recently come out the end of that training process. What lessons have you learnt, and what is the JAG training program going to deliver that we're not presently doing?
Yeah, so I think freshly birthed into the consultant.
I'll come once.
I think that
I'll just do your ERCP, and then probably
what's key when you go into something is
and,
knowing exactly what it is you need to learn. And it's something that I really like about this session. There's learning outcomes. Actually, when you go into EUS or ERCP training, knowing what it is that's before you is difficult. So one of the great things about the accreditation pathway in EUS and ERCP that we've now got through JAG is there's a clear curriculum about what people need to learn. Biliary stricture management, cannulation techniques, managing the fluoroscopy, understanding the EUS console, and we've laid out a kind of beginner, intermediate, expert level that people should be achieving at different stages in their training. For example, in endoscopic ultrasound, to familiarise yourself with the console, we're saying that you should attend with a radiologist and observe 50 transabdominal ultrasounds. So you're familiar with the control when you walk into the endoscopy unit. one of my interests is on endoscopic non-technical skills and managing your cognitive load. And if you walk into a room and all of a sudden you're trying to manage an endoscope you've never held before, intubate without being able to see where you're going, and then also trying to manage ultrasound and images you're not used to, you get massive cognitive overload in that situation. So breaking that down into more bite-sized chunks makes it much easier for the trainee, I think.
Okay. And Gavin, we saw Charlotte, one of our fantastic fellows, being, I think, beautifully trained in that procedure. There is a tension, though, isn't it, that the more we set up these accreditation steps, the risk is that we put people off. You know, how do you see us getting the balance right? Because we need more keen, young, excellent interventional endoscopists going into this.
It's a good point. So Taz has mentioned that we've laid out what the training looks like, but from the bottom of the ladder, you know, you're looking at 250 EUS cases before you are expected to reach competence. We're talking about doing a summative assessment at the end of both EUS and ERCP once you've got the numbers. So the whole concept of proving competence and evidencing your competence has now very much been well defined with the JAG certification. And you're right, I think for a trainee at the bottom looking at that would be a little bit daunted to see what is set out, but at least the steps towards that training is much more clearly defined in the UK, such that if you are a program training director or a trainer within your hub and spoke model, I think we need to be a little bit more imaginative about earlier exposure of usually gastroenterology trainees. Of course, there's radiologists and surgeons, but that's a little bit more niche in the UK. But having exposure to interventional endoscopy per se, and certainly HPB endoscopy in particular, at a much earlier stage, and identify those that are keen, possibly at the exclusion of them training in colonoscopy, quite frankly. So in the UK, we've now got Shape of Training, which has limited a 5-year training program down to 4 years. To get colonoscopy up to however many, 300 procedures with competence, with summative assessment, then ERCP US is a huge ask. So we're almost certainly mandating post-CCT fellowships, which I think we've known about for some time as being necessary for ERCP and EUS, but I think the new certification has pretty much made those mandatory for most training programs. But early exposure, early identification of those with the skills, with the aptitude, with the interest, definitely.
Brilliant. Now, the whole focus of this whole London Live Endoscopy course is training and education, and we'll be talking more about that through this session. But let's move on to the next case. Thanks, guys. Okay, so next case, 88-year-old lady presents with painless obstructive jaundice. CT scan shows a mass in the head of the pancreas with upstream dilatation. And the plan here is for an ERCP with tissue sampling and relief of obstruction. Again, using the Pentax DEC duodenoscope and the Boston Dream Tome. We're going to be talking a little bit about biodegradable pancreatic stents, both now and also later on. We're using the Olympus extraction balloon and the Cook cytology brush. And you'll see at the end, we're using a fully covered Cook Evolution self-expanding stent. Again, unapologetically discussing again issues around difficult biliary cannulation. A few words about reducing ERCP pancreatitis risk, biodegradable stents, and stent selection, particularly for this case with regards to extrahepatic strictures. So here we go.
So you're joining us. A difficult case, this. So this is elderly lady with large pancreatic mass and jaundice. She's got a fixed neck. We're doing the procedure with her in the left lateral position, under sedation. And I suppose a few things to say. We're lucky enough to be able to swing the C-arm across, so we're getting a little bit of a better view, but it really does hamper you. If you've got a fixed C-arm, it can be really difficult. And we thought we'd got, before he joined us, I thought I'd got the wire up the bile duct, but in fact, on contrast injection, very helpfully. Can you go back? Have you got any recorded pictures here? Can't remember whether we've kept any of them. Yeah, so, okay, so just showing you the previous picture. you could imagine that that we're just starting to delineate the lower bile duct here, but in fact the giveaway is side branch filling, and particularly here when we inject a bit of contrast, we're actually filling the Santorini duct. So I know that I'm in the pancreatic duct. It all looks very infiltrated and tricky, and so what I've done is I've done a small sort of mucosotomy, if you like. I've kept the wire in the pancreatic duct. I've done a little cut just to give me a better chance of getting access into the bile duct. And I'm just going to put in a prophylactic pancreatic stent here, both to reduce the risk of pancreatitis and also to give me a better chance of getting into the bile duct. And in fact, I'm going to use here the biodegradable Archimedes stent. Can we just coming out with the biodegradable Archimedes stent. This is a 6 French stent. Great advantage being that we don't have to remove it. And if I do succeed in getting in a metal stent here, as I want to, then a standard pancreatic stent would very likely not fall out. And so that's in a nice position there. I'm just using the sphincterotome to push. I'm just coming out with the wire. Screen, please. So that's in a nice position, that stent, and I'm coming out with the wire. Now, hopefully, that looks very nice. You can see that there. Stop screening. And now I'm hoping that I might be able to go over the top of this, bit of bend, and get up the bile duct. If not, I will do a pre-cut. Screen, please. It's tempting to think I'm in the right place here. There we are. Yeah, no, that's nice, isn't it, actually? So that proved a very nice approach there. I think we're in the right place. Never be complacent when you've got a patient with a big necrotic lesion, because you can make false passages very easily. Off with the bend. Yeah, those are the intrahepatic. So we're in a good place. Isn't that interesting? I mean, I'm going to do a little bit of a sphincterotomy here, and then we will do a brush, and then we'll put a stent in. A bit of bend. Streaming up. It's quite a long stricture, this. And those sort of wavy filling defects, you know, they can be due to stones. Once or twice I've seen it due to tumour, actually. But the thing that, particularly if you see that towards the end of an ERCP, it very often is due to blood. I'd be a bit surprised if it was blood as early as this, and we saw it on the first cholangiogram, didn't we? Okay, well, at least we've defined the lower end, the top end of the stricture, haven't we? And yeah, so we've used a biodegradable pancreatic stent here, so-called Archimedes stent from Q3 Medical. I definitely think it has a role, including particularly maybe in these sorts of cases, because conventionally speaking, you shouldn't leave a pancreatic stent, a prophylactic pancreatic stent, in for more than a couple of weeks. So let's go up with the brush. One thing I don't like seeing is people advancing the brush, opening the brush through the stricture. You should open above the stricture. So screen, please. So you pass the catheter brush through the stricture. It's quite tight, but you get all the way through. And so you open the brush, and as you open the brush, yeah, okay, and then just draw that back through. There we are. And then you draw that back through. That's fine, and then you close. Nice. Stop. Screen. Perfect. Let's get this stent in now. Perfect. Beautiful. So just advance that there. Okay, good. And you're in good position now. You can start deploying. Okay, now look away and see where the yellow marker is. Stop there. Okay, so you can now pull back. Good, and now pin out, please. Okay. find the yellow marker. Beautiful, beautiful. Wonderful. Lots of obstructed bile coming out. That's a great result. Because this is a tight stricture, you need to stay with the tip of the duodenoscope against the stent to avoid the stent being pulled distally as you take out the delivery system. So you can take out the delivery system now. Beautifully done. And then you can see that the olive is coming out there. Now, there we go. We're all done. And yeah, good result. You know, that's a very, very long stricture. I think it reflects the size of the mass, to be honest. But that should provide definitive drainage. And because we have that Archimedes stent in, that should reduce, we hope, the risk of post-ERCP pancreatitis. She's obviously had rectal NSAIDs anyway. And that biodegradable stent will biodegrade over the next week or two. And that should all be fine.
Okay, so again, the sort of case that we see very regularly in our practice. A few points of discussion. Reem, in your practice and maybe in US in general, the ESGE guidelines advise if we're getting difficulty getting into the bile duct and you're in the pancreatic duct, the choice is double wire techniques or pancreatic stent placement or transpancreatic sphincterotomy. We're showing the guidelines here. Some people favor early pre-cut sphincterotomy. What's your approach?
So I want to say I try and follow the ESG guidelines as well, but it depends on the indication for the endoscopy, how much time I've spent into the pancreatic duct. I generally try and convert early on. So if it's 2 or 3 tries and I keep getting into the pancreatic duct, I would switch. If I have a good handle on the wire and it's already in the pancreas, then I would leave it and do a double wire. But if I go back into the pancreas again, I tend to do a transpancreatic or a Goff sphincterotomy. I know not many people like that.
A what?
I think isn't it named by Jeff Goff, who started? I don't know.
Never heard it. How does it differ from a pancreatic sphincterotomy?
Just you go towards the bile duct. So similar to what you did
with a pancreatic sphincterotomy.
Yeah, but just you that
okay.
way.
And what about a technique that we often do is we call it a mucosotomy, and by that we mean sort of a mini pancreatic sphincterotomy. Is that?
So
Webster sphincterotomy.
Oh, okay. So that could be it. So we could name it that now.
It'll be as well known as the Goff sphincterotomy.
We could name it whatever you want. I tend to do probably somewhere in between because I don't want to, you sort of cut towards the bile duct and then you could then try again. And then once you, sort of similar to what you saw there, you expose the bile duct orifice and there was some bile draining. And so you could redirect the tone that way. I think the key thing with any of the methods that we try is if it's indicated or not and when to stop, sort of if you can't do that. And that's the main thing that we generally teach is that if you try and after 10 minutes and you still can't get in and it's not an urgent endoscopy, then just exposing a little bit of the bile duct decreases the edema and you go back in 24 to 48 hours and try again.
Yeah, I really like your advice to, before you start, have a clear idea as when you might stop if you're having problems. I think the scenario we see problems is when people keep going and you get mission creep, and before you know it, people are doing big needle knife pre-cut sphincterotomies through ampullary tumors, and it's all going horribly wrong.
Yeah, and obviously we can go over a pancreatic stent like you did, and then or do a freehand needle knife. But those I generally reserve to bigger papillas. So if it's a small one like that, I'm generally a little bit less aggressive.
All right, let's discuss some more cases and show some more cases. So next, 27-year-old lady, again presented with obstructive jaundice, all nice and straightforward. She's got stone in her bile duct, except that she has situs inversus with, as you can see on this MLCP, everything on the wrong side. We're, again, using similar kit to previously. A few words about approach to Situs inversus. Somebody else might quote the figure, the number of patients with situs inversus. It's, I think, 1 in 10 or 15,000. So every few years, you're going to have a patient statistically with this. And there's a few ideas about room setup and overall approach. Unusual procedure this, doing it with my colleague Simon Philpotts. So this is a young woman with small bile duct stones on MRCP, which are symptomatic. We're looking to do an entirely run-of-the-mill, straightforward ERCP. The challenge is that she has situs inversus. And so there are a few important considerations here. The first is the position of the endoscopist and the patient. Essentially, the procedure is done in a mirror image. How we've arranged the room here is that the patient is lying the opposite way to what we would normally do. So the patient is lying reversed on the ERCP table and is lying in the right lateral or the right semi-prone position. And so the endoscopist essentially is standing the opposite way, the opposite side to usual. That's fine, so I've got a very nice position there. Yeah, very nice, son. Simon has rotated the endoscope 180 degrees and is now in quite a short scope position, but in a otherwise conventional position. Looks very nice. So Simon did it very straightforwardly, but when one is intubating the esophagus, I describe it as a bit like playing ping pong or table tennis backhand. One is it's a reversal of the usual movement down the esophagus, and the bile duct should probably be at 1 o'clock rather than 11 o'clock. Although you do often find that in patients with any congenitally altered anatomy, that things can just slightly unconventional. Approaching this with the Boston Dream Tome, short wire system, 0.035 inch Jaguar. Beautifully done. Well done. Lovely. Beautifully done. So I explained to this lady beforehand that the biggest challenge would probably be getting down to the into a good position on the papilla, but in fact Simon has done this very made it look easy. Simon made it look easy. That's very good. Show the maneuver again then. So secure against the with the left hand, and then slowly push in an anti-clockwise torque because it's situs inversus. Boom, and then you've got a nice stable position there. That's an air bubble, yeah. I tend to have a rule that however few or however many stones there are in the bile duct, I always like to do 2 completely clear balloon trawls prior to stopping. So good result. Interesting case, situs inversus. So just to remind us of the techniques. Patient position crucial. The patient needs to be in the right prone position or can be supine if one is using general anesthesia. The endoscopist essentially approaches from the opposite side. If you're lucky enough to be able to have the patient lying the other way around on the bed, then you don't get caught up with the X-ray machine, and then intubating the esophagus in more of a backhanded type of maneuver. And then once you're in the duodenum, as Simon showed very nicely here, often looking to rotate the endoscope 180 degrees. And everything broadly is straightforward from there. You could argue that the line of your cut is a little bit more towards 1 o'clock than 11 o'clock to get up to do a biliary sphincterotomy. Yeah, okay.
Yeah, a little bit more left talk in the stomach. Finally, the maneuver to remove stones. We spend a lot of time teaching our fellows about the maneuver of when you're in a short scope position with the balloon against the stone near to the papilla. We then push in and do very light clockwise torque. With situs inversus, one needs to lightly push in and do anti-clockwise torque. Anyway, job done. Nice result. Well done, son.
Okay, we'll be discussing this case with another one, which we're about to show. This is a 38-year-old lady with history of biliary atresia from birth, who had surgery at the age of 2 months, so-called Kasai procedure, resection of the remnant bile duct and a loop of small bowel brought up onto the liver hilum. She had previous ERCPs overseas with stenting of the right liver. The left liver is largely inaccessible. And 5 months previously had 2 biliary stents inserted into the right, but has recently represented with worsening pruritus and a rising bilirubin. Here we are using the therapeutic Pentax EC34I10 colonoscope. Boston Dream Tome, we're using Creo grasping forceps, as you'll see, in an Olympus extraction balloon, and then Cook 7 French straight stents, and also the Cook Titan 6mm dilating balloon. So unusual case, but I hope we can have some discussion around understanding what biliary atresia is and what options are available for treatment, and both in this case and subsequent lecture, the approaches to ERCP in patients with altered foregut anatomy. So let's go through to the case.
So very unusual case, this one. This is a lady about 40 who was born with biliary atresia and was jaundiced at birth, and at 2 months old she had a Kasai procedure in which a loop of small bowel was brought up onto the liver hilum, and separate anastomoses were brilliantly made onto the tiny right and left intrahepatic ducts. And then the other end of the small bowel loop is connected as part of a Roux-en-Y anastomosis in the mid-jejunum. She has had recent problems with worsening itch and low-grade cholangitis, not particularly jaundiced, bilirubin about 40. And so our challenge here is to see if we can get round to the bile duct. At her last ERCP done 5 months ago, she had a couple of small, I think a 5 French and a 7 French stent put in the right intrahepatic ducts. There is said to be no access into the left duct system, and the left lobe itself is completely atrophic, so probably not contributing to function. I'm using here the Pentax EC34 I10 colonoscope with a 3.2mm working channel. You can see fantastic endoscopic views. She tells me that she thinks that some tattoos may have been placed on the small bowel. Well, here we are. So this is interesting, isn't it? So here is the Roux-en-Y anastomosis. Well done. So here we are looking up into the liver in a patient who's had a Kasai. Let's see what we got here. So I think that what we're seeing there is the entrance into the right duct system, and then that into the left duct system. Okay, so I think, to be frank, it has been felt that there's no mileage on the left. This is where the money is. This is into the right duct. And okay, so here we are, up close and personal. Screen, please. I'm hoping that I'm going to get the wire in a bit further here. Looks a little bit more. Oh, that's gone somewhere. That looks a bit more promising, doesn't it? This is the part of the liver that is critical to her. So let's have a little bit of contrast going in there. Okay, so those are the ducts we need to get into. Down with the balloon. Bit of debris coming out. The question is, what's above there? Screen, please. Wowie. So the scope is sort of 10 millimeters, 11 millimeters wide. That duct's a bit dilated, isn't it? So I can pull an 8.5 millimeter balloon out through the anastomosis here, but it looks to me as if things that there's some filling defects above it, above the anastomosis. I think it's a reasonable plan just to do a dilatation of this anastomosis. So I'm definitely going to put stents back in here. Take that picture, please, and stop screaming. Yeah, just keep that on for a few minutes. That's fine. It's draining very nicely. There are filling defects there, but I think that's all good. We're draining the anastomosis well, and in fact, when we suck out, it drains out very well. So here we are. So we're just going to finish this procedure by putting in a couple of small 7 French 5 centimeter straight flanged stents. There's one. That's very good. It goes without saying that you have got to do these cases with a short wire system. So we've got the Cook locking device here. Makes all the difference. If you were having to use truly long wire, it would be a very stressful exercise. But I know that there's no way that this wire can go too far in or fall out or whatever. It's completely stable. Here's the stent now. That's good. Try and stay up close and personal. It's not the easiest thing, really. But let's hopefully we can get this one in. There we go, screen. That's good. Those stents are in a beautiful position. And I can just release that one. Release, release, release. Kaboom. Both those very nice. That's the end of the procedure. So I suppose a few comments, a few teaching points. We're increasingly doing procedures in patients who've had altered foregut anatomy, and you need to have the right tools. And in this case, using the Pentax 3.2 millimeter channel colonoscope was fantastic. Really got the job done. Beautiful endoscopic view. Very rare scenario of a patient with biliary atresia, but she's done very well over many years now, and we want to keep it that way. So a good result, and thanks so much. Thanks, team. Brilliant.
Okay, Gavin, you're about to tell us a bit more about different approaches to biliary access, but just give us an overview of the things we need to consider in looking at the imaging, in deciding on the best approach to biliary access in a patient with altered anatomy.
Well, I think you've hit the nail on the head. Often the referrals are, often they don't mention it at all because it's lost in the midst of time. Probably not in somebody like this, but we see that all the time, whereby sometimes you're on the table and the anatomy is unconventional. Not ideal. I think for trainees, as you receive the referral, if there's any mention of abdominal surgery, if it's not clear-cut exactly what that is, just to do a little bit of digging. And if it's anything to do with Roux-en-Y-limbs, Whipple's, bariatric surgery, and if the patient's not sure, the referrer's not sure, it's the benefit of a complex, we call ours a complex benign MDT. It's often not benign disease, but what have you. And that means getting the source images and having a really good look with your radiologist as to defining exactly what that anatomy is. Defining the length of that limb. Are we likely to get there with enteroscopy? Would it need double balloon enteroscopy to have any prospect of getting to the bile duct or the pancreatic anastomosis as it may be? And if not, what is your plan B? And that's where EUS comes in, which I'm about to speak about.
Yeah, well, you go off and get ready for that. And Reem, you have a huge practice in bariatric endoscopy, and general endoscopists and certainly general physicians still don't quite understand the different implications of different bariatric interventions when it comes to doing an ERCP. You know, comments about that. We've seen patients who have come with percutaneous drains when they've had a gastric band or a sleeve gastrectomy, when in fact it shouldn't have been difficult.
Exactly. Or the other day I had a patient referred who had a duodenal switch operation and had a metal stent put in percutaneously for me to take it out. And those are extremely difficult to do. But I think the key thing, which Gavin said, is to always read the op notes or understand what type of operation it is. And maybe if you can, speak to the surgeon involved, because that's really important. And that's the same with both bariatric or even the sort of liver transplants, because you have different types of liver transplants that you can get as well. And then the various different approaches. I always try, if it's going to be similar to what you did, is use a PEDS colonoscope. We use mostly Olympus and put a cap on it as well and hope that you'll get there.
The problem, from our experience with the PEDS colonoscope, is that when you get there,
you can't do anything.
You can't do as much as you wish, can you? You know, because often you can't even get the, you know, a sort of CRE dilating balloon through the channel, and you know.
You've got very limited devices. So it's the CRE 6 to 8 that you could use, the Tillman wire, a balloon that doesn't have that much give. And then the stents are usually just the 7 French stents that are able. Sometimes you could put the fully covered metal stents, but it just depends on...
Real technical challenge.
Exactly.
And I think watching that video, actually, George, the mechanics of the case are completely different. Oh. We're on a high alert, so excuse me. So the you saw with the stent, pulling the balloon down to pull the stones out. Is that a lot more difficult in anatomy like that?
Yeah, I think it's a really good story about the fire alarm.
We can't hear it.
Hopefully that's the end of that. No, I think it's a really good point that the traction, pulling traction on a stone and on an endoscope when you're in altered anatomy can really put tension around some of the small bowel loops.
Yeah.
We'll come back to that, and Gavin is going to now tell us more about endoscopic approaches in altered anatomy or challenging cannulation.
Thanks, George. So 8 slides in 8 minutes, and quite a big topic, so if I just have my slides. So there are lots of reasons to have an inaccessible papilla. Obviously, what we've just talked about is the dark blue at the bottom half of this slide. So we've got our surgeons have created surgical alteration. Bill Roth 2, a dying set of patients, in that we're not seeing that quite so much anymore. Then your Roux-en-Y patients, we just saw a Kazai where the Roux-en-Y anastomosis is quite short. But if that's a Roux-en-Y for a gastric bypass, you can bank on an extremely long Roux limb and then a Whipple procedure. But that's not the only reason why you can't do a conventional ERCP. There may be pathology, or there may be a failed ERCP, such that you've failed cannulation, which happens, duodenal obstruction, so the inaccessible papilla from pathology, and the infiltrated papilla, which we've already talked about today. And the options for those are PTD, of course, percutaneous drainage, EUS-guided biliary drainage, which I'm going to talk to you a little bit more about. And as Reem said earlier on, if it's failed cannulation, then if the patient is not critically ill, not cholangitic, then it's perfectly acceptable to either refer at that point or repeat the procedure a few days later. The options for surgically altered are even more numerous. So if this is a Roux-en-Y gastric bypass, you can do a laparoscopic supported ERCP. That was something that we were doing quite a few of before we got into the EDGE procedure. There is PTD as well to get you out of trouble. This introduces enteroscopy as an option, and of course EUS biliary drainage, which again I will expand on. So this is Reem's meta-analysis from 2017 now, but this is one of the first, well, the first big meta-analysis looking at EUS-guided biliary drainage versus percutaneous drainage. And to be honest, the data set hasn't been hugely added to since then, and only one of these trials was an RCT. So Reem makes the point in this paper that, you know, a lot of the data is heterogeneous and they're in expert centres, but nonetheless, there was certainly a trend towards EUS-BD being technically effective and creating fewer adverse outcomes. Enteroscopic ERCP, I'm not going to speak too much about this because, to be quite honest with you, at UCLH, we are not enteroscopists. There is no double balloon service with us in the HPB team, and therefore it's something we don't do an awful lot of. But with a short roux loop, we may go with a colonoscope, as you've just seen George demonstrate. But you can probably predict failure in about 40% of cases. And I think so long as the patient's aware of that, then that's fine. It's certainly almost, well, there is a risk of perforation, which George alludes to in the last comments, but it's probably a safe attempt. If you don't get there, fine. There's a perforation rate, and that's about it. So that brings us up to EUS guided biliary drainage. So just bear with me as I go through this animated slide. So if it's surgically altered, think about enteroscopic assisted ERCP. If the stricture is extrahepatic, and in particular, there is access to the duodenum, so this means you can access the bile duct across the gut wall. Then on the diagram on the top right, this is route 2. So you can go with a EUS-guided choledocho duodenostomy, usually with a LAMS, a lumen-opposing metal stent. But of course, you can also go through the stomach. So that's EUS-guided antegrade stenting. So that's puncturing the left intrahepatic ducts, passing a wire across the stricture, across the papilla, and stenting antegrade in that fashion. Or the exact same technique, but picking up that wire and going with a rendezvous procedure such that you swap to an ERCP scope and pick up the wire. And if all else fails, there's reasonable amounts of data in the context of obstructive jaundice in malignancy that if the cystic duct is patent, and your EUS will usually tell you that, then draining the gallbladder is a reasonable option for palliation, but it's not something we've had to resort to too often here at UCLH. However, if there is no access to the duodenum, particularly if there's surgically altered, then of course your CBD entry approaches are not feasible or valid. You're then left with either a PTD or an EUS-guided antegrade stent or a EUS-guided hepatogastrostomy, leaving a stent across the stomach wall. So that's for extrahepatic strictures. What about hilar strictures? Well, then you're much more limited as to what you may achieve. EUS is, generally speaking, only going to get you into the left side. I know there are units who do entertain right-sided punctures from the duodenum, but that's not something we've got involved in. So again, you need to be really careful as to the nature of that hilar stricture. If it's malignant, is the patient resectable? If they're resectable, we may still favour the fact that our surgeons would be much more confident with a PTD so that we're not risking any complications. But very often these patients are not surgical. You need to then be very thoroughly sure as to the nature of the pathology before you go putting uncovered stents across. But in this context, if the predominant aim is to drain the left side of the liver, then it's an excellent indication for an EUS-guided hepatogastrostomy. And we've got some video cases on that coming up over the next day or two. What about benign disease? Well, classically, that's going to be stones. Don't forget, if the gallbladder is in situ, there's a conversation to be had with the surgeons about a gallbladder exploration at the time of the laparoscopic cholecystectomy. I still think that's the best treatment if the patient, in any event, is going to go towards surgery. If the stones are small enough and the cystic duct is patent and favourable, that's a question to be had. But very often, if they're post-cholecystectomy, you need to think again. This is the role for EUS-guided rendezvous. I think we've got a case coming up whereby the rendezvous is often made much more straightforward via a choledocho duodenostomy. So you put a LAMS from the duodenum. The patient is then in a position of safety because you've drained the bile duct with a coaxial pigtail usually, and then you've got all the time in the world to bring them back, or at the same session go with a nice controlled rendezvous procedure where you're not worried about losing wires, etc. Maybe we could talk about that on the sofa shortly. And if that is a proximal stricture, don't forget that we've now got Spyglass Discover. So if you've got a large stone burden within the liver, it's an excellent role for percutaneous drainage and Spyglass EHL. And if it's all left-sided, I think we presented a case at this meeting last year. If it's benign disease with strictures and post-op, etc., then it's another role for the EUS-guided hepatogastrostomy to access an anastomosis or left-sided stones. Just a little word of note when you're planning about relieving distal biliary obstruction in the context of gastric outlet obstruction, then just be minded that there's a bit of evidence emerging that if there is concomitant gastric outlet obstruction, then your choledocho duodenostomy may not fare so well, and there's probably favours certainly treating the gastric outlet obstruction at the same time. But this paper identifies the fact that the patient will do better with an EUS gastrojejunostomy to relieve the gastric outlet obstruction rather than a duodenal stent. And to drain the bile duct, they may do better either with an antegrade stent, transpapillary, or a hepatogastrostomy proximal to the obstruction rather than going across the bulb. So this is not a huge amount of data, but it's a little bit of a theme emerging that practice may be changing if there's concomitant gastric outlet obstruction. You may be well aware of these guidelines and technical reviews, but they're well worth a read to expand on lots of the points that I've been making from the ESGE. And perhaps this slide should have come first, but really the take-home message is that this is very much a multidisciplinary decision. We need the involvement of our HPB surgeons, our radiologists to decipher the anatomy. You need to determine what your local expertise is, which is going to be very different in different centres. You really need to define your therapeutic objective. Is this benign disease? Is this cancer for which we are just aiming to palliate? Or is this a patient that at one time or another is going to come to surgery, which will change your options? And then what all of this means is that you often need to go into the procedure with several possible outcomes for that patient in terms of managing the biliary obstruction, what type of stent you might resort to, whether you're going to manage gastric outlet obstruction at the same time. And therefore, the consent process for these complex cases is certainly an awful lot longer than it perhaps would be for a standard ERCP. And there really is the role to have pre-procedure clinics so these patients are well counselled. And I think I'll leave it there. And we're into our next case. Thanks, George.
Tour de force, Gav. 8 slides, 8 minutes, covering a huge area, and we'll touch on those points in the further cases. So let's go to the next case, 76-year-old lady, recurrent cholangitis secondary to bile duct stone. At an index ERCP done elsewhere, a large duodenal diverticulum was found, and it was not possible to identify the ampulla, and so she was referred on to us, where we had the facility to do the procedure with anaesthetic support, procedure with the Pentax duodenoscope and dream tome, again using a Cook pancreatic stent and other techniques. And the learning objectives here are to understand the approach to difficult cannulation and the options for alternative biliary access.
Screen there. Fine. So it's very unfavourable positioning where the diverticulum lies with the ampulla within it, that long scope you aren't orientated on fast with the ampulla, and short scope we just fall back into D1. So on coming back, Charlotte's tip of the scope's actually popped into the diverticulum, which has got lots of food in it. So we're just cautiously flushing that out to see if we can see where the ampulla is. You just have to be very, very careful with the tip here that we don't push against the side of the diverticulum, as obviously the wall is very thin. It's been very difficult with the positioning. Screen there, we're just sort of semi-long scope, stop screening, to get the tip of the duodenoscope into the mouth of the diverticulum. We've been looking around up and down the duodenum to try and find the ampulla, and it looks like it's just here, just within the mouth of the diverticulum at sort of 9 o'clock here. So we're now going to try and see if we can cannulate from this position. So after a long time sort of trying to get in a good position, we can only get the sphincterotome engaged in the pancreatic duct and filling that. So after a long time struggling, we've managed to get the wire to go down the pancreatic duct. So I'm just going to slowly back away with my sphincterotome in the duct and see whether we've got a view that enables us to reattempt either double wire or a pancreatic stent. Side branch again. A bit more bow. So we've been unable to orientate the sphincterotome with double wire to get it in a favourable position to go in the bile duct, and just repeatedly the pancreatic duct again. So we're putting a 5 French single pigtail prophylactic pancreatic stent into the pancreatic duct, and hopefully that will enable us to then cannulate over that. Patient has already had a small cut made. Stop screening. So we can see where the pancreatic duct is, obviously. Here comes our wire. Definitely further attempts to cannulate over the pancreatic stent weren't successful, and the pancreatic stent's now fallen out. So we've decided to move away from the retrograde approach, and we're now doing an endoscopic ultrasound to see whether we can run an EUS rendezvous. So we're in the bulb with a dilated bile duct here with filling defects within it, following that down to the ampulla with the diverticulum below. Going to have another look down from D2 to actually get a good view from down here. A duct coming in, which is probably the bile duct, which is very tortuous at the distal end, which is, as Gavin said, it's going to make it very difficult to navigate a wire down. You've got bile ducts down here where the narrowing is, but we'd be puncturing here. So we've made the decision that it's going to be difficult to do a traditional rendezvous, so we're going to come back to the bulb and puncture into the much more dilated upper bile duct to put in a CDD. So we decided that hot axios was the better option in this patient's case due to the tortuous distal bile duct. We felt that a rendezvous puncture of a 19 gauge needle and trying to pass a antigrade wire was going to be difficult, so, as we were worried that the wire might loop in the distal bile duct. Also, she's had a long session of trying to cannulate retrograde with some pancreatic duct filling and a pancreatic stent that's fallen out, so we were worried about the risk of pancreatitis with a transpancreatic puncture. And the hope is that if we get this hot axios in, that will drain her bile duct, prevent any further cholangitis, and she hopes to be able to go home today. Okay, so I'm happy with this position. So that's it. So I'm through into the bile duct. Try and get as much of that device out as possible. Lock it there. So we're just going to deploy the distal flange. Just going to push that in a little bit more. There you go, so that's nicely deployed in the bile duct screen. Fine. So now we're just going to pull the axios up against the bile duct, and we can see the black marker in the duodenum. You can see the stent now in the duodenum. Just push it out of the scope and back away. There you go, and you see a big flow of bile. Screen. Stop screening. So let's see if we can just get this wire a bit better in. So we've got a wire in the bile duct that we're going to pass a double pigtail stent through. We're going to try and redirect that wire up into the more proximal bile duct rather than distally. And we can already see small stones coming through the hot axios. So we've got an extraction balloon just through the hot axios here. We're going to try and reorientate the wire so that it goes retrograde up the bile duct. There we go. So now the wire up towards the liver. You can see the aerogram right at the top. Save that. Stop screening. Should we just inject and screen? Fine. You can see that filling the dilated bile duct down to the ampulla with filling defects within it. So we're good to deploy the stent now. So save that. Stop screening. So let's have the... We're going to put a 7 French by 4 centimetre double pigtail stent. So we've now deployed the double pigtail stent through the hot axios. Unfortunately, it didn't go up into the upper duct nearer the liver, but it's going to keep that hot axios patent, and we can see that contrast has drained briskly from the bile duct apart from the dependent area in the distal duct, and reassuringly, the contrast has drained from the pancreas.
Okay, lovely case demonstrated there. Taz, you've got a big focus on training. these are highly complex advanced procedures. What's the forum by which, people build experience and build expertise in these sort of procedures?
Yeah, I was watching that with my heart in my mouth a bit as Simon and I trained very closely
Yeah,
together,
of course.
and amazing watching him doing that case.
Yeah.
And I think that the key, a bit like when you're training in diagnostics, is that you have this wealth of experience to build on when you've seen when things have gone right. And we talked about how good the editing is, but when things go wrong as well. And I've watched Gavin deploy a lot of these stents, Steve as well, and seeing when things usually go right, but sometimes when things goes wrong, and having that experience to fall back on and knowing not when to panic, I think. And so having seen lots and done lots under direct supervision, when you then take that step out and start doing things on your own, you're able to pick on that experience. But I think that, certainly within your first year of training, your first 6 months, but you shouldn't be out doing these on your own necessarily.
Okay. And Gavin, we've seen a very smooth example here where failed native cannulation and then immediately progressing to an endoscopic ultrasound approach. Is that the only algorithm? In days gone by, I don't think an attempt was made here to do a pre-cut sphincterotomy. It may be that the view was poor to do that. Would that be a wrong algorithm to say, native cannulation hasn't quite worked, we come back a few days later, which of course is what we did before, and of course, not so long ago, these patients might have gone off for a percutaneous transhepatic drain. Where do those different techniques now sit in 2024?
So I think this one, I think the penny dropped pretty quickly, that if you bring them back a week later, it's not as if you've initiated a needle knife and you go back a few days later, the edema's settled, a bit of bleeding settled, and you're straight up. This was essentially an inaccessible papilla. So I think we have to think about something else here. That's going to be a PTD, which is probably a week in hospital waiting for procedures. The complication risk of PTDs we all know about, often elderly, frail patients. So the notion of getting them done at that time is excellent if you've got the expertise. And then the option here, I think, on the table is either a rendezvous, a traditional rendezvous, so a 19-gauge needle, which Simon mentions. That's easier done in the antegrade angle in a short scope position, but you're often transcending a little bit of pancreas doing that with a 19-gauge needle, so the pancreatitis risk. And as we spoke off air, Reem, it's often extremely fiddly to get that wire into the duodenum, change scope, pick it up. Often that wire might be lost. An option here, if the left intrahepatics are very dilated, a more straightforward rendezvous is probably not via the bile duct with a very short length of wire, but often transgastric rendezvous. So you're getting into a nice juicy left-sided duct. It's much more forgiving in terms of losing your wire. But even then, it can be fiddly picking that wire up and getting it through your scope. That's where I quite like, if the bile duct is sufficiently dilated, the approach that Simon went with here, which is a 6 to 8 millimeter axios, then either leave it there, bring the patient back, or if the patient's beautifully settled and sedated or tubed or what have you, proceeding there and then through with your balloon through. And we've done several of these cases now. We're accepting of the safety profile of a choledochal duodenostomy with the lambs. I certainly am. Once you get that stent in and you've got all the time in the world to go transpapillary, this patient's going to need a long SPY session looking at those stones to clear it. Okay. And so probably best rebooked, as Simon did here, for a week or two down the line.
Okay, and Reem, the point about transpapillary drainage, you mentioned that would be the ideal here. Are there limitations and concerns about CDS lambs, issues about sump syndrome? Is that something that you see? Gavin in his talk mentioned about the combination of duodenal obstruction and more proximal duodenal lambs can create some difficulties. Do you want to tell us a little bit about that?
No, absolutely. You both hit the sort of nail on the head. I think preserving the natural anatomy as much as possible is the most important. Less biliary reflux as well, and less sort of symptoms, I think, long-term from these patients. But with duodenal obstruction, you're sort of already going into sort of other territory. And I think you do get sump syndrome and it's more common than we think, if not just patients just coming back in with also just cholangitis as well. So using smaller stents like the 6 and 8 help, and then putting the double pigtails through them also prevent that from happening to a lesser degree. Do you do that routinely?
And I don't think the take-home message here is that you would leave a CDS in benign disease. This is half this patient's therapy.
But she's going to have it for a while.
In malignant disease, that's different. And that would be a stent and leave. We perhaps haven't got time to primary choledochoduodenoscopy for malignant obstruction versus an ERCP in terms of the less pancreatitis risk, a bit of data that might be something that we see more of as data emerges. But very recently, the Dragoo paper from Anthony Teo, I think there's a little bit about stats that there's going to be a little erratum that comes out. But essentially, that shows patency at 12 months in malignant palliative setting for distal malignant obstruction that's pretty good. So the whole notion of sump syndrome and stent dysfunction of the Orlams wasn't borne out in that study. We need to see what the erratum comes up with. But,
and I wonder whether it can be translated elsewhere, if people eat differently, what type of food they eat, if they have concomitant duodenal obstruction or not. I think that those are keys.
We have not got time to get on to microbiome. I'm sorry.
Sadly.
What about leaky gut? Are you going to talk about that?
No, not talking about that either. This is a good old plumbing symposium. So, fantastic session. Thanks, guys. We're now going to move sessions focusing on biliary strictures, and delighted that our friend and colleague Deepak Joshi from King's College Hospital is going to get the ball rolling, telling us about the endoscopic management of primary sclerosing cholangitis.
Great. Thank you, George. Thank you for the kind invite, and to the rest of the team. So I'm going to talk very quickly about ERC in primary sclerosing cholangitis. These are my disclosures. So primary sclerosing cholangitis, it's a rare disease, but there's an inflammatory, autoimmune pathophysiology, and probably an element of what we don't truly understand either. Now, we know it's progressive. A number of these patients will progress to liver transplantation. And what keeps us up at night is the increased risk of malignancy, both cholangiocarcinoma, gallbladder cancers, and obviously, if they are cirrhotic, of hepatocellular carcinoma. Now, as ERCPists, HPB endoscopists, we will see a number of these patients as they develop strictures, cholangitis, and we will be intervening. Now, I just want to highlight very quickly the sort of change in nomenclature. We used to talk about dominant strictures, but now the EASL guidelines, the ESGE guidelines have moved us more towards talking about relevant strictures and also high-grade strictures. So a high-grade stricture is a biliary stricture that we've seen on MRI, MRCP, with greater than 75% reduction of the duct diameter in the common bile duct or the hepatic duct. This business of less than 2 millimeters, less than 1 millimeters, nobody ever measures it. So this is much easier for us and our radiology colleagues. So what are the indications for ERC and PSC? Well, in order of sort of frequency, so low frequency, sometimes you might be asked to insert a nasobiliary drain for somebody with refractory pruritus. I think that's changing. There's a number of drugs now, IBAT inhibitors, where we're using them in PSC. Biliary stone disease, these patients tend to form small stones, can form cholangitis, but a number of our scopes in these patients are those with high-grade biliary strictures. This is a summary from Wafa Ahmed, who published this in Frontline Gastroenterology last year, looking at the different sort of guidelines from BSG, ASLD, and EASL as well, when we should be intervening, when we should be following them up, and sort of giving you a guideline as to when we take these patients on. So I'd say the key thing, this is a nice little pathway, again, from the same publication. And what I want everybody to take home is before you take on an ERC in a patient with PSC, discuss this in an MDM. So you need to have your radiologists, you need your surgeons, hepatologists, as well as your endoscopists, and decide, is this the right thing for this patient at this point in time? When you've agreed that, yes, we should be going ahead, think about what equipment you're going to be needing. Are you going down the route of excluding a cholangiocarcinoma? Are you going to be using cholangioscopy, EUS? Or is this for cholestasis and cholangitis? So again, depending where you are, what your sort of support is within your unit depends on whether you'll be taking these cases on. So a few practical sort of top tips, if you like. This is taken from the EASL guidelines published in 2017 now. Now, there's anecdotal sort of evidence which suggests that maybe the papilla, the major papilla, is smaller in these groups of patients. The more you do ERC in these patients, you convince yourself that they are smaller. I'm not sure if there's actually true evidence of that, but there's an increased risk of complications, so pancreatitis, cholangitis, and if you look at the guidelines, they do recommend that those undertaking this sort of procedure are well experienced and in a sort of an environment and a unit that are used to managing these patients. Another key take-home message is you have to give your patients prophylactic antibiotics, just because you are very likely not to drain all the segments of the biliary tree, so they need antibiotics. That's a must. So when you have decided that you're going to sort of access a stricture, you need to have your stricture goals essentially. And I like to sort of promote the AAA approach. So access, this includes your guide wires, your cannulas. Assessment of the stricture, is that going to be cholangioscopy? Are you going to take biopsies endoscopically as well as brushings? And then what action you're going to take. And we'll talk a little bit about that shortly. So this is a video, a cholangioscopic video of a patient with PSC. You can see these pseudodiverticuli, the guide wire is just coming out, and that's sort of freehand advancement of the cholangioscope. This is the hilum. Again, lots of scarring. This patient was being worked up for a potential liver transplant, and as part of the workup, there was concern of the tissue at the hilum. So you can see good image quality here. We can look around, we can make an assessment of the mucosa and actually give us a little bit of reassurance that there's no clear sort of malignancy or mass that's infiltrating. I think in this case, we did eventually take some biopsies. This is the origin of the cystic duct here, but it's about taking your time, having good visualization. You can see it's very fibrotic here in the common bile duct. But this was very helpful in this patient, and they went on to be listed for a liver transplantation and successfully transplanted. And reassuringly, the explant didn't show any evidence of malignancy. So what about action in these groups of patients? Well, the seminal paper is in 2018. This is the DIL stent study, and there was no superiority of stents versus balloon dilatation. But, and the key thing was that patients who had stents had increased risk of sort of adverse events, cholangitis, pancreatitis, and we've certainly gone towards balloon dilatation more. Data out of Germany, this is back from 2019, talks about scheduled versus on-demand ERC, and I think, certainly in the UK, going to scheduled ERC every year in all our patients with PSC is perhaps not practical, and maybe this data is unique to this cohort and this unit alone. So I think I'm well on time. So the key things I want to highlight is the MDT approach in patients with PSC. Know what your goals are before they even enter the endoscopy room. Certainly they need antibiotics before their procedure. They need to have the AAA approach, so thinking about what accessories you're going to use, how you're going to assess a stricture, and what action you're going to take. There's an evolving role of cholangioscopy, and the more we look, the more we learn. And the treatment of strictures may well change as we have newer sort of stent technologies as it comes through. So I'm going to stop there, and I think we can roll the next VT.
Yeah. So you can see we have achieved biliary cannulation of the recipient bile duct.
Can we mag up one, please, guys?
Balloon
So
that has
bit
been
of a
inflated,
wisp of contrast going.
Define the anastomosis. You can see contrast is advancing, but I was
so you can see it's
unable
just
to
coming
advance
back on
the guide
itself.
wire across the anastomosis. You can see filling of the.
So what you can see here, we're in the recipient duct, and in front of us, right in front of us, you can see is the anastomosis. Now, we tried previously in September, we couldn't win, so what hopefully we're going to demonstrate here is the use of SPY in sort of directing cannulation. So yeah, just trying to see if I can get some contrast across. Picture there, please.
Can we mag up a little bit?
Yeah, we can. Can we mag up one, please, guys? So a bit of a wisp of contrast going through, I think. So you can see it's just coming back on itself. So what you can see here, we're in the recipient duct, and in front of us, right in front of us, you can see is the anastomosis. Now, we tried previously in September, we couldn't win, so what hopefully we're going to demonstrate here is the use of SPY in sort of directing cannulation. So
was that despite being in a good position, the wire goes up and then loops around. And you can see why it loops around, because only with SPY, which you're beautifully demonstrating here, can you absolutely, like throwing a dart at the bullseye, it's only with direct visualization that you have really any chance of accessing the proximal duct.
Screen, please. Yeah, it's tricky. Screen again. Problem I'm having, George, is that S.
Yeah, 100%. You lose pushability.
Yeah, the pushability goes. Stop screening.
And I think for that reason,
screen, please.
The only chance we've got of getting our CAFs in is to overcome that stricture.
Yeah.
Otherwise, don't.
It's a bit of tension now.
Come on now. Come
that
on
goes, I think.
Not yet. Not quite yet. Come on.
Okay, a bit of tension now, Myron. Oh, no. Stop screening.
Bit more tension.
Yeah, tension.
Go. Right, come on.
Screen, please.
Right, up close and personal now.
Back
a bit on the wire.
Wire's coming back, a bit more. Okay.
Oh, well, it goes through anyway. Okay, so now exchange.
Stop screening. With the ultra tip on the 025.
Yes, we could.
Yeah, and see if that then goes a little bit more.
Yeah.
Screen, please, guys.
Small victories, maybe.
Yeah, but I think this is. I mean, look at that. It must be less than a millimetre now, George.
Yeah, I agree. Fantastic case. I think we'll win here, Josh.
I
think we will. By hook or by crook.
Oh, you're through. Stop screening.
Yes.
Well done. Well.
Go with the wire. Yeah.
Okay, yeah.
Nice.
Okay, very good.
Nice.
Yeah. Okay. Stop screening.
Good.
Screen again.
Oh, blimey. Well, good for your thumb, this.
Yeah.
So we had a minor victory with that 018, but we are going to need to do better.
Screen, please. Giving tension. Pulling the wire. Stop screening.
Yes.
Oh, screen. That was momentous, George.
Okay.
Still.
Minor victory. Back on the wire, please, a bit.
Yeah. coming back, coming back, coming back. Yeah, that's through, George, I think. Is it? Yeah,
probably
okay.
is.
Okay,
Nice.
stop screening.
Lovely.
Okay, so now the 4mm dilatation balloon.
Yeah, so
yeah,
push
okay,
in,
so,
push-
oh, wait.
push in. Now, finally, after 8 long wire exchanges, stop
Yeah.
there. That's fine. That's lovely. Keep going.
Yeah, that's 12, George.
Is it already?
Yeah.
Screen, please. Makes you wonder all the fuss.
Yeah. Where is this stricture, George? Since we were able to get different cannulae across, and then eventually we've just dilated with a 4mm dilatation balloon. Now, if we show you the X-ray,
back on the wire more.
you can see the recipient duct is very floppy.
Good.
But what George is demonstrating beautifully is how he's
back on the wire
providing the pressure.
Another.
Okay, I think we're gonna. Okay, so nice case. A lot of high-fiving going on there.
There's a lot of love. It's genuine. Genuine love.
Anyway, the excitement there was the challenge of this post-transplant stricture, and the is there something peculiar about post-transplant anastomoses? Because if you had a benign or even a malignant bile duct stricture, you'd very rarely be presented with these challenges.
Yeah, I think what we probably illustrated there was the redundancy in the recipient duct. So the scope position was slightly long. We're trying to get a wire round an S-bend and then apply pressure. And I think it just generates, more difficulty in the procedure. And you can see we eventually got the wire across, but then we serially dilated with very tiny cannulas, and then almost balloon sort of dilated with the cannula going up. So I think that's quite unique to transplant, with the redundancy of the recipient duct.
Okay, and Bev, you're very involved in the transplant service north of the Thames, and Josh is south of the Thames at King's, and of course at the Royal Free. Talk to us about managing those strictures, both in terms of when we dilate, what stents we use, and the choice of stents related to the timing of the transplant.
So I think, if you've got an issue very early post-transplant, for example, the first week or so, even the first 10 days, surgeons generally don't like it when they don't like dilations, and also it's probably preferable at that time to be putting plastic stents rather than metal stents. The cafe stents do have a smaller caliber of 8mm, but still, they think that the tensile strength with that, they might not like the surgeons.
So we use cafes from day 2, day 3. So
and just tell us about, so people may not be aware, we didn't have time to completely elaborate on that. This is an introductal, fully covered, self-expandable stent.
Yeah, so
why not use good old-fashioned conventional fully covered stems?
So I think where the cafes gives added benefit, it gives you the greatest radial force where you need it across the anastomoses. They don't migrate. You deploy a removal string through the major papilla, which you can then remove the stent. Whilst with the fully covered, wall flex stents or other stents, let's say, they do migrate either up the duct or down. And we've had patients where it's become impacted at the TI. And again, the surgeon is not very happy at that point.
And I think even aside from migration, of course, because you're having a transpapillary stent, then there's a risk of pancreatitis. And also the other caveat with post-transplant cafes is that, you need enough of a landing zone above the anastomosis. So sometimes the donor common bile duct is actually very short. And if you're not reasonably symmetrically placed across the stricture, then you tend to slip downwards. So I think that influences.
You need 2 centimeters above the stricture, below the hilum.
Below the hilum,
to be
exactly.
able to deploy safely and get a good result as well. Yeah, I completely agree.
But at least you can then blame the surgeons if they've got too short a donor duct. But
we blame them for everything.
Really good. I'm sure it's reciprocated. Let's move on to two cases back to back, which further explore the decision making around strictures. Okay, so first case, chap in his mid-60s, biliary obstruction, previous cholecystectomy. He's presented now with a distal bile duct stricture with small intraductal stones above this, no associated mass, and at ERCP, we defined this stricture. He had cholangioscopy at index ERCP, which showed rather nodular erythematous mucosa, tissue sampling, negative for malignancy, and a fully covered SEMS was put in. He's now coming back at this procedure for stent removal and further assessment of the previous stricture. We're using the Pentax DEC duodenoscope and the Microtech IMAX cholangioscope with the Boston Jaguar. So learning objectives, again, furthering the discussion about the investigation and management of biliary strictures. Hopefully I have a few words about the role of cholangioscopic visual and tissue diagnosis, and then the issue of the chicken and egg of strictures and stones, which comes first, and how we manage perhaps stones above strictures. The second case, because we're going to run them back to back, is a lady with biopsy-proven metastatic pancreatic cancer, admitted with progressive jaundice, with imaging, MLCP shown on the right here, showing tight hilar stricture involving the origin of left and right ducts. And our radiologists have charged us with looking to stent both the left and the right anterior system. And again, particular focus here, as you'll see, because of the complexity of the case, we're using the Archimedes biodegradable pancreatic stent. We're needing to do a pre-cut sphincterotomy using the Cook pre-cut sphincterotome. Both the Boston Jaguar and also the Fujifilm MedWork GPS wire. Particular feature is showing the use of the Cook Zilver stents, which can be inserted side by side down the working channel. So again, get back to the crucial issue of how to get up the bile duct. We're going to be talking a bit about biodegradable stents, managing hilar strictures, and a few little tricks and tips around that topic. So two cases back to back.
Welcome back to the room. You've heard this chap's story, previous bile duct stones above what we think is an inflammatory stricture. Last time we inserted a fully covered mesh metal biliary stent. The plan for today was to remove the stent and then probably reassess the stricture with cholangioscopy. We're doing cholangioscopy here. Using the Microtech IMAX cholangioscope. Particular features of that, you can see I'm not going deep sea fishing. There's a harness to secure the cholangioscope to the endoscopist. This is a 10 French catheter, 2mm working channel, and a 400 by 400 LED at the tip of the cholangioscope. And we're going to pass it up, see how we get on. So I'm just going to change my orientation. I can lock the position of the cholangioscope with a little knob there, which works nicely. And there we go. And we've passed through nicely into the lower duct. I can now release the lock and see what we're looking at. So a very nice mucosal view there. Just up screen, please. I'm just approaching the liver hilum. You can see actually there's a little bit of an inflammatory response there. Now, it's quite interesting, isn't it, that very nice view of these sort of frond-like abnormalities. And, you know, in other settings, people might start saying, oh, that's a biliary IPMN or some such thing. It's not. You know, it's a feature of stone disease and stents, I would suggest. Just going to come back a little bit on that wire, just see if I can orientate into the other ducts and follow that up. Okay, so nicely up in the intrahepatics. It really is extraordinary the extent to which cholangioscopy is now incorporated into our standard practice. You know, that mucosa looks completely normal. Very nice definition of the normal vascular pattern there. This is where we see this slight mucosal change, but I would say that is a normal feature in a patient who's had stones. I certainly don't think we need to biopsy. No, I mean, look, there's the beautiful view there. I mean, that's really very nice. Screen, please. I mean, clearly the mucosa in this area, looking into the cystic duct there, is very different to when we come back to here. But as I said at the beginning, the problem is this is where that migrated, fully covered stent will have been impacting in this area. This mucosa looks utterly normal, doesn't it? I mean, we're almost out of the sphincter, and got very nice orientation onto the. I'm just coming back. I'll probably drop out through the sphincter in a minute. Okay, so you can see that I'm really almost out. If you look at the duodenal view, I'm almost out of the sphincter here, and yet I've still got a very nice view of the whole of the lumen. Okay, that's a normal sphincter there. Okay, all right. I'm very reassured in that result, actually, to be honest. So just to summarise, there was an anxiety about the cause of this chap's low bile duct stricture in the setting of previous difficult bile duct stones. The stones are clear. We saw that on the cholangioscopy and the fluoroscopy, and reassuring cholangioscopic findings using the Microtech IMAX cholangioscope. Thanks so much. Okay, so here we are again with our excellent Sydney fellow, Charlotte. You've heard the story, 77, metastatic pancreatic adenocarcinoma, and she's presented now with progressive jaundice related to a hilar mass with separation of left and right ducts. And so our aim here is to place bilateral uncovered mesh metal biliary stents. You can see you're coming in quite flat here, and so the risk is that one heads towards the pancreas. So Charlotte doing all the right things, trying to get more below the sphincter. Yeah, I like that. Soft hands, slow movements, nice. It's tricky though. Yeah, so we've tried a number of times to get up the bile duct, and we're probably in a duct. Not completely sure whether it's pancreatic duct. We haven't got it going in more deeply. I think it's okay here just to put a sniff of contrast in. Wait a minute, I think we've got it. We're in a little bit more deeply now. Okay, so now we're in a better position there with the wire. Okay, so I'm going to hand back to Charlotte. Now we could now do a double wire technique. But actually, I think we need to protect the pancreas a little bit further. The question is what stent to put in. Now, obviously, around the country, we mainly use 5 French non-biodegradable pancreatic stents, and we do that because in about 80% of cases, the stent will fall out within a couple of weeks. Now, one of the considerations for this patient is we're expecting to put in bilateral uncovered mesh metal biliary stents. Very probably, if you have 1, let alone 2 metal stents across the biliary sphincter, that is going to make it much less likely that a non-biodegradable stent is going to fall out. And if it doesn't fall out, then our policy is that the patient has to come back for another endoscopy to remove that stent, which for lots of reasons we really wouldn't want to do here. So here we're using the Archimedes biodegradable 6 French by 6 centimeter stent will protect the sphincter and very likely reduce the risk of ERCP-related pancreatitis and biodegrade over the coming weeks. Gently, here we come. There we go, there we go. It's got a, there we go. Very nice. Super, stop there. So that's stent, very nice position. And maybe come round to the left, and now we need to see if we can get over that. It is going to be long scope that will get us in here. Sure of it. Right, a little bit of bend. Let's go with the pre-cut, please. So we're using the Cook pre-cut sphincterotomy. Right. Charlotte, keen as mustard as always, has said, can I have a go? I think that throws up a really interesting question about needle knife sphincterotomy. How do we train in it? And what are the scenarios? So this elderly lady, we need to get biliary access. Charlotte has tried to get in conventionally, has failed. I've tried to get in conventionally, have failed. We've got a pancreatic stent in to help us. Charlotte has tried again and failed. I've tried again and failed. And the question is, should I now hand the scope to Charlotte to have a go at pre-cut? Well, if she doesn't do them, she's never going to learn them. On the other hand, there is absolutely no doubt that your best chance at a pre-cut is the first chance. And I think here, I'm not going to let her have a go. But in fact, for those who are interested and involved in this area, May 9th and 10th, we have a hands-on HPB masterclass in which we have a superb hands-on model for teaching pre-cut sphincterotomy. So those perfect. Now, my practice my golf swing. How am I going to do this? I think I'm going to go up like this. I'm going to start at the sphincter and move upwards. Okay, we good? Okay. I'm shortening my scope. Now, so I've de-roofed it. I've pushed the sides apart, not in the most elegant way ever, but I think the bile duct is there, and I'm just going to cut down onto that now. Okay? And as soon as you think you've got what looks like bile coming out, I now remove, needle back, and personally I now go again with the sphincterotome. Right, so I'm just going to see if now this takes me up. There we are. Good. It's difficult to think that that is anything other than in the left. Just a little tip, if you're doing bilateral stenting, quite a good idea to use different wires. So here I'm using the MedWork Fujifilm GPS wire. It'll make it clearer when we come to put the stents in, which side we're talking about. Screen, please. Okay, that looks a bit more promising. We certainly wanted to get into left, right anterior here. We might just have got lucky. That is so tight. We're definitely going to need to do a dilatation here. So look, good example here of using those different wires. I know there's no confusion. We know that the green MedWork GPS wire is in the right anterior, and we know that the Boston Jaguar is in the left. We're going to go with a 6mm Titan dilating balloon. Yep. Screen. Nice, and let's inflate. Yep. Okay, so far so good. We've got wires in left, right anterior. We've dilated up the stricture. Now we're going to go for bilateral mesh metal stenting, and for this we're going to use the Cook Silver stents. There's a great advantage here, because if we were putting metal stents one after the other here, the significant risk would be that we would not get the second stent in because of the tightness of the hilar stricture. Now we can put both of these stents down the working channel at the same time because they have a 6 French delivery system. And so these are the Cook Silver stents. We're going to use 2 10 centimetre by 10 millimetre stents, and this puts lots of pressures on our wonderful nurses because they both need to be deploying the stents at the same time. So this is a long wire system. The stent does not foreshorten, and you also can't resheath it. A bit of tension. Right, beautifully across there. That's good. Right, now we are nicely across the stricture there. Stents in both sides. It'll start getting, that's good, that's good. Stop there. Wait a minute. Wait a minute. Yeah, stop. Let's keep deploying. Both of you keep deploying, and I'll tell you if I want you to stop. All the way. All the way, all the way, all the way. Okay. And so we've done what we always like to do, which is what we call shotgun. That you really should bring uncovered metal stents out into the duodenum, which means you have access in the future. And those stents have deployed beautifully, and I can take both delivery systems out. You can see what I mean about that pancreatic stent. That's never going to fall out if that's a non-biodegradable. Long, difficult procedure, but actually I think a fantastic result next. Thanks so much.
Okay, well, we mentioned shotguns there, and we're now going to turn this into a crime show. And I want our fantastic faculty to give me a crime in hilar stenting. Joshi.
I'll start off with, I think you have to stent both sides. Patients benefit from it. I think there's good data. So not just going for one side, unilateral stenting. We're talking about uncovered stents, obviously. So yeah, I think you've got to aim to do that.
And just to extend that point further, if you can get in one side, you're doing the ERCP, but you can't get in the other side, just go for it and hope the radiologist can help us out, or what should you then do?
So there are alternatives. You can go with an IR technique. Let's say you stent the right and the left is, you can't access it. You could do that, but that should be decided before. You can also do HGS potentially. But you need to think about that before. It might be that you just leave a plastic stent and then you come back again another day. So you don't have to commit either. So, but it's just good planning beforehand, I'd say.
Okay, crime number one, good. Crime number two, Bev?
Well, of course, you should not be putting uncovered metals if you have not proven malignancy, and also their operability status.
Yeah.
We've had a couple of cases now where, assumed hilar stricturing was thought to be from cancer, and they turned out to be IgG4. And we've had, a couple of patients who have intractable cholangitis and have actually gone on to receive transplants or required liver transplants for that indication.
Great,
yes.
great point.
Yeah.
So,
yeah. So crime two, never ever, and this doesn't just, of course, apply to hilar malignancy, does it? Or hilar strictures. Never insert an uncovered mesh metal biliary stent without absolute proven malignancy, not just what the radiologists think it looks like, absolute proven pathologically, and a surgical discussion as to whether there's a surgical option. That's two crimes. Reem, third crime of hilar stenting.
Be a little bit controversial. I think.
No, surely not.
No, but I think just to sort of reiterate the point about malignancy is actually getting a good occlusion cholangiogram to know where you're putting the uncovered stents. We've had cases where someone had put them in the cystic duct instead of the left and right system. But sort of throwing it back at everyone, we're seeing more and more survival with these patients, either metastatic colon cancer or cholangio or anything like that. And so these uncovered stents are becoming occluded. So we've sort of shifted back to plastic with these, or just putting them on the right side and a hepatocogastro on the left, and doing more RFA through them. They're just more likely to occlude, and then just trying to do plastics through them becomes harder and harder.
Yeah, and I think that, I suppose my crime would be assuming that plastic stents are a bad thing. Plastic stents across the liver hilum, you can always go back. You can always go back if they're not working well, if it's not right, if they're not in the right place. But if you know, there's an old nursery rhyme of, which is probably politically incorrect, when she was good, she was very, very good, and when she was bad, she was horrid. No, I probably, and it's live, we can't cut that.
We have a different one.
No, don't make it worse. But you know, I often say about stenting that, you know, uncovered metal stents across the liver high, and when they're good, they're very, very good.
Yeah.
But when they're bad, they're horrid. And if they're put in without a clear indication, absolute disaster, complete disaster. Okay, and any other tricks and tips that people would use here? We mentioned using 2 wires.
Yeah.
You know, here we were using the Cook Zilver stents, which have the particular advantage that they're a 6 French delivery system, and so you can put both delivery systems up at the same, both stents into position at the same time before deploying. Most of the other uncovered metal stents are usually sort of 8 French, and so you can't put them side by side.
Yeah.
Reem, do you have?
I like your trick with the wires, the different wires. We do that as well. We use the 2 Boston, I think they're the agile stents, but also go side by side. But we would have to either silicone spray them or lube them really well. And often a lot of force.
A lot of push.
Yes, to get them in.
And are they, the Zilver stent is a long wire system, and they can't be resheathed. So it's, you know, it's
one direction only, isn't it?
You know, you don't have the luxury, for example, of the conventional wall flex or the Cook Evolution stent of, you know, up to halfway you can resheath, start again. So that's something that certainly to be, you know, to be sort of conscious of. And yeah.
I mean, I think, you know, the 2 wires I really like, and I tend to do that as well. And I think if you've already got 2 plastics in, always do a car lock exchange to prevent yourself from getting lost. I think if you've already gone to the trouble of getting a left and right with plastics, just try and preserve your access to avoid delays and trying to selectively cannulate again. And
Reem, in you were saying that you quite favour plastic stents,
especially if they survive longer. But we do also, we haven't talked about it. I don't know if anyone uses as much as radiofrequency ablation to try and either through an uncovered or just to sort of, if you're just trying to get into a hard stricture, just.
I mean, the theory behind it is very attractive, isn't it? You know, you know, prior to stent deployment, you know, delivering RFA, will that maintain patency? I think the data doesn't completely, you know, isn't completely solid.
Yeah, retrospectively, everything, you can show whatever you want retrospectively, right?
Yeah.
So we've shown that it does. But I think in series that have come out of China, the survival rate was equivocal. I think it depends what the indication is and then how often you're doing them, because then it doesn't make sense if you're doing them the same way as Barrett's. Like, are you bringing them back every 3 months? Is it cost effective or not? Yeah. So we just do it every time you're changing out a stent, and if we're using plastic stents, then we do it more often.
And on the question of changing plastic stents, if the patient's doing well, and this applies to plastic stents, extrahepatic as much as Hylam, if the patient's doing well, do you schedule them to come back for a stent change, or do you wait for them to get cholangitis or get jaundice? Many of these patients will be, you know, going through chemotherapy. Do you just keep your fingers crossed and get them coming back early?
So I've done both, and sometimes certain patients where I've waited and then the oncologist would call me and say the liver tests are going up, that would be an indication to change them out. But sometimes I've waited too long and the strictures have become worse, and then it becomes a 2-hour ERCP instead of sort of 45
Do you
minutes.
normally use the Carlox sort of stent remover as well to cannulate first
exchange
through the stent? Or?
So We have a David Carlock. I don't use him a lot. So which one do you
Why he comes into the room and does it for you?
I was like, Carlock, come here.
That's impressive. We can't do that, unfortunately.
So we. Do you mean just leaving a wire?
Yeah,
yes. So that's sometimes I do that, and then you lose the wire, which then you swear a lot, and it's usually the fellow's fault because it's never really the attending's fault. But it's a lot of dilating and stenting, and then doing the same for the other side.
I guess another trick is if you don't have the luxury of having Zilvers, start with, you can load both metals up all at the same time on each wire, just so you save a bit of time with, getting the nurses to open the stent, etc. And then I would suggest always going with the more awkward angled one first, and then the second one will be the more straightforward, so that you have a bit more push. In theory, yes. Yeah.
Okay, great discussion. Going to the next case, 47-year-old woman, previous jaundice with right upper quadrant pain. She, in fact, when she presented with her jaundice, she had an EUS CDS because of very tight distal benign biliary obstruction. Interestingly, and we're seeing this increasingly, the conclusion was that this is likely to be a ketamine-induced cholangiopathy. And the plan for the procedure we're going to show was to do a rendezvous procedure through the CDS, something that Gavin alluded to earlier. We're using the Pentax deck duodenoscope, the Creo grasping forceps, Boston Dream Tome. As you'll see, we do use the Boston Spyglass, and we're tissue sampling here using the Steris Infinity cytology brush and the over-the-wire histoguide forceps, and then at the end place a Cook Evolution fully covered SEMS. So learning objectives, again, we get back to that issue of emerging approaches to biliary access. Few words about investigating biliary strictures and the management of extrahepatic biliary strictures.
Great. So this is a very unusual problem. Young patient with a benign, very tight low bile duct stricture that we believe is related to ketamine. We see increasing numbers of patients with ketamine-associated cholangiopathy. And although we've been able to get access to the lower bile duct at ERCP, it's been quite impossible to pass a wire through the low bile duct stricture. Previously, my colleague Gavin Johnson did a very nice therapeutic EUS and placed a lumen-opposing metal stent, hot axios, into the bile duct through the duodenal wall. That's drained her biliary tree, but it's not a great option, we don't think, long-term, and we would really like to return her biliary drainage to normal flow. And I think we can debate that. It's just been impossible previously, even when we've got a wire down being passed antigrade through the lambs, it's just not been possible to cross the stricture with the wire, and so we're wondering if we need to go with spyglass cholangioscopy here to achieve this. The problem here, of course, is we can see that although that lambs is in a beautiful position, the orientation is shockingly bad for us. I think we just go straight with spy. There we go. So there we are. When we go straight in, we're going completely the wrong direction. Beautiful view in there, so we can look up the bile duct. That's fine, except that it's absolutely not what we want. We want to be hooking right down with injecting. So we're putting contrast into the bile duct. You can see it coming down the bile duct and then it just tapering. In reality, we've not got a hope, I don't think, of hooking the spy down. We're right against the wall there. It ain't gonna happen. So we've had a go getting in through the lambs. Impossible to hook down with any purchase. I'm just going to have a go again at seeing if we can access endoscopically. Inject there, please. Yeah, screen. Keep injecting. Okay, there we are. That's where we need to go. Stop there. So that's quite interesting. So I think a little bit more bend, please. Screen. Nice. And inject there, please. Stop there. You can see what a weird, disordered, very odd stricture. So when we inject there, we fill the biliary tree and it comes out through the heart. So stop. So we know that we cannot be parabiliary. But I still just wonder whether it takes a strange turn here. There we are. So I'm in the biliary tree. That's super. I'm through the sphincter tone, but it's unbelievably tight, this. Oh, no, there we are. Screen, please. Okay, take that. You know, we've presumed that this is a ketamine-induced stricture, but we haven't actually sampled across it yet. So we're going to do brush cytology and endobiliary biopsies. Do you want to do this? So, I don't know if you can see it, but Charlotte here is going to be using the Infinity brush by Steris. It has 3 portions to the brush, thick, firmer bristles, like a toilet brush or a chimney sweeps brush at the proximal and distal end of the brush, and in the middle, softer bristles, the idea being that the stiffer component excoriates the stricture more, and the softer bristles in the middle capture the cells. That's the idea. Let's close it and let's pass that up. There we go. Very nice. Is that going through? Yeah, no, it's out there. Okay, slowly close there. Slowly close. You can see it's difficult getting that through. You can see the brush is actually quite nicely there. It shows that quite nicely. So close again. So it's an interesting point and worth discussion. We don't almost never pre-dilate, but for access here, we're going to need to. What we're going to do here, we're using the Cook short wire fusion Titan balloon, 4 centimeter by 4 millimeters. Got a very low profile, and I would hope to be able to advance this through the stricture if we can. Here we go. There we are. That's good. We're through there. Screen, please. Bit of contrast in. Yep. And now let's inflate to 12 atmospheres, and let's deflate. So we're going again in with the Infinity brush. That's better. And let's, that's it, and open the brush there. There we go. Open a bit more now as you can. Now you just come back a little bit. Yeah. Open more, a bit more. Good. Now nicely there, and now you can just wiggle a little bit backwards and forwards. Okay, so Charlotte here is using the HistoGuide endobiliary biopsy forceps from Steris. Passing biopsy forceps freehand up the bile duct carries a risk, and so the advantage of this system is that the biopsy forceps runs along the wire, but for the 6 millimeters or so at the very tip, which is the cup of the biopsy forceps. Now that most distal 6 millimeters, you know, can create just a little bit of a challenge sometimes passing through the sphincter. But overall, one has a much more reliable passage of the forceps. So close there, and let's just pass that up. Okay, so yeah, just gently passing up there. That's good. You've got past the lip nicely there. Screen, please. Getting better, getting much better. Sometimes dropping the bridge. I like that. Actually, I think you've done that very nicely. Just dropping the bridge and allowing the biopsy forceps just to bend in the duodenum can be quite helpful there. Can you open the biopsy forceps there? Yeah, well, we don't know whether you're open because it may be the orientation. Why don't you keep it open, come back a little bit. Yeah, I think it is open there. Yeah. It is open. Now push in again. Drop, yeah, that cup is definitely open. Yeah. And now push into the tissue and then close. Good. And then I hope you feel a little tug. You want to feel a little tug, and on the other hand, when you close the cup, if it jumps forward, you've almost always missed it. Okay, so that's good. So let's come out with that. And to be honest, I would expect these biopsies to show profound, bland fibrosis. So we've got lucky here with getting conventional biliary access. But there's absolutely no doubt that the hot Axios here, when this lady had severe jaundice and a completely impassable stricture, saved her having a percutaneous transhepatic drain. That would have been an external biliary drain, because they would have not, the radiologists would have probably done no better than us at getting anti-grade across the stricture, and then she'd have had all the issues of electrolyte disturbance, managing a biliary bag. So the LAMS here has been invaluable, but we're going to, in a few minutes, remove that, having got retrograde access with a stent that we hope will remodel this stricture, but I think we'll see this as a very tight stricture. So we're using here an 8 centimetre by 10 millimetre Cook Evolution fully covered mesh metal stent. We're choosing 8 centimetres because I want this deploying proximally above the LAMS. Now, clearly, we want to be sure that we are not deploying the proximal end above the liver hilum, but I think we're fine there. I would now, we haven't seen the distal end yet, but we know where it is. I would start deploying now, and that's a beautiful result. And we're just going to come back more proximally in the duodenum and remove that hot Axios. There we are, that's done its job, and it can now come out. Nice, perfect. Yeah, screen please. Just pull. Perfect. So, excellent result there. Combination of previous lovely therapeutic EUS by colleague Gavin Johnson and excellent ERCP by Charlotte today.
Okay, so a few issues there. Ketamine-induced cholangiopathy is something we've seen a few cases of now, and we obviously think of ketamine causing lots of bladder problems, but it certainly causes fibrotic disease elsewhere. Let's talk a bit about the assessment of extrahepatic biliary strictures in the absence of a mass. Joshie, the tradition was you did an ERCP, you waved a brush up the bile duct, and then the patient went to the multidisciplinary meeting and you took things from there. Is that approach good enough, or should we be pushing things further?
Well, I think the more sort of sampling techniques you use, the greater your yield in theory. So brushings, we do 5 passes at King's. I don't know what other people do. We'll try and take endobiliary biopsies, and if we're doing cholangioscopy, targeted biopsies as well, and try and give your histopathologist, cytopathologist as much tissue as possible, because sometimes your yield is not, great. So I think the more you apply, the better. There's advanced techniques, next generation sequencing they're doing on cytology as well. That's another option. I think that's mainly in trials, but the more the better, I would say.
Sorry.
No, I was going to say, so FISH and Oncomine testing.
So FISH is not available here in the UK, certainly at King's it's not, but our histopathologists are using next generation sequencing on cytopathology samples, which is very exciting.
Yeah.
And Reem, Joshie mentioned endobiliary biopsies, which we showed there. Does that, if you're going to do cholangioscopy, do you still do endobiliary biopsies? Do you do cholangioscopy at index ERCP in a case like that? What would your practice be?
Yes, because ultimately tissue is the sort of the key thing. So even if you see something that looks malignant on cholangiopathy, you still need the tissue to prove a point or to sort of go down the next steps. Sometimes I don't use like a cholangioscope initially, especially if the duct is small enough and I worry about the risk of pancreatitis. So I end up just doing brushing in that setting, waiting, a few months, and then if the diagnosis is still indeterminate, doing cholangiopathy in the second setting. I know that I've been, I'm maybe a bit more conservative in that approach. I know people ultimately do it first time.
Yeah, I think in our practice and at the Royal, I think we'd do the same, wouldn't we? That Actually, unless there's a particular reason to be concerned about doing cholangioscopy, we would. You've put me off now.
No one said anything.
We would.
We're too British. We're too British.
We would push things and look to do cholangioscopy at the index procedure. More discussion, but I think we're going on to the next case. 69-year-old man presenting with epigastric pain, worsened over some months with weight loss. CT scan shows a partially cystic lesion in the tail of pancreas, but with tissue encasing the celiac artery and occluding the splenic vein. We're using here the Pentax J10 EUS scope, and particularly showing here the Boston Acquire S fine needle biopsy needle. And again, we're going to discuss the relative indications and limitations of fine needle biopsy versus fine needle aspiration, whether the latter has a role. We'll be seeing some of the discussion, some of the anatomical landmarks, and a few little techniques and tricks and tips for EUS FNB.
Gentleman with epigastric pain with CT evidence of a semi-cystic, semi-solid lesion in the body of his pancreas. We're in the stomach at about 45 centimetres. We can note the splenic artery going past the kidney to the patient's left. And if we follow that, we see that this is tortuous here, and then encased by this lesion with a cystic component to it. So here we have the splenic artery, cystic component to the lesion. This is, we've previously measured it, it's a 45 by 45 millimeter lesion. And portal vein is out the back. So we just drop the frequency. Portal vein's down here, the confluence. So that's portal vein going back to liver. So it's SMV's clear, but the splenic vein is involved. And in terms of pancreatic duct, unusually upstream the pancreatic duct is not particularly dilated. Yeah, so there's the duct. And it just dilates up here in the lesion. So there's slight prominence of pancreatic duct, but unusually as you follow that to the patient's left, it is not particularly dilated, and then you get this sort of classic periductal hypoechoic halo around an obstructed pancreatic duct, which we're seeing through into the tail. There. So we're going to need to biopsy this. So we've got the new Acquire S needle from Boston, which the difference being, which may be of great value here because we're biopsying from the stomach, is that it has a sharpened stiletto tip, which when going through the stomach wall, which can be very elastic and very thick, occasionally with the previous legacy Acquire, one would find yourself having to pass the needle with quite a lot of force, whereas the Acquire S, the idea is that with a sharpened sheath and keeping the sheath in on the first pass, then it facilitates cutting. What we might aim to do is just take some of this fluid away with the first pass as well. So I'll probably target my first pass into that fluid. Just check our needle tract for vessels. And of course the advantage of the Acquire, which hasn't changed, is the nitinol nature to it, so it's less likely to bend when I'm bending the needle. Last check of Doppler signal. And quick throw of the needle. And that went in nice and easily. And then we're going to take the stiletto out, guys. So I'll get the some of this fluid out and then get a core on the way back. So again, the option of the stiletto, if it's going to be a straightforward puncture, usually the legacy Acquire has no problems. So you may choose just to go with a primed needle, so you have wet suction on approach if you're not somebody who's previously used a stiletto. But I think this is a useful option for when the first puncture does prove difficult. You can go with a stiletto in. This may already be blocked now because I've just probably got a little bit of tissue in it. We've got about 4 mils there, but clearly there's some left. So what I might do is reset that needle. So then we've got some untainted fluid for analysis. So that goes straight to cytology. Then I'll reset my suction, and on the way back, on the aspect of the lesion closest to the scope, I'll take a core biopsy and then maybe get rid of the rest of the fluid next time. So reset that to 5. So again, so now we have by definition, have a fluid column in the needle here already. So I'm just going to open that up, and then at this side, take some tissue cores. Okay, and lock that. And that can now flush straight into formalin, please. So it's whether this is quite viscous fluid. There's a little bit of extra echo density to it now, isn't it? Whether that's some blood that I've just deposited. I probably would cover this gentleman with a single dose of prophylactic antibiotics. I suspect we may not get any more fluid out of that now, given its new density. So we're now stilettless. Have you flushed with saline? So now I've got what we would call wet suction. So I've got a column of saline in my needle. There's the needle coming in. I'm going to line up with the cystic collection again. Final check on Doppler. And then this is without the stilet, just to see if it cuts. Right, that's a really interesting illustration. Because we are quite tangential at this angle needed to get to the cyst. And we're going through the stomach, which is elastic. Perfect demonstration of what the Acquire S may bring. So can we just take this down, because that's the same degree of force I used earlier on. You can just see that's just skimming across. So I'm going to keep my needle in, but we're going to pass the stilet once again. So unscrew there. So it's just the sort of case where you want the best cutability with your needle, because we're tangential in the stomach. Usually less of a problem in the duodenal bulb accessing pancreatic head of pancreas lesions, because you've got often a long or short scope position, but the duodenum is much more fixed, it's much more thin-walled, and there's often less ability for the tip of the echo endoscope to bounce away because you're in a tighter space. So we're just passing the stilet now. Obviously it needs to be right the way to the tip so that it's sharpened, so it needs to be screwed in so it doesn't move, which is that, so that's nice and tight. So now we've essentially sharpened the tip of the Acquire here. We'll get ready with suction, guys. And same degree of pressure. And that's gone straight in. Lovely. Okay, so now stilet out, please. So if you're having to use the stilet for each puncture, as I am here, it does mean that you're no longer able to do wet suction, which some people advocate without the stilet. So all I would say to that is that the head-to-heads between wet suction and slow pull stilet show that they're probably about the same. So I would suggest if you're having to use the stilet for each of these punctures, as I seem to be, then we might try some low stilet pull. And I would normally go with 3 passes as standard for an FNB needle. And then I would evaluate the adequacy of the sample. And if we've got some nice white cores, that's usually going to be proved to be diagnostic.
Do they do 24?
Yeah.
Okay, so very nice demonstration by Gavin. Reem, the development of the latest FNB needles, have they made FNA a redundant technique for making a pathological diagnosis?
I think so. We automatically always go for the core needles to get any kind of tissue, because really we're competing with IR and their percutaneous biopsies or their core needles, and often now our oncologists want a lot of core samples so that they can do further testing for oncomine testing or further genetic sequencing or next-gen sequencing, sorry. And we typically just use FNA needles for cysts. So for purely pancreatic cysts, that's when I would use that. And otherwise, it's a 22 core needle for generally most things apart from a liver biopsy.
Okay, and any needle choice related to position, for example, within the pancreas, lesions within the uncinate versus elsewhere. Either of you, Bev, do you make any judgment about your choice of needle around that, the anatomical site of the lesion?
Yeah, if you're in a D1, D2 view and you're going to go quite round a bend, then I think the sharp core does a quite good job of going around that bend. But apart from that, I don't really make too many changes in terms of my FNB needles.
Okay,
and also partly because I don't have that many choices.
Sure.
Yeah.
And
also a caveat when you were mentioning about FNAs. I mean, I think sometimes if you've got a very tiny lymph node, I still might use a 25 FNA with suction if it's a very, very small lesion or something like that. But in general, I think 20 sharp cores or FMB needles have taken over. But I think there's possibly still a very small role for FNA in acquiring tissue.
And if you get what you think are good samples, but the tissue's negative, do you go round the loop again? You know, many of these patients will come back into the MDM, and the extent to which metal stents affecting your tissue sampling. Do you remove that stent before sampling a small lesion, or do you keep it in place? What's your technique?
I think EUS has become so good. The processors are really good that you can see what you're doing much easier, but also the needles have become really good. And Gavin touched on a really good point of the technique that you use to acquire the tissue. So there has to be some form of suction, either if it's a hydrostatic pull technique or the suction, either wet or dry. I think those are key things, and you can actually see core tissue. So if you know you're in the right area and you see core tissue come out, then more than likely, I want to say 90%, you always get a diagnosis. It's very rare that a metal stent has been put in before an EU. And after the case, some of these needles are so sharp that you can go through them and you don't necessarily need to take them out. I think I've had to do it maybe twice in the last 5 years, but not very often.
I mean, sometimes they're helpful in that if the stent hasn't fully remodeled, you can know exactly where the pinch point is. But similarly, I mean, generally we don't remove the metal stents, but on patients who are coming back perhaps for the third time, that's when I take the metal stents out, do EUS again freshly without the stent, and then replace the stent after.
And we stopped using on-site pathology because I think it's just too expensive and it wastes a lot of time, because if you know you're in it, you see core, generally you have tissue.
Yeah, for us, the logistics around that are also challenging. Okay, so come to the end of the stricture session. I think great discussions around tissue sampling, approaches to stenting. We're going to take a very brief break now and then come back for all things stone disease. Thanks.
So this is going to be everybody's business because we're going to talk all things stones in the next hour or so. And we're going to just start with a case, if we may. So if we just run the first slides. So this is a 56-year-old with dilated ducts, cholestatic liver function tests. She's had an EUS referral with the question mark of bile duct stones, MRCP precluded due to claustrophobia, which is not an uncommon problem. And the aim of this case is to, again, the use of EUS on the table, whether one then proceeds with an ERCP and standard stone extraction. We're using the Pentax kit in terms of the J10 echo endoscope, the Pentax DEC duodenoscope, a Boston Dream Tome, the Irby and the Olympus balloon. Diagnostics, EUS, what's the utility of that in these cases, and standard biliary stone extraction technique.
We just had a chat with her in admissions and she's completely asymptomatic. So we wanted to do a quick check, and this is the fantastic utility of endoscopic ultrasound. We're using the Pentax J10 echo endoscope here with the Hitachi console. So I agree. So yeah, beautifully demonstrated. So there's a hyperechoic area in the middle here, and an acoustic shadow before. So we've answered the question here. So she's got a CBD stone. So it may not be that exciting whiz-bang endoscopy, but primary cannulation at ERCP, I think, is probably still the hardest thing. Still sets fear into the heart, both the trainee and the trainer. I think finding that risk balance between kind of exposing the patient to the risk of post-ERCP pancreatitis versus allowing a good training episode and the trainee a good chance to progress is always really tricky. But Sung-jae is very experienced, so we're very lucky to have him. And we're using the Boston Dream Tome with the 035 Jaguar here through the Pentax DEC duodenoscope. Sung-jae is trying to get a bit close to the ampulla, but the position is such that he's having to approach this from quite far away. Leading with a tiny bit of wire, as you can see, just to try and improve his accuracy. And maybe heading up towards the pancreatic duct. So you might want to try just repositioning there. So he's heading up towards the 11 o'clock position. Just trying to head superiorly into the top left of the Mercedes-Benz, and he's engaged with the papilla. So withdraws on his wire a little bit there and tries to watch the blue tip disappear. Screening, please. Do you want to try that? That looks good. Yeah, okay, brilliant. Fantastically demonstrated. So Sung-jae's done a great job there, and we're going to proceed to a sphincterotomy. So we are using the Irby Vio 200D machine set to sphincterotomy setting, so endocut 1, effect 2. Tricky position he was trying to get in. He's now finding the same difficulties when trying to do a sphincterotomy. So a bit of left wheel, I think. Okay, that's well done. Okay, and we're going here with the Olympus 3V balloon. And 3 different sizes. Got the 8.5, 11.5, and a 15.5 balloon. Sung-jae sized up the distal duct here, so the width of the scope is about 12, 13 millimeters. So if you look at that distal duct, that probably corresponds to about 11.5. So Sung-jae's going to demonstrate his stone removal here. So he's just locking the balloon with his left hand against the shaft of the scope. He's going to do big wheel down, push in, and torque right under screenings. So you can see as he does this, the angle of the travel of the balloon is directly down rather than pulling laterally against the side of the bile duct. Oh, there we go. Glad we did those extra trawls, hey? There's 2 of them. Perfect. So there you go. EUS for bile duct stone assessment, followed by ERCP, wire-guided sphincterotomy, and balloon trawl. Bread and butter ERCP, but lots of hurdles and lots of decisions to be made, and very well done by Sung-jae and team. Thank you.
Okay, thank you. Excellent case demonstration there. So we've just got a minute. We're going to do a more complex stone case shortly and talk about the technicalities of stone extraction. But John, what's the utility of EUS skills for an ERCPist?
So that's a loaded question, Gavin.
It is a loaded question. Anyone at the Stoke Symposium will know it's a loaded question.
Yeah. I mean, I think this particular case beautifully demonstrates the utility, doesn't it? but I think this is potentially a sort of a rather more limited indication where you haven't got MRCP. So I think in the absence of MRCP, absolutely, I think EUS is a no-brainer here, because we've heard there's no symptoms, we've got a dilated duct, we've got no idea what the pathology is. So I can see the point of this. I suppose the broader issue in terms of UK clinical practice is how do people dual accredit in EUS and get the skill set? Because actually I'm not so sure what we're actually having here is EUS. What we're having is ultrasound of the bile duct. So we've got to consider a number of things. How do we train our young colleagues to dual certify in EUS and ERCP, and is that actually achievable? We've got a workforce issue, as you know, with about a third of all UK ERCPs about to retire in the next 5 years. So I think we have to, in a sense, fit the clinical utility or the indication around what's reasonable and practical to achieve. So absence of MRCP, absolutely. I think this is almost a no-brainer. Whether it has to be at the same setting, you could argue that the patient could have a separate a procedure. If it's simply an ultrasound of the duct, then the patient can tolerate that, I would say. But that's not quite what I think an EUS is.
No, agreed. I think a learning point from this is to be very sure that there are stones before proceeding with an ERCP. So if you haven't got EUS skills and the MRCP is 3 months old, unless there's a huge stone burden, I think just take a moment, repeat the MRCP.
And the critical thing here for me is whether this patient actually has a gallbladder in situ. Because, if you've had someone who's had a definite episode of deranged LFTs, dilated duct, and there are stones in the gallbladder, you could argue that patient can go straight to surgery and have a bile duct exploration. But the widespread ability to, to actually get into the bile duct at, laparoscopic chole, or even getting patients laparoscopic chole these days, means that there's significant delays. So I think if the gallbladder is in and there's a risk of stones coming subsequently, you could argue that you in a dilated duct and an episode of cholangitis, that a prophylactic sphincterotomy would still be indicated. But in the cold light of day, if the patient not got symptoms, absolutely EUS here. Yeah.
And you make a very good point about access to cholecystectomy. I think it's a pan-UK problem of timely cholecystectomy after the index presentation of bile duct stones is certainly around London is an issue. I think it's an issue around.
Yeah, I mean we're seeing a lot of patients who we've done duct clearance at ERCP. They've got the gallbladder in. They're on the list, but the 2-week wait patients are just swamping everything at the moment,
and those patients are coming back. Yeah. Okay, next case. If we could run the slides. So a 66-year-old gentleman, this time significantly unwell with an ITU admission with acute pancreatitis, cholangitis and increasing inotrope requirements. This is the Friday afternoon phone call, no doubt. CT showing just a dilated bile duct only. And again, claustrophobia, lots of claustrophobics in North London, it would seem. So the equipment here is the DEC duodenoscope, the Dream Tome, the Boston CRE dilatation balloon, and the Olympus extraction balloon. Learning objectives of the role of sphincteroplasty in stone management, and critically, an important discussion on the timing of ERCP in critically ill patients with cholangitis. Run VT.
Okay, so here we are. This is a chap with cholangitis, primary patient with cholangitis, primary cannulation. Come down from ITU. With multi-organ failure, with evidence of biliary obstruction, likely related to stones. So Sunjay is doing all the right stuff, very gentle movements, leading with the wire. Okay, that's nice. Very nice, look at that. Beautifully done. Made it look very straightforward. Okay, we're using the Boston Autotome with a short 0.035 inch Jaguar. So it shows quite nicely the fact that the contrast falls to one wall. So you can see that the wire doesn't have any contrast next to it, but that's clearly at the top of the duct from a gravity point of view. and all the bile is, all the contrast is pooling at the lower side of the gut duct. So it's a slightly dilated biliary tree. You're going to be doing a sphincterotomy here anyway, aren't you? And it remains possible there's a stone at the lower end there. So are we all padded up? That's it slow. That's nice. Perfect. Don't come back any more than that. That's a perfect position. Yeah, stop there. Difficult to know exactly where the transverse fold is here, isn't it? I'm not convinced you can do too much more cutting here, but you can assess it. Yeah, this is quite interesting, isn't it? I think at the moment, just take that picture. I think there are stones. Screen, please. Can you mag up one, please? I think at the top of the common hepatic, those are stones, aren't they? Can you see them? Yeah. Quite faint, but I think that's where the mischief is. Definitely. And you can see that just a little hint is that just a little point is that we know air bubbles float, and we know from a gravity point of view that the left-hand side of the duct is the most dependent part of the duct. We saw that from where the contrast went, and that's also where those filling defects are. So these will for certain be stones. So I think now the question is, can we clear all of these just with balloon extraction, or do we need to do a little stretch? It's a bit tight with 8.5 there. Just go in a little bit there and then blow up again. And let's do another cholangiogram. I want to see how wide the distal duct is. Quite a few stones there. You know, personally, I here would you can very easily do a 10 to 12 millimeter CRE. In the management of bile duct stones, we talk a lot about cholangioscopy. Probably the biggest impact on stone management actually has been the introduction of safe balloon sphincteroplasty. So here we are, we're using the Boston 10 to 12 millimeter CRE RX, the RX because it's a short wire system. So I know we've said it before, but the rules are always do this through a prior sphincterotomy. So a little bit of wasting there. You can see how those stones might have just sat above that. Always be sure that there isn't a stone between the balloon and the bile duct wall. Never dilate to wider than the duct above the sphincter. Yeah, and suction, suction, suction. Suction, suction, suction. Yeah, I think suction, suction, suction. Good, here we come. Now see if we can get an endoscopic view now. All these stones coming out, I would suggest. That's good. Here we come. Here are the stones. And then do your nice maneuver. Secure with your left hand. And then push in and clockwise torque. Boom. Beautiful. There's a couple. And then you're beautifully coming down the line of the duct here. Because I think what people sometimes do is that they pull with the balloon and they pull with the scope, and then they come out sideways, and then you can traumatize the sphincter, and you know you want to keep the line of traction. So Sunjay is beautifully showing this here. Keep screening, and then a little bit of rotation, little bit. Oh, perfect. Absolutely perfect demonstration. There's a little stone still sitting there, isn't there? You want to just suction, 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 seeing if... That's where I think that doing a sphincteroplasty can help. Okay. That was perfect. I think we're in good shape there, aren't we? Yeah. So I would do a couple more balloon trawls at 11.5, I think. Yeah, the 11.5 balloon, I think. Lovely. I like that movement, Sunjay. Now, just to finish off, go back up. I want you just to demonstrate how I want you to convince me that there's no stone behind the scope. Okay. So just remind me what maneuver we do with that. Yeah, sure. So screen, please. So locks off, locks off. Yeah. And I would do anti-clockwise twist. So push in. Like this. Nice. Yeah, and save that picture there, please. Beautiful. So you've also demonstrated that because that's a classic place for stones to sit, often at the junction of the cystic duct. We're done. Okay. Stop screening. One more picture of the scope out the way. That's right. Just looking for any odd, weird gas patterns. Beautiful, isn't it? Yeah. So scope. Very nice. So beautifully executed, Sanjay. Straightforward case, but you know, very, very nicely done. Excellent.
So if there's any advert for the excitement of ERCP at seeing George Webster at his sort of seasoned stage of his career, still excited at the sort of the thought of the appearance of a gallstone after a balloon trawl, but with these critically ill patients, there's very few things as satisfying. So George talked us through sphincteroplasty and some do's and don'ts of sphincteroplasty. We don't need to reiterate that, but Bev, your approach to stone management, I think we've got some guidance or a slide that we can put up. What constitutes a difficult stone? When would you think about sphincteroplasty? When would you think about cholangioscopy and lithotripsy, direct lithotripsy?
I mean, in my internal algorithm, I guess, a difficult stone is when you've got a very big stone and a very small strictured distal CBD, probably from inflammatory reasons. And I think for those ones, cholangioscopy with VHL is probably the way to go these days. But I do think there's an unused need of the mechanical lithotripter, which is way more cost saving. And if your stricture is not that tight at the bottom, if you can crush a stone really well with a lithotripter, then
that single large stone.
Yes.
That's not so big it won't fit in the within the basket. Yeah. And
but you also have to remember that there are some caveats to that. In that, exactly as you were saying, Gavin, if you want to use the mechanical lithotripter well, then the duct has to be big enough for it to fully open up. The smallest one is probably a 4 by 3 centimeter. So if you can't actually open your mechanical basket up big enough, you'll never catch that stone. And there's also a rotating element to it. So some caveats to using mechanical lithotripter.
Okay. So good. I was going to make the exact point out as to whether any of you are still using the mechanical lithotripter, because I think it's seldom that it gets off the shelf. John, any comments? Balloons, baskets, lithotripters?
Yeah, I think that the mechanical lithotripter is it's a great device when it works well, but disasters we all know about, and I think it's familiarity with the kit. So I think in some ways, if you're going to continue using a mechanical lithotripter, it's good to get the kit out and familiarise yourself with it in a cold scenario. And I think it's one of those things that actually, if you've got a nice case, just to maintain skills within the whole team, because it's actually some nursing familiarity as well. And then just an awareness as to what you do if you get the stone stuck around the lithotripter and having the crushing device available and that kind of thing. So
I wouldn't say it's a dying art, but it's one that we're using less and less of. Okay, and John, this was a critically ill patient, intensive care. Any sort of take-home messages about the timing of ERCP here? Any comments or observations?
Aesthetic support essential. This has got to be done. You're really looking for a competent operator who can get this done fairly quickly. This patient needs to be in and out of the room safely. We don't want to make matters worse by getting a complication. I mean, I think it's interesting, because I think one of the other elements of a difficult extraction here is, well, this ampulla was on the side of the diverticulum, and balloon sphincteroplasty within the wall of the diverticulum. I'm also a little bit more nervous about, Gavin. We don't. We also, I think, we probably don't talk enough about stone shape, because when you look at a stone, you think, well, that one looks like it's going to be easy to remove because it's got a favourable shape. A nice elongated stone is much easier than an angulated and multifaceted stone. In terms of timing, you don't want to be doing these on a Friday afternoon if you can possibly avoid them, but often the patients seek it out. Got to make sure, as always, with everything endoscopic, the patient is well resuscitated. There's a clear team plan. The team are focused on, and that's communication with the anaesthetists. But ultimately, I think sometimes people unnecessarily delay. So we're not going to bring this patient to ERCP until we can get them stabilised. Well, the answer is they're not going to stabilise until you get that stone out. So I think it's timely, it's careful preparation. The team are focused, and we've got an operator who's competent.
And I think sometimes with these very sick patients, the focus and agenda is not on stone removal, it's on achieving drainage and cholangitis.
Absolutely.
If you know that, it's a large stone and there's a 50% chance it's not going to come out. Why bother trying to tackle it when actually they're just sick from being obstructed?
Adequate drainage.
Yes.
Okay. And there is actually a video of the mechanical lithotripter being put together on Gastro Learning Forum. I'm hearing in my ear. Okay, time for the next case, moving up in the scale of complexity. So this is a 64-year-old female, a bile duct resection in 1999 for choledochal cyst disease, which is a whole level of controversy we're not going to perhaps get into. Recurrent cholangitis due to intrahepatic stones above an anastomotic stricture. And the aim here is to clear the intrahepatic stones and optimize drainage via the anastomosis. Kit in operation you'll see is the Boston Spyglass Discover, so the transhepatic scope, a Terumo 11 French sheath, an Amplax 180 centimetre stiff wire, the Cook 10.2 French biliary drain, more the parameter of our interventional radiologists, the Q3 Medical balloon expandable biodegradable biliary stent, and the Olympus 3V extraction balloon that we've already seen today. So we're going to discuss the percutaneous biliary access in patients with altered anatomy, the role of percutaneous transhepatic cholangioscopy, and the role of biodegradable stents in this unusual group of patients.
This is a lady in her 60s who in 1999 had a bile duct resection for choledochal cyst disease and had a hepaticojejunostomy formed. And then over the years, on 2 or 3 occasions over the last 23 years, she has needed procedures to deal with stones forming above an anastomotic stricture. And in the past, we've really had not much choice but to do these as entirely radiological approaches. But more recently, we've had the opportunity to use the new Spyglass Discover 65 centimetre cholangioscope, which we're using here. So here we are looking up into within the biliary trees. Last time we did her procedure about a month ago, there was an enormous stone above the anastomotic stricture. And that stone has formed over the last decade because of impaired drainage through the hepaticojejunostomy. So one of the questions for this procedure is what our goals are. So here's a good conglomeration of stone here. So there's always a question whenever you're dealing with difficult bile duct stones, is yes, we need to fragment these stones with electrohydraulic lithotripsy, but what about getting the stones out? And that can be a real challenge doing anti-grade procedures because curiously, it is much easier pulling stones down the bile duct in the conventional way with an ERCP than it is trying to push them out. And the other question is, what about opening up the orifice to let the stones out, whether that be a balloon sphincteroplasty across the biliary sphincter, or in this case, dilating the anastomosis. The 2 lines of argument are, number one, if you dilate the opening early on, then stone fragments might fall out by doing so. The other argument, if you open up the anastomosis or the orifice before you do EHL, then because you need normal saline to be opposed between the EHL probe, if the orifice below this is too wide, then any normal saline I put in just disappears and we don't get proper apposition. There we are, that's good. Looks a bit small bowely there, doesn't it? Excellent. So we're nicely in the small bowel now. The anastomosis is here. If we're going to insert a stent across this, and then we're going to in fact put in a new type of biodegradable, expandable stent, which has the potential huge advantage that we don't need to go in and remove it as we would for our usual expandable stents, which are metal. We couldn't use that in this situation because we'd never be able to get it out again. Okay, good. Can you just blow up to 8.5 there? So that's where the anastomosis is, just sitting above that, do you see? Good, and then it goes through into the small bowel. So we've got that clear demarcation of where the small bowel is and where the anastomosis is. Down that up. So the Unity B stent is over the wire, across the stricture,
There are radio opaque markers proximally and distally, and we're now inflating the stent to 10 millimeters with an inflating balloon with contrast within it. That looks like a really nice result. Okay.
So here we are, nicely onto the top of the stent, and it's interesting. I've got that stone debris is running through now, and I think there's a good chance that will really improve the situation. There it goes down the stent. Okay, excellent. So that shows lovely drainage down the stent. We've cleared some further stones. We've got a 5.7 centimetre biodegradable Unity B stent, which we've inflated to 10 millimetres across that anastomosis. And we can see that we've got really nice runoff at the end. So here we are 6 weeks later, and on tubogram we can see dramatic improvement in the intraductal stones and still excellent runoff through this anastomosis. So this is a really good result.
Okay, a very nice demonstration of the SPY Discover and sort of antegrade EHL there. So John, we talked about aberrant anatomy earlier this afternoon. There are options in these patients. Percutaneous we've seen. In the context of a gastric bypass, we've got a lap-supported ERCP, and we've also got the EDGE procedure in those who've got a sort of affection for intervention in the US. Any comments? What would be your practice?
I think the honest answer is that this is the sphere of someone who's also is able to deliver not only ERCP but also the EDGE. So it's not something that I've taken on. I think you need to be multifaceted to be able to bring the expertise to the to the individual scenarios. I mean, this is very impressive, laparoscopic, obviously. Transhepatic. I'm really interested in the stent and the biodegradable nature of that, and whether that gives you the same. We were just talking off camera. Whether that gives you the same forces in terms of opening up this stricture, because the inevitability must be that these stones must be at high risk of coming back.
Yes.
And furthermore, whether a single dilatation of an anastomosis is delayed or the relapse of that restenosis delayed by this stent, I don't think we know. I don't think there's data on it. So John, we've shared care on a patients who've had a dramatic intrahepatic stone burden and have done really well with transhepatic SPY. Any sort of tips or tricks you'd pick up from that?
Yeah, I guess you really have to work well with your radiologists. Pick case selection, making sure you're picking patients who are going to be suitable to have a PTC, and then appropriate counselling of them beforehand so that they're aware they're going to sit with an internal external drain for a period. And then, as we were saying just before the session, that actually you can clear very large stone burdens, surprisingly, with this. And I think that's, as you say, down to the sort of the nature of flushing through an open hep edge. So if you can remodel or dilate up the stricture at the hep edge, then actually you can get good results. But I think we don't know what the long-term data are, and I think part of the consent has to be that these are at risk of reforming. If you're doing this for a second or a third time, should the patient be going down a surgical reconstruction route? So I think it's just having those sort of considerations and making sure the decision-making as part of an MDT, I think, is key.
Yeah. And then I think also talking in terms of altered surgical anatomy, I think if a patient has presented with, problematic CBD stones and still has their gallbladder in situ, then they should be really going down a surgical route with an open exploration rather than pursuing these sorts of techniques if the gallbladder is still in situ.
I might have this conversation with John off air. So since going live with EDGE here, we've done about 5 or 6. The number of referrals coming through has gone up, but very often this is a patient post bariatric gastric bypass surgery, and the first thing you notice either on the referral or on review of the imaging is they've got a gallbladder. And I made the point to John that is a surgical referral first and foremost. It's likely to be a one-stop laparoscopy, if not open, probably increased risk of being open if there is bile duct stones. But an EDGE procedure is always at least 2 endoscopies, even if you clear the duct in the first session of getting your lambs from gastric pouch to excluded stomach, and you fix that with stitch or a stent fix, which would be my practice, and go straight for the index ERCP there and then, which is what we've done. that patient still has to come back 6 weeks later and have the stent removed. On the best case scenario, it's a 6-week period.
Exactly, yeah.
And very complex consent conversations with regard to EDGE with patients, just to conceptualise what we're suggesting.
Yeah.
So again, another role for a sort of consent clinic at the very least, and very, very hard to explain on a telephone as well. You know, it's very anatomical, and one has to be sure. But we've done a number of EDGE, and it's been a fantastic intervention. But the ones we've done have not been the cold elective ones. They've been a bile leak or a very jaundiced Maritzi, which has been.
And are you going with a 20 by?
We'd use the 20 mil.
Yeah.
Yeah, absolutely. And then less chance of stent migration. I think if it's a genuine elective case and you're going for EDGE, I still think there's a role for just leaving it in place for 2 weeks, creating the anastomosis, letting it settle down, bringing them back. But then you're committing them to 3 procedures minimum. So there we go. I think we've got a minute or two left. Any comments, John, on the 2024 management of Maritzi syndrome in the era of cholangioscopy? Loaded question.
Wow.
Yeah.
Use a cholangiogram.
I hope there's not too many surgeons watching.
Yeah.
Yeah, well, I think we can now manage a lot of these patients. I think it's a consideration at it's review of the imaging before your ERCP, awareness as to whether you're going to be able to clear that up with conventional ERCP, and planning ahead, an awareness about the differential for a Maritzi as to whether it actually is a bile duct stricture, and then early use of cholangioscopy. And the MDT really is transformatory for these cases because it's all about planning and reviewing your cases before you go ahead.
Yeah, and I'll stick my neck out and say that I think Maritzi syndrome is now a endoscopic problem and not a surgical problem. So we've contributed data here to a European retrospective review, and what's come out of that data across Europe, big numbers, is that the nature of the biliary surgery is much downgraded. You're back to needing a lap chole, not an open cholecystectomy, not an open bile duct, far less likely to need a hepatocogeg as a complication of bile duct surgery. So I think that is beginning to emerge in terms of data. So any take-home messages of stone duct management, Bev, before we close the session?
I think a good sphincteroplasty is always a good idea. I think we've sort of gone away with the big surgical sort of sphincterotomy approach these days. And even when you do a big sphincterotomy, sometimes when you do a sphincteroplasty, you see that actually you've not actually, gone away with the sphincter. So yeah, good sphincteroplasty, stones, yeah.
And George made the point on the video, it's worth reiterating. I think stone management has been transformed with the era that we are confident to dilate up a previous sphincterotomy to the size of the distal bile duct, and it does transform the rates of duct clearance on the index ERCP. Okay, so I think that is a wrap for the stone session. So we're going to take a brief break, and we're going to have a quick reshuffle of the lineup on the sofa. And the final session of the afternoon to close out the HPB session is going to be pancreatic endotherapy, so don't go anywhere. Thanks very much. Welcome back. So we've got another 45 minutes of the HPB Symposium this afternoon. John stayed on the sofa. We've got George back with us and Reem as well. And we're going to go straight into a case, and the topic is going to be pancreatic endotherapy for this session. So let's run with the first case. So this is a percutaneous biliary access in, oh, that's the wrong slide. Can we go back to the case? That's the next case, thank you. So a 34-year-old gentleman with a history of chronic calcific pancreatitis. He's had an ERCP with spyglass pancreatoscopy and EHL with stone fragmentation in August 2022, which was effective for pain relief. However, he now has recurrence of his pancreatic type pain and weight loss. There's his latest MR. Next slide, we're going to, long list of kit, duodenoscope from Pentax, the Dream Tome, the Olympus balloon, the Fusion Titan 6mm dilatation balloon, the Boston Scientific Spyglass DS, the Boston Scientific Autolith EHL system, and finally a Boston Wallflex biliary stent fully covered. So what are the indications for endoscopic intervention in chronic pancreatitis? What favours endoscopic therapy for stone management? And what are the do's and don'ts of stenting in the context of pancreatic benign disease?
Good, here we are. So doing this next procedure with Charlotte, our Aussie fellow. And this chap is only 30, but got chronic calcific pancreatitis, which is painful and with obstructing stones. And so the aim here is for pancreatic endotherapy. So you're in somewhere, aren't you? And so the question is, are you just against a stone? You want to show us again what happens when you go with the wire? Screen, please. See if you can advance there. Bend your sphincter tome a little bit, just to see if a change in direction. Yeah. So where's that gone to? That's interesting. Good. Beautiful. Nice.
Now relax the tone.
So lovely. So that's flicked past nicely now. So let's inject now. Screen, please. Okay, so stop there. Stop injecting. And take that picture for us, please. So dilated duct, maybe some hold up at the lower end. I think I would do a balloon trawl just of that lower end. Lovely, but you've got a secure wire here. So just go in that little bit. There you go, you pop through there. Screen, please. Look, there definitely is a stone here. Now, question is this is very interesting. Question is what we do here. I would not try and pull that stone out because it's going to jam in. I would try and go below that stone, push it up, and then we go with a 6mm balloon sphincteroplasty. So just come back a little, blow up there, up to 8.5. Yeah, good. And just see if you can push that up. It's going to be tricky, but yeah, maybe you are. Good. Stop there and inject now. Take that. We can't see the stone there anymore, but there is a stricture there. So I think we now go with a 6mm. So we're using here the Cook Titan balloon, which is a short wire system. So now let's inflate. Okay, so screen, please. That's it. Bit of contrast coming into the balloon now. Okay, so hold it there. Okay, let's deflate there and then just see if you can advance a little bit further in. Now let's inflate again. Keep that little bit of forward pressure. That's fine. We keep that on for 30 seconds. One of the great frustrations of life is that removing pancreatic duct stones with a balloon is very frustrating. And that's because the stones, I think, nip into side branches. I think we leave the wire in, we come out with the balloon, we go in with spy. There we are. Nicely through. Good. I think advance through there a little bit. A few little bits of debris. What are we looking at there? That's it. Can you get? It's just all a bit narrowed there, isn't it? Is that a stone or is that just a bit of muck? See if we can go a little bit further. Can we screen, please? That's it. And go a little bit further. Do you mind if I have a little look? I think you've done nicely that. Well, a bit of stone there, isn't there? It's almost a bit of a cast, that, isn't it? And we see that in the pancreatic duct more than we do in the biliary tree. These proteinaceous stones just take the form of the duct. You can see how these stones just disappear into a side branch. Yeah. There we are. We're right out to the tail of the pancreas here. There's no other obstructing stones there, so I'm going to slowly come back. I think the dominant problem here is actually a stricture at the head rather than stones per se. You can see there, do you see it's very inflamed, isn't it? You can imagine it almost looks like a Shatsky ring there. I think that's where the problem is, and I think he would do well with a 6mm by 4cm mesh metal stent. See if we can remodel this. And let's slowly inject. Slowly. That's good. Stop. Okay, good. Keep injecting. And then this is where it all closes down and is yeah, take that picture. Got a bit of debris coming out. That's not bad. Take that picture. Thanks. But I think here we can make an argument for putting a stent in here. You know, it's narrowed down at the bottom. It's dilated further up. We've got out the stent, the stone debris that we'd fractured with EHL. Okay, so Charlotte's going to put in this stent. So the question is what stent we use here. We're going to use here 6mm by 4cm mesh metal biliary wall flex stent, just to see if we can remodel the lower duct here. Start deploying. That's it. Slowly. Screen as it tends to just not do much for a bit and then start going. Oh, that's good. It should suddenly get moving. Very nice. Very nice. Do you want to see where you are? You can just see the yellow marker there, so that's beautiful. So nice slow movements. That's great. Little bit at back. That's good. Very nice. Nearly there. You can just. That's good. You can let it ease in now. Beautiful. Perfect. And that's a beautiful result. And you can see there is that wasting, isn't there, through that stricture. Okay, well, very nice. Good result. And we can discuss the different approaches to managing painful chronic pancreatitis, but hopefully this helps him. I suppose just one final comment. We don't like to leave these pancreatic stents, and particularly metal stents in the pancreatic duct, for very long. I wouldn't leave this in for more than 6 weeks or so before removing it, and hopefully it will have remodeled the stricture by then. Thanks very much.
Okay, nice case. So, Dr. Webster, there's rich data from around Europe and elsewhere as to the benefits of extracorporeal shockwave lithotripsy. Surely a fantastic case to refer to the ESWL.
Yeah, no, it's a, it's fair comment, and it's part of the ESG guidelines. I have to say that over the years, practice has changed. We haven't historically had great success with ESWL. That may be the logistics around the service. Places like Hyderabad, Nagy Reddy's group, they've got, people whose work 5 days a week is entirely ESWL, and that builds up obviously an expertise that we don't have. We have to refer our patients into the urology stone MDM, and maybe there isn't quite the focus or the expertise. And I think technology is changing as well. I mean, Christian Gerges from Düsseldorf published just last year, promising data on spyglass pancreatoscopy, as shown here in managing intraductal pancreatic stones, and certainly that, with caveats around specifics around anatomy, that's our practice, and we may have an algorithm to show what we...
With a surprisingly good safety rate, which has been our experience here in about 25 or 30 endopancreatic lithotripsy.
Yeah, we
touch wood, we've not had a catastrophic acute pancreatitis, which shows you how forgiving a chronic pancreatitis gland is.
Yeah, all of these patients have got, a significant degree of exocrine insufficiency, and that's probably the reason why things are pretty safe. And I mean, this is our algorithm, and again, it's what we do, and this isn't an evidence-free zone, but there's so many caveats around the literature out there, and so
I think painful can be both for the patient and the endoscopist.
Yeah, but I think it's an important point that if patients do not have pain, whatever the anatomy is, we don't offer an intervention.
Yeah.
But if they do have pain, and if they're a very good surgical candidate, then we do offer surgery. I have to say, many of our patients, are quite keen to see if endoscopic therapy can help.
But so if you see a stone in someone with a dilated duct, you wouldn't intervene if they don't have pain?
No.
So isn't there a risk or a theoretical risk of worsening the pancreatic insufficiency?
But I think that's the point. It's theoretical. I don't think there's any. I don't think the evidence
in
is
America, we like to.
Really?
I'm joking.
Wow.
If
America,
you
the
see
great
a nail,
interventionists. You know.
If you see a nail, hit it with a hammer.
Yeah.
That would be our practice, probably in the UK, that if it's not painful, due to the inherent risk of intervening, if it's pure pancreatic insufficiency, for which there's a perfectly good prescription of, enzyme replacement therapy. So what are those endoscopic factors that lead towards likely success, George, in terms of that box?
Yeah, so a stone within the duct, and that's why it needs to go through the MDM, because quite often you've got pancreatic calcification. Actually, it is not within the main duct. So stone within the duct, upstream dilatation, and therefore good evidence that the stone is obstructing. I think we like for there to be ideally no more than 15 millimeters between the papilla and the stone, and no significant stricture between those 2 points. We tend to say a stone less than 10 millimeters. Certainly we've got some data that on CT scan, getting the radiologist to give us a so-called Hounsfield, giving us a measurement of the Hounsfield units, and that if the Hounsfield is greater than, which is an indication of density, if the Hounsfield is greater than 1,000 or certainly greater than 1,500, then fragmentation of the stone, even with direct EHL, can be particularly challenging.
Okay, we've got to go to the next case, but very briefly, Reem, we saw the stricture in the pancreatic duct here being remodeled, the use of a fully covered metal stent. Any thoughts or just closing comments on that before we move on to acute pancreatitis?
So in the States, we don't have the 6 millimeter fully covered stents, and that's the ideal stent to use. Obviously, you want to think about how long you leave them in. We were hearing that your experience here would be just maybe 6 weeks to maximum of 3 months, because you can get the stent can become embedded in that area. In the States, if you use an 8 millimeter stent, you should do a biliary sphincterotomy at the same time, because otherwise you could get cholangitis. And otherwise, it's multiple plastics.
We had a young chap quite sick with a pancreatic metal stent who got cholangitis, so a point well made. Okay, now for something completely different, the realm of acute pancreatitis. So this will be a problem common to most of us. So admitted to the local hospital, a 46-year-old female with acute pancreatitis, past medical history as seen there, including portal vein thrombosis, ongoing sepsis despite percutaneous drainage, and CT evidence of a collection opposed to the stomach, separate to the collection that had been drained percutaneously. We are using the new Fujifilm EOS EG580 scope. We're using a 15 millimeter hot Axios lumen opposing stent from Boston Scientific, an 035 Boston Jaguar, and a Cook double pigtail stent. The learning objectives is the timing and anatomical approach in management of walled-off necrosis in severe pancreatitis, and then the decision with regard to lambs versus pigtails for drainage of necrotic collections. Thank you.
Okay, so again, we're just having another look here, trying to find a wall. It's not the clearest of cysts in terms of access, and we just want to be happy that we're not inserting the stent into the colon. So actually what we're deciding on, we're going to go with a 19 gauge needle here, and we're going to inject some contrast down the needle and just check on fluoro and check that that fills the retroperitoneal space rather than something intraluminal that would look more like the colon. And so contrast going in, you can see it filling that space, and actually on the fluoroscopy I can see nicely that it's filling the retroperitoneum and not filling the colon. So we can be more confident to go with the hot Axios. And actually there's a very short saddle length there. I'm just going to put a wire down so that we've got our position confirmed, and actually that means that we can with more confidence go with the hot Axios over the wire directly into the space that we have already identified with contrast. So screening, please. Yeah, okay, great. So I can see that wire's in a good position. Lots of wire in, and because we're going over the wire, it's not going to affect the diathermy as we go through with the hot axios. So if you've got the wire slightly shorter and your tip of the needle comes into contact, that can affect the diathermy. But if we've got plenty of wire in and going over the wire, that won't affect our diathermy. Okay, great. So we're just going down with the Boston Scientific 20mm by 10 lumen opposing metal stent, and all connected and yep, through. Okay, great. So I'm just going to continue with step 1, advance needle as far as I think is safe, and then lock, and remove my diathermy, thanks Gav, and then I'm just going to pass a bit more wire in, make sure there's plenty in there for our exchange, and then I'm going to unlock step 2, I'm going to deploy the distal flange of the stent, and you'll see that coming into view on EUS now. And there you go, you can see that expanding nicely. And then we're just going to bring that, try and get a better view, bring that back into the channel. We want to see that as well described going from our rugby ball to our football, so we know we're getting that apposition with the walled off necrosis, and that looks good to me. Okay, now we're going to push out step 1 and looking away, talking right, just to deploy the stent. And with this Fuji scope here, you get a really nice view of the stent, and you can see that well deployed because you've got a nice wide-angle forward-viewing lens.
Okay, nice demonstration there. So we're just chatting off air. These drainages are very easy when you've got a nice big anechoic collection, pseudocyst or sort of 50% liquid, nice big anechoic target. That wasn't the case here. So what makes these challenging? Because Ree made the point off air there that actually a gallbladder can be easier than a pancreatic necrotic collection sometimes in terms of LAMS placement. So John, what made this difficult?
Yeah, I mean, I think there you've got full house complexity. You've got very heterogeneous collection, lots of solid components. You've probably got gas within it if you've got gas-forming organisms. Often the patients are quite sick if you've got distended small bowel in a patient with ileus, or so all of those factors come into play. I think what Taz demonstrated there is sort of ideal technique, isn't it, of putting a needle in, getting samples back. You can send it to a culture, you put your wire in, you confirm under fluoro with some contrast, you're not in another luminal structure like bowel, and then you're in a safe position to deploy.
Yeah, and I think the more interventional EUS I do, the more I lean towards delivery of contrast if the anatomy is not quite there, or obviously the use of instilling with saline to make your target a little bit bigger very occasionally can be useful in walled off necrotic collections. So Reem, we all thought LAMS were it when it comes to necrotic collections because they're bigger, they're 20 mil or 15 mil, the solid stuff's going to drain through. Is that the case? Should we be using pigtails and saving a few pounds and pence, or
depends where you are
dollars
in
and
the
cents?
world. I think it went from plastic better to metal, and now sort of shifting to sort of saying there's no real difference. I think it depends. If you're going to end up doing a lot of necrosectomies, you know that there is a large collection. It extends into the paracolic gutter. You're going to be doing a lot of endotherapy and multiple sessions. It makes sense to put in a metal stent. And so that's usually our go-to. And in actual fact, it is easier to do. It's easier to train people on. And it takes less time.
Yeah, and I think that's right. And as we've been saying in terms of interventions, once you've got your handle of how the deployment works with the LAMS, in particular the hot axios, and you've done a few cases, it is straightforward. And these patients, as John mentions, are grossly sick and often need something doing. Okay, and I think we're going to come to a clip or a case of a necrosectomy, but what would be your comments on the timing of a necrosectomy? In fact, why don't we do the case first, and I'll come back to you on that. So let's run with the next case. So it's a 45-year-old gentleman with severe gallstone-related acute pancreatitis. He has severe sepsis, ARDS, tracheostomy, critical care neuromyopathy, so the real sort of heart sink, long stay patients that we're seeing. There's already been the prior placement of a 20mm hot axios into a large walled-off necrotic collection, and he is now planned for an endoscopic necrosectomy. Kit in use is the Pentax therapeutic gastroscope, the Interscope Endorotor 3.2mm through the scope debridement catheter, the Boston Scientific Captivator single-use snare, and the Cook Solus 10 French double pigtail stent. And we're going to talk about endoscopic approaches to necrosectomy and the use of double pigtail stents within the lambs. Let's run with the video.
You're back with us. This poor chap who's about 50, had a really, really nasty episode of gallstone pancreatitis about 4 months ago now. A horrible pancreatic necrosis. You can see he's got significant esophageal candidiasis as we go down, and the thing that turned the corner for his care was having an EUS guided hot axios lumen opposing metal stent into his collection. But he's still got a lot of necrosis, and so our job is to try and clear that. And our discussion is how best to do that. Using here the Pentax therapeutic gastroscope, the EG34, 3.8mm working channel. But actually the quite interesting thing straight off is that we can see that we can get into the stent. When we first did a necrosectomy a week or two ago now, the whole of the lambs was completely clogged up. Question is, what techniques do we use to clear pancreatic necrosis? And what we're using today is the Endorotor from Interscope. There are 2 Endorotor catheters that one can use. There is the through the scope system, which we're going to use today, which uses an approximate 10 French catheter. And so I think there's a lot of interest in the Endorotor, which uses a rotating barrel and a suction system, basically to cut and hoover the necrotic tissue out. You'll see that in just a minute. And I'm coming out with the Endorotor, so 9 French catheter, and you can see that I can rotate this around, which basically protects whatever is underneath. So there's essentially no risk of me, or almost no risk of me grabbing or getting stuck on the mesh of the lambs. At least that's what we would hope. And what I'm hoping to do is to just come up onto this, onto the necrotic tissue here, and you can see that it's so the barrel is rotating between 1300 and 1700 a minute, revs per minute. You can see we're just dragging the fluid in there. And I have to say that it's a very controlled technique. Okay, we're just going with the 20mm diameter captivator snare. Okay, are you open? Fully open? Nice. So again, just see we can loop over the top of that. Close. Yeah? I've cleared the lumen. Ah, it's beautiful, isn't it? That is absolutely beautiful. I definitely think now we go with a bit more Endorotor. And I think that this is where the ability to have direct vision now makes all the difference. Because direct vision and being able to select the areas that we really need to treat. So for example, we do not want to treat this beautifully granulating tissue here, but there's still a bit of necrotic stuff here, which I'd be quite keen on seeing what we might do something about. Okay, there we are. You can see we're nicely through the collection now, through the lambs. Just moving back and forth through that. I have to say, it feels, you need to set time aside for it. There's no doubt about it. This is not a 10-minute job, but it feels very controlled. I just get the feeling that I can see where I am. I've got the barrel at 6 o'clock now, but that I can see what I'm going down onto. I think this is very nice, actually. I think we are pretty much at the point where we can put a pigtail stent through this and then feel that we've done a good job. Just to finish off, we're going to put in just a pigtail stent, because we know that that 20 millimeter hot Axios does a great job until it gets completely blocked up. So a discussion point. We've had a few patients, particularly those who've had a 20 millimeter diameter hot Axios inserted, in whom we've put a 7 French pigtail stent through, and the stent has migrated. And actually it seems to particularly have migrated into the cyst, which is clearly not a very good scenario. And so we've started using these 10 French double pigtail stents from Cook called the Solace stent. Now, the important thing about this, it has a much bigger pigtail. And there, the actual pigtail itself is wider than 20 millimeters. So this should make it very much less likely that you might get either inward or outward migration of the stent from within the 20 millimeter hot Axios. So that's what we're going to use here. We're just going to load it onto the system. Thanks. Nice, and there's the delivery catheter. Can we screen, please? Now I'm going to just walk away here with my scope. Delivery catheter is there. It's absolutely fine. So I'm just coming out of the hot Axios with my scope. Yeah, that's good. And there's the stent. So that's the internal marker there. Okay, you can come back with your delivery catheter now. Bit more, bit more, bit more. Let that pigtail. Beautiful. Stop there. Lovely jubbly. Okay, and now all I'm worried about really is the bottom end now. Okay, screen please. That's good. I'm just going to come out here. Okay, stop there. Stop there, stop there. Everything out. Pull everything out. Pull, pull. Nice. Okay, and now we've got that nice Solace 5 centimeter, 10 French pigtail stent. A nice position there. That's not, you can see there's, I would suggest, no chance of that disappearing into the hot Axios. And we're all done. And from when we started, there was a horrible load of necrosis just blocking the whole of that stent, and that's much, much better. So I think we're really winning with this poor chap with his nasty necrotizing pancreatitis. So we're all done. Thank you very much.
Okay, thanks very much. So since the sort of advent of LAMS in the management of walled-off necrotic collections, we've gone with the notion that not all patients will need a necrosectomy. Numbers vary depending on your practice, etc. So we've gone for the step-up approach, whereby if the patient doesn't settle or they fail to thrive, as in this example, we then go with a scheduled direct endoscopic necrosectomy. But is that the right way, Reem, or should we be more aggressive earlier on?
So funny you should say that. So retrospectively, it seemed to make sense exactly what you said. So you wait. About a third of the patients probably don't need another necrosectomy or another endotherapy type session. But in a recent randomized trial by GBang and the Florida group, it was a multi-center randomized trial, international with centers from India and the US. But small, so they had 33 in each site, and they compared doing an upfront necrosectomy to just bringing them back at scheduled times. And they favored, the conclusion favored doing an upfront necrosectomy. Very small difference in numbers, sort of the mean difference was either doing 1 session versus 2 or 3. And there was no difference in mortality and other outcomes. So it sort of gives us pause, and maybe that you should be upfront aggressive in these patients.
And George, we saw you demonstrate the endorotor. Do you think we finally got something in the toolbox that, above and beyond polyp kit, which frankly they're not polyps, that kind of helps further the success we're having with nephrectomy in terms of time effectiveness and not being there for 5 hours with a snare?
Yeah, I think historically we've, as you say, we've just got some things out of the colonoscopy room and we've put a snare down, we've put a Rothnet down. I think one of the concerns about snaring is that you can get big lumps of tissue, but you don't know what's happening the other side. And I have to say, when we first sort of heard about the concept of endorotor, I think we were all a little bit nervous. This idea that you've got a rapidly rotating motor cutting through the tissue, but actually, because everything's under direct vision, because the rotor itself is protected, and you can rotate such that you're against the necrotic tissue. When we've used it, I think we've both found that it feels a very controlled procedure. And the point you made offline, that what we often see is actually going with the endorotor seems to then improve the overall plane to then go with a snare. So I don't think the endorotor replaces other techniques entirely, but I think it definitely complements, what we've otherwise been doing.
And it needs negative pressure. That's the whole point. So if you can't draw a tissue onto the endorotor, it won't cut. Yeah. Technically, it shouldn't cut into things that it shouldn't. But creating that groove within the necrotic material to get a snare round. And I know that they also are making an over-the-scope device, which I don't have any experience of. But any comments on that? Because that is thought to be very promising. So you've got much bigger jaws of your
and I mean the through the scope is a 3.2 millimeter endorotor. There is an over the scope 6 millimeter endorotor catheter. That for obvious reasons is rather more cumbersome. One needs a rather more favourable route through the lambs. You really need to be doing it with the 20 millimeter lambs, and it will be particularly challenging if you're having to hook up through the lambs. So, but again, the likelihood is that the wider, the bigger the chamber, the stronger the suction, and the more likely one is to be able to perform necrosectomy. But I think the technology is definitely shifting the dial in terms of how we manage these patients.
And Ovesco has a device, I think it's the excavator, where it's a little bit like Pac-Man, also sort of grabbing necrotic.
And an observation I've come to the conclusion of is if the lambs has been in there long enough, taking it out and then proceeding with a necrosectomy gives you a manoeuvrability a lot more. You can pull bigger chunks through, and that can be quite forgiving. And any closing thoughts, John, before we wrap up the session?
No, I think we spoke earlier on a bit about the logistics of these cases, because they are time-consuming. These are sick patients. I think our practice at the Royal Free and our learning from the cases that we've done is actually we're trying to be more aggressive and schedule them in, allow them sufficient time, because they take several hours even with the newer techniques. But I think you've got to, particularly when you've got a sick patient with walled-off necrosis, you've got to try and make progress, and they need multiple sessions. And it's often we do them on the ICU, try and take out the logistics of moving infected patients around the hospital. But yeah, it's sort of planning really, and making sure that you keep going, because
you really don't need fluoro either. Actually, even for the pigtail at the end, you rarely need fluoro.
I agree with that. Yeah,
but it's having enough time to get the job done properly, and it's such a burden on the rest of your service, because if done properly, these are tubed. They always need to be intubated due to the horrible stuff that comes up. A proper 2 or 3 hour session, and then the hot ERCPs on the walls aren't getting done that day. So it's a challenge. Okay, thank you to the panel. So that brings us to the end of London Live Endoscopy Day 1 2024. Thanks for joining us. We've had 1,600 people online today from all over the place, I am assured, which is fantastic. please join us tomorrow. We've got a whole morning of lower GI endoscopy to look forward to, and an afternoon dubbed Innovations, but it's a bit of a mixed bag. We've got GI bleeding, we've got lots more about novel EUS and interventions, so please join us tomorrow, and please remember to fill out your feedback forms. And we're going to take a well-earned rest, and we'll join you all tomorrow. Thanks for joining us. Cheers.